السلام عليكم. Shall we start? السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم، والصلاة والسلام على سيد الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Good morning everybody, and we would like to welcome you all to SIMEC 2022 under the umbrella of King Khalid University and the Saudi Medical Education. I am Abdullah Asiri. I'm a professor of cardiology, King Khalid University. I was a former dean of College of Medicine, King Khalid University. And I'm honored to share this session with my co-chairman, Dr. Muna Sheikh, who's an associate professor in Al-Imam Abdurrahman bin Faisal University, and she's a known Saudi figure in medical education. The first session today is going to talk about assessment and the feedback. And to tackle this topic, we are having 3 international speakers, and they are figures in medical education. It's going to be through the website, so through the online sessions. And I would like to remind all speakers to stick to the time allocated, and we will leave the discussion to the end of the presentations at the panel discussion. I will ask my colleague, Dr. Muna, to present the first presenter.
Assalamu alaikum wa rahmatullah. Welcome all to the first session of the Saudi International Medical Education Conference 2022. This conference is unique because it coincides with the 20th anniversary of the Saudi Society of Medical Education. And it's also unique because it's the first medical education conference after the COVID-19 pandemic. So we hope that in the next sessions you'll be hearing about the crisis management during the pandemic, the stable management, and the new normal. So please stay tuned and enjoy the sessions. Our first speaker is a pronounced eminent speaker, Lambert Schwerth. He has obtained his PhD degree from Maastricht University, and he has been a leader in student assessment. He has been pioneering the work and innovating in student assessment. He has been the chair of the task force on assessment since 2000, and he has been an advisor of assessment to all medical colleges in many medical colleges in the Netherlands and UK, and he's been chairing the International Consensus Group on Educational Research, the results of which were published in the Journal of Medical Teacher. Since 2007, Lambert has been a full professor for innovative assessment at Maastricht University. Currently, he is holding a professor position for medical education at Flinders University in Adelaide, Australia. Please listen to Lambert and please put questions, because we're going to have a question and answer session after the speakers finish. Thank you.
Thank you very much, kind hosts, and good morning to all of you. I want to thank you for allowing me to speak at your conference. And I think it's one of the wonders of technology that I'm speaking to you and presenting my slides without having to do any travel. The only problem communication technology hasn't been able to solve yet are time zone differences. So it's morning where you are and it's evening where I am. But I'm very pleased that I'll be able to speak to you about a topic that has always been the center of my interest, namely assessment. And today I want to focus on programmatic assessment in combination with what's known as assessment for learning. So I've given the presentation the somewhat misleading subtitle, Tips for Application. And now you may think that this is a presentation that will be about a sort of 12 tips for the application of programmatic assessment, or a straightforward roadmap to application of programmatic assessment or assessment for learning, but that's not the case. And I feel that I need to explain to you why that is. Because an important consideration is that education and assessment are actually quite complex phenomena. And they are always the result of interaction between numerous factors, and most notably, of course, the interactions between learners and their teachers. And it's not to say that complex phenomena are always difficult, but they are certainly not straightforward or entirely predictable. And that has consequences for how we see the nature of evidence in medical education, because evidence in medical education is different to, for example, evidence in clinical research. In clinical research, we assume that the outcomes are valid regardless of whether they were found or where they were found and where they are being applied. So if a therapeutic intervention, a drug, works in London, it's safe to assume that it will also work in Tokyo, New York, Vancouver, Adelaide, and of course in Riyadh. But in medical education, there's an interplay between different sorts of evidence. Examples are findings about limitations, or there is generic evidence that's always true, wherever you find it. So an example is findings about the limitations of the short-term memory and its relationship with information in the long-term memory and how that applies to learning. But there is also context-specific evidence, things that are true, but dependent on national or local culture or context, typically values and beliefs, but also the way education is financed, the expectations of society, and many more. These are important to consider because what may work in one society or given that society's culture may not at all work in an entirely different society. So that means that the effectiveness of educational approaches needs to be understood so it can be adapted to the local circumstances. And this is not entirely different to clinical practice because despite evidence-based guidelines, a good understanding of the patient's pathophysiology will allow you as a doctor to slightly deviate from the guidelines and personalize your approach to each patient. And then finally, there is the impact of your organizational context, your staff, the level of educational literacy of your staff, the strategic plan of your organization, the leadership, etc. And all these three sources of evidence have to be taken into account when trying to apply an assessment approach such as programmatic assessment. So you could almost say that trying to apply programmatic assessment at your own organization in exactly the same way it has been applied somewhere else is more likely to fail than to be successful. So the logical question then is, to which problem is programmatic assessment assessment for learning a solution? Because the last thing I would like to see is that people embrace a solution simply because it looks good or because it's popular or because it's a hype. Because what you need to do is a clear analysis of the existing problems and whether your solution is a good solution to the problem. So here are 6 of what I think central problems with the way we currently assess our students. And the first one is that we assume that the traits or the constructs, the things that we try to assess with our assessment are stable and generic. So if we assume that somebody, we measure an aspect of somebody's competence with a test, we assume that we can very clearly distinguish between those who are highly competent and those who are not. So if this is one of these tests with 4 items, 1, 2, 3, 4, and 5 students, A to E, this test tells what this test tells us is that student A is highly competent and student E is highly incompetent. But what you see here is that student A performs well across all 4 items and student E performs poorly across all 4 items. And that's why student A has achieved a score of 4 and student E only achieves a score of 0.8. So now, if we now assume that if we had a so-called parallel test, a test of equal difficulty on the same topic, but with a slightly different question, like this one, we would assume that we actually would find again student A to be the top scoring student and student E to be the bottom performer, and that the rank ordering from A to E would be the same on both. That's basically the fundamental to test-retest correlation, Cronberg's alpha, and what have you. So in an ideal situation, when we're looking from a criterion validity or a criterion perspective, In an ideal situation, we could even expect that student A would again obtain a score of 4 and student A would again obtain a score of 0.8. But unfortunately, practice is quite different. It's a different picture. There's a lot of interaction. There's a lot of scatter in how students perform. And in this matrix, student A may be the top performer when it comes to item 1, but he's absolutely not the top performer when it comes to item 3. He's almost a bottom performer. Whereas for student C, the picture is quite different. They are the top performer with respect to item 3, but a bottom performer on item 2. And on the parallel test, you would find, again, a lot of interaction and a lot of scatter, but it's an entirely different scatter. So let's assume that item 1 is on cardiology and item 3 is on respirology. And then assume that there are 2 students, Jenny and Tom. Jenny does well on cardiology, but not so well on pulmonology. And Tom does well on pulmonology, but not so well on cardiology. From an educational point of view, it is more interesting to understand why Jenny didn't do so well on respirology and why Tom didn't do so well on cardiology. Actually saying that from an educational point of view, that differential interaction is much more important than just saying you can compensate performance on one domain with competence on another domain. But in our standard psychometric approaches, the classical test theory, but even generalizability theory, the interaction between cardiology and respirology and Jenny and Tom is generally part of the error component. We say it's error variance, and it's not the signal or the true score variance of our measurement. The other assumption is that they are generic or independent. We typically assume that the format of the assessment determines what the assessment actually measures. When you ask somebody about their assessment, the typical reply is in the format of, we use multiple choice. And of course, considerable amounts of research have been performed, especially in the 1980s and 1990s, where they compare different assessment formats. And the most popular types of studies were, of course, comparing open-ended and multiple choice questions. And these studies were typically done either in a multi-trait, multi-method, or in crossover designs as depicted here. And in crossover designs, one part of the assessment was administered in multiple choice format to one group of students, and the second part was an open-ended format. And for the other group of students, the first part was open-ended and the second part was multiple choice. And that way you could make an analysis of the impact of question format and question content. And invariably, the results showed that competence did not generalize very well across content. So that's assumed by the diagonal arrows, because where the format was the same, they were both multiple choice, but different content. And the green vertical arrows show that where the content was the same, but the format was different, correlations were extremely high. That's counterintuitive, but it's a very robust finding. And the most plausible conclusion is that the traits are neither stable nor generic. And it's a basic assumption about underlying our testing. So in order for traits to be stable and generic, we also have to treat individual items as meaningless because we're looking at a trait. We're not looking at the item. We're not looking at cardiology versus pulmonology. We're looking at overall traits. So items are only there to contribute to the total test score, but they're not seen as meaningful in themselves. So let's say this is multiple choice item 1, and here is multiple choice item 2. And let's assume that one student answers item 1 correctly, but item 2 incorrectly, and another student items 1 incorrectly, but item 2 correctly. So they would both obtain a score of 0.5, but on different knowledge. And you could argue that in the multiple choice test, oh, this is acceptable. After all, the amount of information from each item is fairly limited. But how about in an OSCE? How about a student that performs very poorly on a resuscitation station, but very well on a communication station. Is it logical to assume that on average they both deserve a score of 50%? Or if there is another student who performs very well on the resuscitation station, but very poorly on a communication station, and thus also receives a score of 50%, is it fair that both students simply obtain the same score without any further educational consequences? Well, in my opinion, it's not. It's not defensible because it doesn't make sense. It doesn't make sense to say you can compensate for poor resuscitation skills with good communication, but it's a consequence of our traditional model of assessment. As a consequence of treating individual items as meaningless and using them only to contribute to total score, that total score seems to be what determines validity, particularly the assessment construct's validity. But when we determine validity, we look only at the behavior of total scores and whether that behavior is in accordance to what we expect. For example, do experts outperform non-experts on the test? Or in other words, whether their total scores are higher than those of non-experts. But if we consider total scores, and these total scores are the results of a combination of individual item scores or blueprint category scores, we actually have to be quite careful to ensure that we're combining components that make sense together. Like I said, competence doesn't generalize well across contents. And if everything is translated to a number and simply arithmetically or mathematically combined, there's always the risk that we add apples and oranges as depicted in this joke. So it is mathematically easy to simply add up population, the number of feet above sea level, and the date of establishment, and arrive at the number of 4663. But it's obvious that these are individual components which are meaningful in themselves and should not be combined. So logically then, when we apply statistics, they have to be based on elimination of information. If you try to express competence on a single scale and treat all the individual items as meaningless, information has to be reduced and thrown away. So here's an example. These are the responses of a student to 3 questions. And at this point, you know exactly which correct and incorrect answers were given. And I can determine which misconceptions the student had or even which patterns of misconceptions there were. All that information is here. But now I start scoring and now have lost the quality of the misconceptions that there might be. The only thing I now know is which items were answered correctly and which were not. So in the next step, I tally up the scores and calculate the total score. Now I've lost the information with regards to which items were answered correctly and which were not. I now only know how many items were answered correctly and how many weren't. And then finally, I sort of compare the score with a cut-off score to determine whether the student has passed or failed. And now all the information has been lost and it's dichotomized into or reduced to fit into one bit of information, a yes or no, a pass or fail. And you could argue that that's not always the case because we sometimes give grades, but grades are still a very limited number of categories compared to that rich information we started with. But that's something that we need to do in the testing paradigm. So if we are forced to reduce information, it is only logical that we try to find the instrument that does this data reduction, this information reduction in the best possible way. And logically, there is a tendency, or there has been a tendency in the literature to find the single best instrument for each trade. And obviously, the best instrument has never been found. And it's logical because it's a matter of horses for courses. No clinical researcher would ever dream of conducting research demonstrating that antibiotics are better than NSAIDs, because the answer simply depends on whether you're trying to treat pneumonia or sterile bursitis, for example. And then finally, there is the implicit assumption that behaviorist drivers, punishment and rewards, are the best drivers to ensure that students actually study and study well. And at the risk of stating the obvious and telling you something that you already know, behaviorism is a very, very straightforward view on influencing human behavior. There's a stimulus, which is observed by the students, which leads to a response in the student. In our case, that's the student's learning or study behavior, which leads to a consequence, typically passing or failing the exam. And the possible ways in which these drivers work are positive and negative reinforcement and positive and negative punishment. And again, at the risk of stating the obvious, positive reinforcement means the student does something I like, I do something the student likes. Negative reinforcement means the student does something I like, I take away something that the student doesn't like. Positive punishment means the student does something I don't like, so I do something that the student doesn't like, the slap on the wrist. And negative punishment means the student does something that I don't like, so I take away something that the student really likes. The typical example is if you don't finish your plate, your food, you don't get dessert. And a well-known fact in behaviorism is that when the reinforcement or punishment are discontinued, the behavior has a tendency to go away, to fade out. Okay, these can be seen as problems, but the question remains, why are these problems? After all, this has been common practice in assessment over the world, all over the world, for decades in a row. So here are 5 issues that I would like to present to you. The first is that competence is actually multifaceted. And it's much more multifaceted than we assumed in the rather simple knowledge, skills, problem-solving ability, and attitudes model, the simple traits model. We know that competence is situational and context dependent. And it changes over time. And it has multiple aspects which all contribute and all interact with each other. And this is reflected in the competency models of almost all major organizations in the world. Medical expert, medical knowledge, or good clinical care are basically what is meant with knowledge, skills, and problem solving. And logically, they are the first to be mentioned in each of these competency frameworks. But there are many more. And they're also seen as integral, as an integral part of competence. And it quickly became clear that we were really able to measure them with a traditional testing approach, and that they required human judgment and subjectivity. So the next problem I already alluded to, but I gave examples only of multiple choice questions versus open-ended questions. But it's actually all across the board. Whatever comparisons you make, if the content is the same, the format is almost completely unimportant. Even in a comparison between the performance on a real OSCE and a written test on skills shows high correlations. And that's counterintuitive because we are used to think in terms of formats and not in terms of content. But the ramifications are immense. If we really want to produce information with our assessment program that is meaningful and useful and that can be acted upon, and whether it's to be used in a learning and assessment of learning context, or to make decisions about whether a student is ready to progress to a next phase or not, or whether we use it in an assessment for learning context to optimize student learning, the information must be meaningful. And for that, combining information that relates to the same content is far better, far more defensible than just combining information that relates to the same format. As a little illustration, you would never tell a patient that their glucose level is far too high, but fortunately their sodium level is far too low, and therefore their average lab results are okay. Because the glucose and the sodium have a meaning in themselves and need to be combined with other information. And modern doctors, the next thing is that modern doctors are not the same as past doctors. What was a good doctor 50 years ago is no longer a good doctor. And what is currently a good doctor will not be a good doctor in 50 years. That changed. The most important development that has happened and is still taking place is the shift from seeing medicine purely as a technical, cure-oriented discipline to being also a humanistic and a more care-oriented discipline. And of course, making the right diagnosis and decide on the correct therapeutic management is still important, but it's not the sole bread and butter of being a doctor. That's why the competency frameworks include so many of the domain-independent capabilities, such as communication, professionalism, collaboration, etc. But there are more. There are actually more changes taking place, and they are taking place in society. And they are having and going to have a huge impact on medicine, how we practice medicine, and on medical education. And of course, there are things like changing demographics, changing technology, changing therapeutics, funding. They all have an impact, but I don't want to focus on those. But I want to focus on these disruptions. And you may think that this is about technology, but it's not about technology. It's about changing fundamental changes in society. It's our connectedness. Through internet technology, we're so much more connected with each other, for better or for worse, and connected with a world of information. And that is leading to fundamental changes in how we do things. And from the many that are happening, I want to highlight 6. And the first relates to what you could call point of care access to information. Current students and graduates, and also patients, have a world of information at their fingertips. And this is fundamentally different from, for example, when I graduated from medical school. I was expected to have the vast majority of that necessary knowledge in my head, and all I could bring were 2 little books and not all the bookshelves with reference books. And that information exists in the internet because of what you could call cognitive surplus. Apparently, humans have a sort of inbuilt desire to share knowledge, to teach and to share information. Where before the internet, if you had a problem, you would have to ask a friendly neighbor or a friend who knew how to fix it, or hire a professional to help you. Nowadays, everybody's first port of call is Google, and which will typically redirect you to a website where somebody has made an instruction or an instruction video even showing you exactly how to solve the problem. Another consequence of this increased connectedness is the way we manage trust. Traditionally, trust is institutionalized. When a patient visits a doctor, they had to simply trust that doctor. It was in the institution of a doctor. Or when I wanted to go to have dinner in a fancy restaurant, I would look up that restaurant and the quality in the Michelin Guide. And the Michelin Guide is written by a couple of experts who had visited that restaurant once or twice and then wrote their review and gave their rating. Nowadays, if I want to go to a restaurant, I actually look up Google reviews, and I typically look at the top reviews and the bottom reviews and see how the restaurant has dealt with the reviews. So instead of placing my trust in the institution of Michelin Guide, I'm now placing my trust in the whole internet community. That has also changed the way we perceive knowledge, because knowledge was always seen as something that the expert had, and the expert was right, and the non-expert did not have the knowledge, and therefore the non-expert was wrong. But currently, we see knowledge as something that has multiple facets and is collaboratively constructed. So the compelling analogy is with the traditional encyclopedia, which was written by a group of experts and held more or less immutable, unchangeable truth, to Wikipedia, which is constantly, it's written by a large community and it's constantly renewed and advanced. And these have led to what's called a degrees of expertise asymmetry. When I graduated from medicine, the predominant view was that I, as doctor, knew everything, the patient knew nothing, and I had to tell the patient what was wrong with them and what was going to happen. And that has changed, because in many cases, the patient has done their homework. And regardless of whether this has led to correct knowledge or incorrect knowledge, it dramatically changes the dynamic in the consulting room. Given the idea of knowledge co-construction, it often leads to a situation where both the doctor and the patient add complementary expertise. There's a funny saying, funny joke in the internet in which a doctor tells the patient, "Don't you think that your hour of Googling is a substitute for my 6 years of studying?" Whereupon the patient replies by saying, "Don't you think that your hour lecture on my illness is a substitute of my experience of living with it for 20 years?" So finally, it's not unreasonable to expect that artificial intelligence and machine learning will have a dramatic impact on the medical profession in the way it's going to support and augment and sometimes even substitute traditional doctor roles, typically making a diagnosis and deciding on the optimal treatment. And that is again aligned with the view that non-discipline specific abilities, collaboration, communication, empathy, etc., feature ever more prominently in the competency frameworks. So a purely behaviorist framework is not enough to drive student learning. As I already said, if your drivers are purely behaviorist, it is likely pardon, that the desired behavior fades out when the reinforcement or the punishment are discontinued. And that was not a problem in a time when I graduated from medical school. So the dominant notion was that medical school would have prepared me with all the skills, knowledge, attitudes, and problem-solving ability to last me for the rest of my career. Of course, I was expected to update my knowledge, for example, if a new treatment modality would become available. But now it is actually likely that students will have to continue to study and reinvent themselves in their roles as doctor or in their professional development, professional identity development, because of those rapid changes, those disruptive changes that I was talking about, which are constantly taking place. So instead of a steady state after graduation, a continuation of development, of learning and development. So not just lifelong learning, but lifelong adapting will have to take place. And from a behaviorist point of view, that is simply not enough, because it's then important to realize that the span of control ends with graduation and then it stops, whereas our responsibility to society starts on day one after graduation. So that leads us to the principles of programmatic assessment and assessment for learning. And the first one is that any aggregation, synthesis, or triangulation of information has to be meaningful. It has to be a narrative, a story. Only that way we'll be able to make better informed decisions about whether a student is ready to progress or not, but we are also better able to provide that student with feedback. And students will therefore better be able to optimize their learning. So even large assessment programs with many instruments, you could say, well, they are multi-instrument and therefore they're a program of assessment, but it doesn't work if every instrument leads to a score, a grade, or even just a pass-fail decision. And then you add up all these scores or pass-fail decisions, because that information is not meaningful. And even if you add everything up, it will still not be meaningful. And that's what I wanted to illustrate with that example of Franz Kuyama, where you add apples and oranges to come to the total score of 4663. No, it's actually about meaningful triangulations. And meaningful triangulations means that instead of adding scores mathematically, you have to take bits out of each assessment modality that can be combined in a sort of narrative that tells you how something is doing, their progress, their achievement in a competency domain. For example, parts of a mini CX or an essay of a 360 degree, and then some feedback tells you something about the achievement in the role of communicator or health advocate or other domains. And of course, for that, you need multiple sources of information. Sorry. You need multiple qualities. And you might think, is that possible? Is it possible to combine information from such various sources and meaningfully triangulate? Well, is that doable? Can we do that? Well, it's something that we do as clinicians all the time. A patient consults you with complaints of fatigue, thirst, frequent urination. On inspection, you see poorly healing wounds. When the lab results come back and you palpate weak or absent peripheral arterial pulsations, and then the lab result comes back and the glucose is 35 millimoles per liter. And then when you conclude that the patient has diabetes mellitus, you've just synthesized and triangulated verbal, visual, tactile, and numerical information. The thing that allows you to combine that information into a meaningful conclusion is that you have expertise to do that. So expertise is key. In order to do that in a meaningful way, collection has to take place in a longitudinal fashion. So rather than having a one-off or only a few points in time during which you assess, where each assessment moment is also a decision moment, you have a program in which all the information that could contribute to that meaningful analysis of a student's achievement is collected continually. And obviously that means, like I said, that you have to separate the assessment moment of the decision moment. And every assessment is actually simply a data point that contributes to the richness of information and which you collect in a dossier or a portfolio. That allows you, that separation of decision moment and assessment moment allows you to be proportional in your decision making. High stakes decisions require rich information. Low stakes decisions require little information. Of course, you need that to achieve some better student agency, because when information is rich and meaningful, it does allow for better and better informed decision making. And the student gets that information as well, so they can take control and be responsible for their own achievement, their own study, but even in the end, for their own learning and assessment. And that's the most difficult and courageous part of programmatic assessment and assessment for learning. And it's the one that requires most organizational courage, because there is a long tradition of assuming that students are inherently unmotivated and lazy, and they need the cracking of the whip of assessment to drive their learning behavior. And there is a strongly held belief that when you give students control over their own assessment, they will automatically revert to all kinds of strategic, cunning behavior.
Professor
So
Lambert,
even in an environment
5 minutes.
Pardon?
5 minutes you have.
Yeah, thank you. I'm almost done. So even in an environment where student learning is supposed to be self-regulated and self-directed, we still treat assessment as something that has to be done to the students rather than with the student. And despite all those fear of allowing students control over their own assessment, at least in part, we automatically assume that once they graduate, they're able to do it. How could they if we never allow that? So allowing students to take responsibility is a very important point. Then finally, that means that we have to look at quality beyond the traditional psychometrics approaches. There are components in the assessment program that are more or less traditional, and they can benefit from psychometric approaches. There is the element of saturation. Sometimes you say, I've done observations and I've seen enough, I've reached saturation. Like in clinical medicine, I've done enough diagnostics to to make a diagnosis. But you can also build in your, you can build in expertise, staff development, and you can build it in as part of your organization. Now, finally, I want to focus on, on how to combine this, because they can work in synergy. And again, a clinical analogy works. When I order a lab test, I'm not interested in a lab analyst's opinion. The credibility, I want a number, and the credibility of that number is derived from statistics, population data, measurement validity and reliability. But if I order a pathology report, I am interested in the pathologist's opinion, and I want to read the narrative, I want to read the story. And credibility now comes from the pathologist's expertise, the clarity, coherence, and plausibility of what they write, and how it relates to my question. If the pathologist gives me a number and the lab analyst gives me a story, they're both useless. So again, it's horses for courses. Now, I'm going to finish off by a simple model of what this means for the practice of programmatic assessment, because however you implement it, these are, there's an element of continual collection of data, formal results, informal results, feedback, what have you. A moment, at several moments during the year, when the student analyzes that information, triangulates it, sits down with a mentor or another staff member to analyze that together, and then identify strengths and weaknesses, make a plan for improvement, and execute that plan for improvement. And it's very important that the student takes agency and is accountable and responsible for this. Because a student who does not seriously engage with this, who finds loopholes, who tries to avoid, that's the student who fails in the programmatic assessment for learning. And of course, a student who, despite the good intentions, doesn't make the improvements that they need to make. That brings me to ending up. It's similar to what you do in clinical practice. You collect data, history, physical examination, lab tests, which you review as a doctor or with a patient, which you analyze, you come up with a plan for improvement, and that's basically it. Final slide. So the tips are not a roadmap. The tips are what you need in your organization to make it happen. You need knowledge brokers, people who can combine that stable evidence with the contextualized evidence with local organization and are able to translate that. Simply copying what somebody else does doesn't work. The leadership has to be on board. If your leadership doesn't see the value of changing to programmatic assessment and assessment for learning, it's going to be an uphill battle for the knowledge brokers. You need courage. Innovation is scary and dramatic. The bigger the change, the scarier the change. So you need courage in your organization, but you can't do it alone. So you need to focus on getting buy-in from all your teachers and stakeholders, which you hopefully will help you to create a culture in which this is possible. And only then, if you got these things ready, is it worth making an investment in the change. Thank you very much for listening.
Thank you very much, Professor Lambert, for this elegant presentations and finishing on time. We will move to the second presenter and we'll leave discussion to the panel discussion. Our second presenter is Dr. Colin Greengrass. Dr. Colin works as a senior lecturer in pharmacology at Royal College of Surgeons of Ireland, Bahrain Center. After completing his MSc in neuroscience from London and PhD from National University of Singapore, he involved himself in different aspects of teaching, learning, and assessment. He also completed his Master in Health Profession Education. Previously, he has worked in leadership role in medical education in different colleges of Saudi Arabia. Dr. Greengrass has consulted on educational program development projects in several institutions across the Gulf region and has conducted numerous workshops worldwide in the field of medical education, especially big conferences workshop held in AMEE in 2018. Dr. Khan is going to talk about the role of cognitive psychology in curriculum design, providing structure to clinical reasoning. Please, Dr. Khan.
Okay, great. He is done.
Thank you very much indeed. Okay, so just switching to presentation mode. Excellent. Yeah, so it's a great honor and a great pleasure to be here to talk to you today. The role of cognitive psychology in curriculum design, providing a structure to clinical reasoning. This will be the topic of this presentation. A little bit about myself. I'm Academic Director for Technology Enhanced Learning, amongst other things, in the Royal College of Surgeons in Ireland, RCSI, Medical University of Bahrain. Surface versus deep learning. Well, it would be expected that deep learning would be employed by our potential medical doctors to a large degree, we would hope. And we would expect that our doctors would have a deep level of understanding of the various conditions in order to accurately diagnose and treat a patient, we would hope. And this short discourse will focus on how a deeper form of learning and potentially more accurate diagnostic reasoning can be brought into medical education through a specific curriculum design ethos. In order to frame this approach, we must first examine how we learn. What we'll be looking at today is how do we learn, store, retrieve, and make sense of information, processes and mechanisms involved in diagnostic reasoning, a curriculum design approach for structuring diagnostic reasoning, and achieving optimal memory encoding, and also constructing and streamlining, which is very important, medical curriculum. So firstly, how do we learn, store, retrieve, and make sense of information? Well, firstly, if we look at schema theory, which is pretty valid theory of learning, knowledge is thought to be held within conceptual schema in the brain. And this is contained within networks of neurons, usually via synaptic connections between them. Schema theory describes how knowledge is structured in memory. And schema or schemata are knowledge structures in the brain, schemata being plural of schema. Schema represent linked components of knowledge which form concepts or ideas. They're constructed during learning, and they are thought to form the structure of long-term memory. We have a couple of schema as examples here. Simple schema, which involves an object, and the various facets and descriptions about what that object is like. And then we have complex schema, where we are looking at the interactions between different objects, each of those objects having a description like that of the simple schema. Well, learning activates and builds additional elements into conceptual schema. And further learning may also form a link between previously unlinked schema without the addition of any further components. So this is constantly going on while we're learning. In fact, in daily life, constantly we are building schema through more and more complicated synaptic connections. Now, the process of acquiring schema occupies a component of working memory during the learning process. And what is working memory? We'll look at that in a moment. Working memory is basically when faced with learning new learning items, working memory tries to sort out what it means by fitting everything together, forming each component's internal structure. So here are some components of something we are looking at right now. We are trying to learn what this means. How do we learn the meaning of these components? Well, we try to establish an internal structure, how everything fits together, how everything is ordered. And that really forms a schema. Now, if there's any prior knowledge, the working memory will access this. And what it will do with that, it will try to understand how new information, which we're facing here, fits in terms of what we already know. This refers to schema in long-term memory, all the things we already know, which may be related to these objects here. And we try to make sense and try to work out how they all fit together. What's the internal structure from what we already know? Now, when a fragment of knowledge is presented which doesn't fit in with any established structure, retention, which is the formation of long-term memory, can fail. And if retention occurs, it's often fragmented and it's not very useful in practice. And as we can see here in this diagram, we have these various blocks forming schema. And these are quite different. These objects to learn are quite different. They really don't fit in with anything else. So we can't rely on long-term memory to really work out the internal structure of these. And even if we did implant this into working memory, it wouldn't be related to anything else. It would be an isolated fragment. Constructivism and schema. Well, constructivism is closely linked to schema theory, in that pre-established schema are augmented by experience to form more complex, more robust schema. So we're constantly refining and expanding upon the schema that we already have when learning. Previously defined schema provide a framework for construction of new schema, and existing schema can influence patterns of incorporation of new information. This last part is very important. What we see here in this example is that cognitive constructivist principles, this particular picture represents two individuals who interpret new knowledge differently in terms of what they already know. Okay, that's constructivism. That's what it's all about. You will interpret something in terms of what you already know, but that may skew the interpretation. And this phenomenon is not ideal for graduates from a medical program. We would hope and expect some degree of uniformity, in fact, a good degree of uniformity in all of the graduates coming from a medical program. The working memory is limited in its capacity. It can only process around 4 plus or minus 1, that's 3 to 5 components at one time within a 30-second block of activity. And this is where cognitive load comes in, and cognitive load theory. Cognitive load theory introduces the idea of load. How much can working memory cope with? What is the capacity of working memory? Cognitive load theory describes how working memory processes information during the process of learning from a load perspective. Intrinsic cognitive overload. Now, if we remember that we can only process 4 plus or minus 1 components at one time, here we have far too many. So there are too many objects which we are trying to learn. We're trying to work out the internal structure of all of these, how they fit together. Within this period of time of around 30 seconds, it's not going to work. We are limited to around 4 plus or minus 1. So when we're faced with too many components, this constitutes intrinsic cognitive overload. The working memory also attempts to link components in order to develop this connecting concept, as we know, and it often uses what is already known, as I just described. But this also occupies a status of load on working memory, and it's called germane cognitive load. When the working memory attempts to link components in order to develop a connecting concept, this exerts that load called germane cognitive load, which refers to the process of accessing, conceptualizing information in this manner. Now, the less complete a structure, or the more incomplete a structure or schema of underlying knowledge, the more cognitive load is required. And here again, we have two examples. In example 2 over here, we have a very much complete schemata. So we have various schema which are all linked together. So this is information about one object, this is information about a related object, and information about another related object. And they're all linked together. We know the linkages. It represents a robust schemata. Example number 1 is a little bit different. There are a lot of incomplete schema here and incomplete interactions. So we don't know everything, or this person doesn't know everything about this particular concept. So example 2 represents long-term memory that has a more complete set of schema, and example 1, a less complete set of schema. Now, germane cognitive load will usually be lower in individual 2 because they have that more complete set of schema. They're able to bypass much of that working out process, and the cognitive load will be less. Now, this is a kind of gross oversimplification of memory. There are numerous other memory access structures, pathways, indexing characteristics, which will influence the amount of cognitive effort required. But the basic principle here is very important. It does have a component of learning, and it is important in curriculum design and in instructional design. So when a component also is presented, which is unrelated to a possible concept, this produces extraneous cognitive load. So here we have these 5 elements, and then we have another one which looks a little bit out of place. Now, if you're faced with learning something and everything seems to fit together, but there's something else that doesn't really fit, you're trying to fit it in, to this central unifying concept, but it doesn't work because it's not related. Again, this is very important in curriculum design and instructional design. And it's called extraneous cognitive load. Why is it a load? Well, it's a load in order to try and work out how this fits in firstly, and then when you find it doesn't fit in, you are now ruling this particular object out and starting again with the objects which do fit together. So it occupies a cognitive load called extraneous cognitive load. Looking at the processes and mechanisms involved in diagnostic reasoning, we're trying to achieve a curriculum structure which enables us to optimize diagnostic reasoning. How doctors think when they diagnose a case is called diagnostic reasoning. And when encountering a clinical case, the working memory again attempts to sort and conceptualize the components of that case. Now, the components of the case are compared with what is already known in long-term memory to arrive at an understanding of the case premise, and at the very least, or to make a diagnosis. There are three main types of diagnostic reasoning: pattern recognition, hypothetico-deductive reasoning, and scheme-inductive reasoning. Now, pattern recognition comes with extensive clinical experience. Eventually, this experience leads to acquisition of a repertoire of problems and their solutions. Pattern recognition uses the resolution of past problems to inform on and address new but similar problems. But pattern recognition, as it comes with extensive clinical experience, is definitely a successful diagnostic reasoning strategy, but it's only really available to experts. It's not available to novices or those on their way to becoming experts. The components of, my apologies, the components of these various cases, this repertoire of cases, are termed illness scripts. And illness scripts are embedded in long-term memory, again, a schema, and we can see a series of cases which they've come across, which are embedded as schema in long-term memory. They form the basis of pattern recognition when facing new cases, the same basic principles again. Utilizing illness scripts, interestingly, is usually a system one processing task. Now, system one processing is part of a fast, intuitive, and largely unconscious system of decision-making. You don't know why you're making that decision. You just feel intuitive about it. You're not really analyzing each component and how it fits together within that decision-making process. It's largely unconscious. This is a highly efficient, rapid process, but it's only accurate if patterns are correct. Just to give some context, more than type 1 processing is utilized in greater than 95% of our decision-making daily. We're not aware of our decision-making. It's intuitive, yet we are making decisions, and that's system 1 processing. But the accuracy of pattern recognition, well, excessive reliance on pattern recognition has been shown to decrease diagnostic accuracy, and that can be problematic. And some studies have particularly cautioned against its overuse among inadequately experienced clinicians. Looking at the declarative system, that's quite different to system 1. System 2 is analytical. Processing is conscious, declarative, and deliberative. You know that you are working through a problem. You're very conscious of it. It has a high cognitive awareness, and it commonly utilizes deductive and inductive reasoning strategies. One of those is hypothetico-deductive reasoning. Now, hypothetico-deductive reasoning involves the procedure of developing hypotheses and testing them for best fits. You come across a case, you develop hypotheses which describe that case. The physician relates the general knowledge of the disease hypothesized to the specific signs and symptoms of the patient, and those least appropriate or with the least comfortable fit are rejected, and the remaining hypothesis is sought. So it's a kind of trial and error to see whether it fits into this particular case description. Hypothetico-deductive reasoning is often superficial, and you can learn hypothetico-deductive reasoning by involving rote memorization of small fragmented packets of information or long lists of static diagnoses. The problems with hypothetico-deductive reasoning, well, only a limited number of possible cases might be considered at one time. So we come across a case, we consider several different solutions, several different diagnoses, but we can only really, because of the limitations of the working memory, we can only really concentrate on 4 plus or minus 1 different cases at one time. Well, we may need more than that number because those cases might not cover the case we are coming across currently. And the case experience may also have some atypical elements that don't fit into any of the known cases. In this regard, it would be impossible to make a diagnosis. Scheme inductive reasoning. This is perhaps the one we're going to look at. Indeed, it is. In scheme inductive reasoning, structures provide specified pathways for diagnosis, conceptualized as decision trees. Diagnosticians gather information to distinguish between choices and make decisions at branching points in a decision tree. So here we have dysphagia, and we're making decisions based on various symptoms and signs along this tree, eventually arriving at a diagnosis. And this is what we're looking at here, all about dysphagia, is a scheme. Now, a scheme describes a diagnostic process for an initial presentation of dysphagia. After several branching points, the number of diagnostic options has been considerably reduced, and this type of problem solving represents the climbing of a conditional inductive tree. The forms of knowledge that are required and used in scheme inductive reasoning are a lot more sophisticated than in hypothetical deductive reasoning. Clinical findings, anatomical locations, pathophysiologic details, disease taxonomies are all important, and they're used in this form of reasoning. And also higher order knowledge structures where we are linking intricate networks into a scheme of relationships and diagnoses, which is what this is all about. What's the difference between scheme and schema? It's similar terminology. Well, schema are different to schemes in that schema are internalized cognitive networks. So each one of these little colored balls is a schema, and the whole thing linked together, because it's linked together, also forms a schema, but a more detailed one. Schemes are external representations which are represented here in this chart of dysphagia. Schemes may not be identical to schemata, but likely they are close to the actual internal representation if it's been learned properly. So for diagnostic reasoning, what is the best method? Scheme inductive reasoning is shown to be associated with superior diagnostic success than hypothetical deductive reasoning. And this is found in both novices and experts, that it has a superior diagnostic success. Hypothetical deductive reasoning is an inferior diagnostic strategy. Pattern recognition and scheme inductive reasoning are basically similar in their level of diagnostic success, except pattern recognition is really only found with experts and it comes with experience. But scheme inductive reasoning is valid for all stages of the learning process because it also is valid for novices, where they can develop scheme inductive reasoning. To enhance diagnostic cognition and performance, we need to be able to learn and establish integrated schema in memory comprising knowledge and related skills. I think we've really established that. And we need to be able to integrate knowledge to make scheme inductively based decisions in clinical practice. And the key here, integrate knowledge. Now, the curriculum has a fundamental role in achieving this aim. And we'll look at some examples of how or what could be done to do so. So can we optimize the structure of a curriculum to enhance diagnostic reasoning? Firstly, looking at the theoretical bit. So schemes are considered to reflect an organized structure for diagnostic reasoning, as we have here, but also they can reflect an organized knowledge framework for learning. So it's not just about diagnostic reasoning, but you could actually learn this scheme. It's been argued that teaching or learning schemes such as these is beneficial for improving problem solving and thus diagnostic reasoning. And there's a little bit of evidence to show that, yes, learning these schemes, a few of them, can improve diagnostic reasoning. But is the title. Memorizing schemes does not equate with good learning practice. Schemes are not well encoded for easy learning. It's okay when you have around 10 of them you have to learn. When it becomes hundreds, then it becomes problematic. There's a lot of confusion within those schemes, and memory, long-term memory, doesn't deal with them easily. We have to learn in a different way to try and learn these schemes. So learning them directly doesn't work. Potentially the best method to learn schemes is through a curriculum driven by memory encoding principles, yet adhering to scheme construction. We'll look at how that might be done. So what are memory encoding principles? Well, effective encoding. So in order to learn and to store a memory, this requires information to be presented or organized in specific ways in order for learning to take place efficiently. Now, memory encoding is categorized as mnemonic and organizational. We'll look at both. Mnemonic is all about imagery and narrative. It's telling visually based stories. The best way of doing it is really through animation and simulation. Computerized simulation is fantastic for it. Mnemonic encoding utilizes mechanisms which facilitate learning, specifically through imaging and narrative. And mental imagery refers to mental representations of visual, spatial knowledge, such as in this diagram here, the physical properties, which we'll look at in a moment, of any objects and event represented. Imagery, however, must also take account of cognitive load and its limitations, and having too many elements and things which are superfluous would detract from this learning experience. And here we have the whole thing as an animation. We have our nucleus, nuclear pores, the ribosome, then we have the endoplasmic reticulum, we have some transport vesicles, Golgi apparatus, secretory vesicles. Then we go on to, there's an lysosome poking out, the cytoskeleton, mitochondria, and peroxisomes. And that's really what we need here. In fact, if we were really dealing with cognitive load, we would not have mitochondria, peroxisomes, and lysosomes, because they're not related to the central concept, which here is all about translation and transport of proteins to the cell surface. And as you can see here, this animation kind of describes, it's not completely accurate because that ribosome would actually be on the endoplasmic reticulum if it was doing this. Organizational encoding. There are several types of organizational encoding. There are those which are involved with categorization, outlining, describing hierarchies, concept mapping, which is very important, chunking, elaboration, and narrative. And these are some examples of how you can describe outlining, chunking, and narrative through a graphic like this, categorization and chunking, and the one which I love to use and it's very useful is concept mapping, which can describe outlining, hierarchies, organization, and narrative. Now, aiding organizational encoding. Organizing information whenever we're teaching or learning anything can allow the bypass of the sorting stage of working memory. So these elements, we don't know its internal structure. Well, we can teach the basics of its internal structure, aid the resolution of its internal structure by the student having access to some method of organizational encoding. And we'll look at how that works in a moment. The solar taxonomy. This is the structure of observed, my apologies, learning outcomes. Okay, taxonomy describes the stages of learning. And this was first proposed by Professor John Biggs. Okay. So the solar taxonomy has many uses in education. Usually the solar taxonomy is used to formulate learning objectives, to assess depth of learning, most important, to indicate the ability to complete a task, in our case would be diagnostic reasoning, but it also, importantly, represents the structuring of content according to organizational encoding principles. Other importances of the solar taxonomy is that it focuses on the following: the process of construction of knowledge, the integration of constructed knowledge, the utility of constructed knowledge related to task completion, observable evidence of a student's understanding, and outcomes of knowledge rather than just merely descriptions of knowledge. This is a very useful taxonomy for developing a curriculum. Now, the solar taxonomy is split into 5 categories or phases. We have the first 3, pre-structural, unistructural, and multistructural, which really constitute a limited, fragmented knowledge structure. What we're really trying to achieve is something in this domain, a relational and extended abstract. So an ideal curriculum would largely dispense with phases 1 to 3. The first 3 levels represent surface learning. They're pre-analytical. They're not very useful in practice. If we're teaching our students lots and lots of this pre-analytical surface learning, then they won't be able to use it in practice, and in this case, within diagnostic reasoning. But the final 2 levels focus on depth of knowledge and depth of understanding. This is relational and extended abstract. Now, an ideal curriculum will try to establish relational aspects from the beginning. But how could this be done? Well, we'll see some ideas. Now, the problem is that we often deliver content in these forms. Unistructural, which refers to a single isolated schema, a single object, not related to anything at all. Multistructural, which are multiple different objects, which are not really related to anything at all. Relational and extended, this is where the relation between different schema occurs. The relational phase. Well, Biggs mentions that in the Solo taxonomy, the relational phase refers to a stage where sufficient knowledge on a subject has been acquired. It's now integrated. If we look at this diagram here of all these schema, they are actually in a relational phase. They're linked together. We know how this object is linked to this, or this structure, or this biological system is linked to this. At a relational level, the learner now starts to see how elements of a subject are put together. And now they can start to make at least a kind of rudimentary diagnosis, maybe without the detail. Okay, I'm hearing myself back a little bit. At the relational level, a learner now has the ability to create structures and systems for sorting new knowledge. At the relational level, a learner can view a topic from several perspectives. And at the relational phase, prepares the learner for problem solving similar to diagnostic reasoning, which is all involving this kind of setup. Also at the relational level, the learner can begin to explain connections between things using systemic and theoretical modeling. Now, this really looks like diagnostic reasoning, at least the beginnings of it. A learner can ask questions such as, what would happen if? What would be the downstream effects of something upstream? What would be the system effects of something affecting one system on another system? Now, this is the level we should aim for in the development of a curriculum. But how can this be done? So now the same question, can we optimize the structure of a curriculum to enhance diagnostic reasoning, the practical part? Well, firstly, we use outlining. We define and provide an overview and a scaffold for learning. And we'll look at some examples of that in a moment. An overview, in this case, we're just going to come up with, is a summary of body systems and how they interact. And what that enables you to do, or learner enables, that enables a learner to do, is to track what happens if there's a system failure downstream, upstream. Subsequently, examining body systems and pathophysiology in more detail. So let's look at what all that means. So firstly, it can all be achieved by outlining, and outlining a process can be achieved through concept mapping. And here we have a process which is outlined through concept mapping. Mutant DNA carried through cell division via meiosis, via mitosis, etc., etc. What can happen downstream? Now, this provides a framework for understanding major interactions between components. And each component firstly will be described at a basic level in order to define how one may impact another. Now, later on, we will describe each component in more detail, more intricate detail. Here's another example of this kind of mapping. We have these three major systems: what happens in a circulatory system at a basic level, what happens in a respiratory system, what happens in the gastrointestinal system, all at a very basic general level. But we look at how one affects another, how perhaps dysfunction of one affects another. Now, this provides a scaffold for understanding interactions between components. It provides a structure for knowledge, despite it being relatively superficial. So we could potentially know the internal structure, at least it may not be absolutely complete, but we know the basic internal structure of a new learning element from the outline that we have been given. Now, this allows context to be drawn in determining the structure of elements in a unit of knowledge and provides a scaffold, what we're seeing here, for incorporation of new knowledge. So basically, we start with this very basic system, and then we look at it in far more detail. The learner must have access to this kind of map, this thing here. It must have access to this kind of map structure at all times because it provides a means of understanding interactions between different components, a structure for conceptualizing new knowledge, and where subsequently more detailed knowledge will be incorporated into that structure, it gives that overarching structure for that knowledge to be incorporated. The outlining process largely bypasses the first three phases of the solo taxonomy. And this leads to a more relational form of a curriculum. Now, it should improve accuracy of heuristics, and there's some evidence that it does. And it should also scaffold learning more towards rapid generation of accurate, robust algorithms, which there's some evidence that this kind of setup also does. Something which we've all definitely come across in the development of a curricula is the division of normal function followed by abnormal function, normalization of function, and application and practice in respect of clinical practice. And all of these are very much valid and very useful in this kind of curriculum. Yes, this layering definitely needs to take place. But how could we really manage a learning framework with all these maps and this various concept maps all linked together? And it's impossible, isn't it? It would take pages and pages of paper. The students would have to have, well, hundreds and hundreds of pages like they take to revise for exams. Actually, the learning management system could cope with it all. And the learning management system, computerized learning management system, virtual learning environment, can provide an interactive curriculum map. What this does is it describes each component, in this case of the respiratory system. It's computerized, and you click on a particular node, and it takes you to somewhere else. So, for instance, you click on the node for lung cancer, it takes you to all the information, or another map, which is describing lung cancer. Click on asthma, and it takes you to a map which is describing all the facets of asthma, which we'll look at one in a moment. But it also provides a clear logical structure to the curriculum. It enables the student to view a scaffold. We're seeing, this is how we want the student to see the curriculum and how everything is linked together, and the student can also see that. Takes away a lot of that germane cognitive load which was required in trying to sort out information. And here we have the next step, where we have components for asthma. And we're looking at asthma from properties of gases, diffusion, gases exchange across membranes, all the way up to clinical applications through pharmacology, therapeutics, etc. And all of the linkages between them are made explicit. Interestingly, within a learning management system, all being computerized, we could have, you click on one particular node, and it gives you something like this. It gives you a micro-learning resource. It may give you another map, which shows you how this is all linked together conceptually. And then that would offer you a micro-learning resource. Now, we've probably established that schemes like this scheme for dysphagia, they're difficult to learn, especially when you have many, many of them. But instead, what we have learned, what we've done here, is we've potentially learned the scheme by causation through an integrated understanding of basic medical sciences. We've done it according to memory encoding principles, which learning schemes doesn't adhere to. But we could have a monster on our hands. If we're looking at all of the content from all of medicine, all conceptually mapped and linked together, it's a huge curriculum. This could be done. It's valid to try and do this, but it's a huge, monstrously sized curriculum. So what we would need to do is we need to determine the necessary and unnecessary content in the curriculum derived according to relevance to defined common clinical presentations which the curriculum will focus upon. And here are some examples of those clinical presentations. If there's something in this massive, monstrous curriculum which doesn't refer to these clinical presentations, then we minimize or remove it. We streamline the curriculum. Content load, so the amount of content, rather than just cutting something out, the amount of content. So we may decrease the amount of content in a particular area, which is refined according to the knowledge requirements of these cases as well. And this minimizes also the inclusion of rare diseases and disorders in the curriculum, which are not necessary for general practice, general clinical practice in a specific region. So disease states which are very uncommon in a particular region, you won't include them. And the basic sciences or the basic medical sciences which are leading up to an understanding or diagnosis of that condition, which is very rare, will also be removed or minimized if they're not required elsewhere. But this will make the curriculum manageable for the learner and manageable administratively.
Dr. Cullen, 5 minutes.
Onto the solar taxonomy a little bit more, the extended abstract phase, which we didn't really look at. The extended abstract phase refers to a stage where sufficient knowledge on a subject has been acquired. This highly structured knowledge base can be viewed in other contexts or problems. So we now have very much a well-established schema. This is very well established. We understand this very well, how all the components fit together. But can we apply that to other cases? Well, the extended abstract phase permits the application of knowledge to other related scenarios and would provide a suitable structure for applied problem solving. And here we have one here. It's well established as a robust schema. It describes a particular case or set of cases. We can apply that to something which is unknown and come up with a robust clinical decision, a diagnosis. And this can inform on diagnostic reasoning for unknown cases with similar pathologies. And that's what extended abstract phase, that phase is all about. It's about, can we apply the knowledge we've learned to other situations? In summary, a learner's curriculum. Curricula are often, and we're all guilty of this, curriculum are often designed according to an administrative structure for use by instructors. What that means is, this particular lecturer will be teaching this on one day, and this particular lecturer will be teaching this in the afternoon on the same day. Well, it doesn't actually adhere to a curriculum which is structured for the learner. And a curriculum, we're in the education business, so the curriculum should be entirely designed and structured for the learner. Another important principle is to scaffold learning throughout the curriculum, to interlink all those learning points to see how they are linked together. And to make that explicit to the student, they have to know where they are in the curriculum. They'll not only know where they are, to know what comes next and what came before, and where they may be lacking in knowledge, but they'll also use that scaffold or use that curriculum as a scaffold for learning, so it will improve learning. And again, some evidence to show that. The most important aspect of such a curriculum is that these linkages of interrelated elements must be made explicit, so the learner must know them. It would also be useful to have sessions dedicated to scaffolding, which must really be incorporated into the curriculum and the schedule. We would schedule a part of a lecture or even a whole lecture looking at, or maybe not even a lecture, but if we're going to be really daring, something which is student-centered. We would look at establishing this scaffold, so the student knows how this scaffold and they know how everything is linked together, and testing it would be ideal. Concept mapping should be continued throughout the curriculum in increasingly greater detail. Now we're getting down to the processing of proteins, of peptides, and molecular chaperones of what they're doing. Another thing we can do, well, how are we going to deal with it all? Well, a learner's curriculum needs computer-aided content scaffolding. We're in this age where everything is online, and we can really use that technology to establish something like this within a computer system, within a learning management system. And what would you do? Well, the curriculum firstly can be visually concept mapped, the learner will have access to the map on the computer system or the learning management system. They'll know how each element is linked together. They'll click on a particular node. It will take them to resources or other maps describing cell death, apoptosis, and activating a node on that map could easily be linked to content or other maps. And here we have one example of it being linked to content. So we clicked on the node for cell division, and it took us to this video describing cell division. That by itself isn't enough. It would be a series of learning resources and probably a map describing the process. Finally, assessment and deep learning. Assessment drives learning, of which there is no doubt, but also the type of assessment shapes the type of learning conducted. Now, assessment of fragmented knowledge or fragmented information requiring factual recall only drives surface learning. So we could have a beautifully mapped curriculum where we've gone through all of that effort, but if we only ask questions in assessment on factual recall, facts and figures, and not really asking questions on the interactions between systems or within systems, mechanisms, how they can be applied. If we're not asking those sorts of questions, we're only focusing on these factual recall, lower taxonomical level questions, then the student will only be driven to learn surface learning. So all of that effort in mapping and integrating the curriculum will be wasted. The assessment which comes from this type of curriculum has to be related to deeper learning, and it has to look at interactions within and between systems, mechanisms, and how they can be applied. Thank you very much indeed, and I very much invite questions.
Thank you, Dr. Colin Greengrass, for this masterpiece lecture. I think this is what happens when you combine neuroscience with education. Our third speaker is Peter Washer. He is a professor he has a PhD in medical ethics and law and education, and he obtained it from UCL. He is a member of the Clinical Communication Skills Unit. He has taught clinical communication at Imperial College in London. He also taught courses in medical ethics, communication skills, education in several leading universities in UK. He has a wide experience of teaching both undergraduate and postgraduate trainees. His book, Clinical Communication Skills, has been published by Oxford University Press some years back. Now he currently works for the King's Health Partner, King's College in London. Please, Dr. Peter Washer.
Thank you very much for that introduction. Can I just check that you are hearing me okay? Is everything okay? Yeah?
Yeah,
I'm assuming so. Yes, I'm really honoured and delighted to be invited to this conference. My only disappointment is that I'm not actually there in ABHA. I have actually worked in the Kingdom a very long time ago, in about 1990, and I have visited ABHA, and I was really looking forward to coming back. But then the pandemic happened, so here we are. My original title was more focused on faculty development for assessing clinical communication. But with your permission, I have broadened that a bit because I wanted to talk more generally about, I think teaching and assessing clinical communication is actually two sides of the same coin, and I want to talk about that. About me. Okay, as per the introduction, my academic background is in philosophy and medical ethics and law. I've worked in university since 1997. Before that, I worked in a charity working with people with HIV-related dementia, and that was quite intense, and I burnt out and ended up moving into academia. I've done faculty development roles across universities and worked in pretty much all of the medical schools in London. More recently, I've been an educational advisor to the Royal College of Radiologists in London, where I wrote the first teaching qualification specifically for radiologists and oncologists. So I just wanted to say, if there are any oncologists or radiologists with an interest in doing a master's in education specific to them, please do go and have a look at the University of Dundee's website. There's an online course there that you might be interested in. And I actually resigned my job at King's College London before Christmas. I've recently done an MBA, and I'm now working as a freelance educational consultant, doing management consultancy for healthcare organisations and running faculty development courses on teaching and assessing clinical communication. I've just done one of those in Poland. My research interests, as my career is also not a very straight line. My research interests are also in public understanding of science, and my PhD and postdoc work was looking at how people made sense of emerging infectious diseases such as SARS. So you can imagine that my citations over the past couple of years have gone like that, which is great. But that's not what I'm going to talk about today. I'm going to talk about my work in clinical communication skills. And as I say, around about 2003, I got my first lecturing post teaching clinical communication at University College London. And I inherited a curriculum at that point that was largely about medical history taking, and I thought was actually quite satisfactory. So, say for example, the point in the curriculum where the students came to taking a sexual history, there was a kind of checklist of all the information that they needed to gather in a sexual history, and then the assessment really was whether they reached the right diagnosis from the scenario. When I saw this session first, I was just thinking, is that it? Is there nothing? Where's all the other stuff? Because medical students are generally young. Junior doctors are young, and you've got patients that are frequently much older, looking at this medical student or young doctor, thinking, "Oh my word, this person is young enough to be my granddaughter or my grandson." And similarly, the medical student is looking at the patient thinking, "I can't possibly ask all these questions. It's too embarrassing. This woman is old enough to be my grandmother." And none of that was acknowledged in the teaching or the assessment. And I just thought it just seemed such an enormous gap. And similarly, the issues about dealing with cultural diversity, about dealing with disability, about talking about complaints, and all these kind of really complex issues were really just kind of boiled down to this medical history taking. And anyway, I felt it was really unsatisfactory. And over a few years, I did a lot of curriculum development work around those issues, which became the book Clinical Communication Skills, and published by Oxford University Press. And the picture on the right is me looking very pleased with myself because it won an award at the British Medical Association for the best book in its category that year. This is the area of work I want to talk about today, and my learning outcomes for this talk. We've already had Prof. Sherworth this morning talking about changes to the doctor-patient relationship. I want to add my penny's worth to that. And then in the middle part of my talk, I want to talk about the benefits of clear, effective, and we might say patient-centered communication. And I've got some 5 benefits I want to talk about. And then the meat of my presentation is about what was the original title, which was really thinking about, and how do we put that into practice? How do we train up the faculty to improve the clinical communication teaching and assessment that hopefully moves away from this kind of model that is just the medical history and moves towards more patient-centeredness, one that is both more satisfactory for the patient and for the doctor and medical student. So my first point then, what are the changes to the doctor-patient relationship? Well, as we have already heard, I mean, the obvious one is the access to medical information. I mean, if you go back a generation, I'm not that old, but when I was young, we had a Reader's Digest medical, dictionary or encyclopedia in the corner somewhere. I had an auntie who was a nurse, but other than that, I mean, nobody had any access to medical information other than the doctor. The doctor was the sole, or the healthcare professional at least, was the sole gateway to any kind of medical information. And now, patients will obviously, Google their symptoms, Google their diagnosis, Google their treatment, Google their doctors even. And will frequently come in now, and even very old patients will have younger children and grandchildren who will be doing the Googling for them, and they'll come to the consultation with printouts of all this information that they've found, and that really alters the dynamic of the consultation, and that's a good thing. Informed, knowledgeable patients is a positive thing. But obviously, as we have seen with the pandemic, a lot of the information out there is just wrong, and patients do not have the research skills to filter and to know where the correct information is a lot of the time. And a lot of it can be very dangerous. So there's a different kind of consultation to be had, which is about saying, okay, a good doctor will say, look, it's great that you found this information. Let me just talk you through why you've correctly identified all the potential treatments that you could have. The reason why I haven't suggested these ones are because of the side effects, and I haven't suggested this one because of the cost, or whatever. But it's a different type of discussion. The second point I would say is about less deference to medical authority. I think there's less deference to all types of authority. If you think of, in more traditional societies where we had sources of authority, it would have been, religion, the police, the press, government. I mean, all of those sources of authority are being questioned, for better or worse. And that, again, feeds into this different kind of dynamic between doctors and patients. The third change in contemporary doctor-patient relationships is just really the complexity of what's available to do now. Again, if you go back a couple of generations, if you had, cancer of the cervix, the options were really limited, whereas now there's an enormous range of potential things that can be done for everything. And then that changes the complexity that has to be explained, and it becomes a much more difficult thing for a patient to think, okay, well, how does this align with my priorities and preferences, this greater life expectancy versus this quality of life, all that kind of stuff. The fourth point is that there are more complaints and litigations. I mean, in some countries more than others, but I think everywhere, a part of this whole different relationship is people are more likely to complain if they feel that they have been hard done by. And the fifth point is what we might call the increasing medicalization of lifestyle. So things that are not really medical conditions, such as aging and obesity and childbirth, become part of, under the scope of medical, the gaze, as you might say. And in response to that, there's a resistance to that medicalization. So we might say the voluntary euthanasia, natural childbirth, LGBT, disability movements, all in their way are trying to demedicalize death, birth, sexuality, disability, and arguing against it being considered as something that the medical has an answer to, and rather as something that is part of the rich variety of the human existence. So, given that things are changing, I wanted to look at some of the research that I used in my book about clear, effective clinical communication. And I've come up with 5 different areas. The first is, with effective clinical communication, you are more likely to get the diagnosis right. Now, put it bluntly, the 3 points, the 3 ways to get a diagnosis. One is the history, one is any tests you can do, and the third is examining the patient. And the medical history always was and still is the most likely one to get the right one. So this is a really old study from the 70s. It was a study of UK medical outpatients appointments, and found that so what they did was they asked the doctors for a diagnosis based on the patient referral letter. Then after they'd taken the history, after they'd examined the patient, and then they checked that diagnosis with the confirmed diagnosis 2 months later. And they found that in 66 out of 80 patients, the doctors found the correct diagnosis on the basis of the history alone. And then Peterson, this is a Canadian study, a generation later, repeated the study and pretty much found the same results. But beyond that, beyond getting the right diagnosis, there's also about scratching the surface and getting to what the patient really is there for. I put real in inverted commas here. And so the ROAD study is a US study of GP visits. And they recorded doctors' consultations with the patients in a general practice setting. And what they found was that, on average, after only 12 seconds of the patients opening their mouths and started speaking, the doctors had interrupted and redirected them. And as a result, they weren't, the patients, what the patients had come there with were being really redirected and hurried along into something that more the doctor fitted the doctor's early ideas of what was going on. The Bell study is a Californian study and a much bigger one, 909 patients that they looked, and they found that 11% of patients had an unmet expectation, leading to repeated visits. And I know when I give this kind of talk to doctors, quite often they say, well, we haven't got time. But a lot of these studies will say, you know, the patient-centered consultation takes about a minute longer, but it saves in time because the patients don't come back. And interestingly, the Bell study also found not only were the patients dissatisfied with them, but the doctors were as well, when they also surveyed the doctors and found that the visits that the patients found to be satisfactory were also satisfactory for the doctor's perspective as well. Similarly, this is a UK study of GP patients. Very few of them felt able to address all their concerns, again, leading to unwanted and unused prescriptions and repeat visits and so on. Now, the third benefit of effective communication is actually from the doctor's perspective. Now, we know as a professional group that doctors have very high levels of stress and burnout, mental health problems, alcoholism, etc., etc. And so this one study of 27% of hospital consultants felt that they had evidence of mental health problems, and those were more likely to say that they had had insufficient training in communication skills, and they felt that it affected their patient care in the sense that they were quite robotic and feeling and remote from patients. And the Bailey study is an American Society of Clinical Oncology one, very interesting one, which looked at doctors' poor communication skills and thought that, so those doctors who felt that they were less able to talk about death and dying tended to continue to prescribe chemotherapy in the terminal phase of illness, which is, you know, a really interesting and kind of upsetting from the doctor's perspective, but a little other patients' finding. So the benefits, number 4, reduce complaints and litigation. I mean, Charles Vincent at Imperial College did loads of work on safety and risk and litigation. And in this particular study that I've quoted here, he looked at, he interviewed 227 patients who had actually taken litigation against doctors. And what he found was that it wasn't just the original injury. I mean, they wanted it not to happen again, and they wanted, but actually, what was more important to them was having a full explanation of what had happened, and really that the offence had been really, expanded by the insensitive way that the incident had been handled by the doctors, which is actually less about clinical malpractice and more about the communication skills. And this Ambadi study is absolutely fascinating. They interviewed surgeons talking with their patients, and they just used 10-second clips of the recordings. They played them to psychiatric nurses who were coding against criteria of whether the surgeons were warm or dominant and so on, or patient-centeredness in short. And they found that those patients who were more dominant and showed less concern, they cross-checked that against, they cross-tabbed it against the surgeon's history of complaints and litigation. They found that those that were more dominant and less warm were more likely to have had malpractice claims against them. And again, this is completely separate to their competence as surgeons. So really very interesting stuff. And my final one about the benefits of communication is that patients really love it. I mean, I say this to students, no patient ever said that doctor, their knowledge of anatomy was amazing. Their examination skills were fantastic, because they don't understand that stuff. And they expect you to know that. They expect doctors to be experts, rightly. But that interface between the doctor's expertise and the patient's experience is the clinical communication. So a couple of studies here. One showed the strongest predictor of a resolution of headaches. This is a big, I think, Canadian study from the 80s. So they went back to 1 year after a first complaint of headaches, and they found that the strongest predictor of the resolution or reduction headaches was that the patients felt that they'd been able to discuss their problems fully with a doctor at the outset. And this Mumford study is a review, but there are plenty of studies that, for example, there are studies that split groups into pre-surgical patients into controlled groups and enhanced communication groups, might say. And so one group gets the regular communication that the pre-surgical patients would get. One has more input in terms of doctors or nurses explaining the pain and what they can expect and so on. And then afterwards, when they look at the prescription charts, they find actually that the patients in the enhanced group used less analgesia. So there's really, really interesting studies out there. Now, the eagle-eyed amongst you will be thinking, but those studies are really, really old. And when I was preparing this presentation, obviously my first thing was to update them. And I thought, actually, I'm not going to update them, because the point I'm trying to make here is this is a really established body of knowledge that is growing all the time. I'm very keen for people to be scholarly and to engage with the research and read it and do their own research. So when I wrote the book, I also produced this web page associated with it, which is still there. That's the web address. And if you're interested in reading any of the references, on the third bullet point on that list, there's a link to all of the references to the paper. So if you can click straight through, if your organization subscribes to the journal, you can click straight through. But more interestingly, there's also the PubMed link. So you can click on the PubMed links and you can find who's been citing that paper. So if you're interested in, communication and compliance, adherence, patient adherence or something, you can go and find what more recent evidence of what people are researching at the moment. I would strongly encourage people to do that. And my point is that there is an evidence base. It has been there for a long time. It really is very established. And I would encourage people to engage with that. So I come to the last point of my presentation, which is about how do we put this into practice? How do we move away from a curriculum that is perhaps too focused on the medical history, and the medical history is still there, the diagnosis is still there. Obviously, doesn't need to be, it's not supplanted by anything else, but within that, it sits within a discussion with a patient, a negotiation of people. How do we move towards that? Now, I've been talking for a good 25 minutes, and I just want to pause for a moment and get you to think. Now, I want you to think of something that you know you can do really well. It might be something professionally, it might be reading MRI scans, or it might be something out of work. You might play a musical instrument or play sport or anything, shopping. It doesn't really matter what it is, but just something that you know that you are really good at. And I want you to think about how you became good at it. So if you can just hold that thought for a minute. So you've got this thing that you were really good at it. How did you know you became good at it? You might want to write that down. And now I want you to think about this thing, and I want you to think about how you know you are good at it. Yeah, so you've got something in your mind that's something you think, I know I'm good at that. How did I become good at it? Okay. And how do I know, what made that thing pop into my mind in the first place? Have you got it, hopefully? Now, obviously, if I were in a room with you, I would get you to write this on a piece of paper. But from doing this exercise with groups of doctors over the years, I think 90% of them will say, whatever it is, you become good at something by practicing it. And if you ask them how they know they're good at it, it's because people gave them feedback and told them when they were becoming good at it and how to become good at it. So you see where I'm going with this. Their practice and feedback are absolutely, at the heart of this. I think they're at the heart of all learning, to be frank, but particularly in this case. This is not something that you can write essays to show that you're an effective clinical communicator. You really need students need to practice it, and they need to, the way that you assess it is that you watch them doing it, either in real situations or in simulations. The other thing is that it is a really, really difficult thing to do, and it comes more naturally to some people. I think of thousands and thousands of medical students I've seen doing simulations, working with real patients. Some of them clearly are more empathic, they're more expressive, they're just more natural than others. But it is something that anyone can learn. I'm really convinced of that. But they need a safe place to learn it because it is really hard, particularly to do simulations in front of their peers and so on. So I think the tone of the feedback, particularly the formative feedback, should always be to hold their hands and walk with them and to build their confidence and nurture their professionalism while they develop their own professional voice, which will be authentic to them. Now, in turn, I think the faculty delivering that training similarly needs to be supported and really have kind of specialist help and support, particularly if they haven't been taught this way themselves. It's just too much to ask people to say, run a simulation if you've not been trained that way yourself, and if you've never done it before. You need some real hand-holding for the faculty as well. And I would say any faculty doing this kind of training for the first time is going to have concerns. I mean, I take my own journey with this subject. I started teaching groups of medical students around 2001, and then, as I said, got my first substantive teaching post just doing teaching clinical communication at UCL in 2003. And in those early days, I was very, very uncertain of it. I didn't like role-playing myself. And I think the thing about students is they really pick up on the mood in a classroom. And if they feel any hesitation, that you will transmit that. So they really need to be, they really need to have a teacher that's really, really enthusiastic about it. An enthusiast, a champion. And so what I would suggest is to identify a group of faculty that are really, really enthusiastic about experiential learning, and get them together. And really, those people that are really reluctant about it, who don't think it's all that, or people will quite often say to me, well, no patient ever died from a doctor being rude to them. But the other things are much more important, the anatomy and the pharmacology and all the other things that they have to learn. And I don't actually agree with that, even on its own terms. I can imagine, I can tell you stories of loads of patients who went to a doctor who was rude to them, and they didn't go back when they should have gone back, and soon enough they're overtaken by events. So I think go with the enthusiasts, the people who really are keen to do things differently. And take them out of work for at least a couple of days, because you need some space outside of work to really think through these issues for yourself. As I say, I was very reluctant. I came to love role play just because I saw how amazing it could be. I mean, I can tell you so many stories. I've seen medical students, doing simulations with actors, and the students afterwards would actually be shaking, with the emotion of it, and they'd say in the feedback afterwards, they'd say, "Look, I knew that was all pretend. I knew it wasn't real. I knew it was just an actor, but the emotions were still there." And you think, well, that is what experiential learning is, and you kind of it's almost like developing a negative. You expose them to that in medical school, so that when they do it in real life, it's like developing that negative, and they're able. It's there somehow, and they're able to put it into practice. And it doesn't matter if they make mistakes, because it's not a real patient. It does matter if they make mistakes when it's with real patients. So I think in this training, we need to get all those concerns out on the table, and give the faculty opportunities to work with role play and working with simulated patients in ways that they will do later with the students. And the great thing about this is that you can actually rewind. If you've got a simulated patient, it's a standard session. You would say, you've got a simulated patient, and you say, okay, this patient has, shall we say, a suspicious mole, and you're concerned that it could be melanoma, and you're going to refer them. So before you call the patient in, you have a discussion with the students. So you've got about 8 students there. How would you tackle this? What would you say? What do you need to find out? Maybe they get their phones out and look up the information. And when one of them volunteers, they call in the patient, and let's imagine it goes disastrously wrong, and the wheels come off, and they just make a complete mess of it. You can say, okay, time out for a minute. Let's stop. Patient, just be quiet for a minute. What might you have done differently? And you get them to discuss in the group what went wrong, and how they might do things differently next time. And then you can rewind to the point where you say, okay, let's go back to the point where you said, I think I'm concerned about this mole, and see where it goes if you take it a different direction. And God, if only life were like that, you could actually rewind and replay things. But it's a really safe opportunity. But it means that that's quite a tricky thing to do as a teacher. So people need to practice with it before they practice with students. The other thing I think that is really great to do is about writing scenarios for teaching and assessment. So obviously the learning outcomes for the teaching are aligned with the assessment, right? So I very strongly feel that there's nothing wrong with, say, if you've practiced an hour in a teaching session, later to say, okay, that's the assessment. So you could use the suspicious mole one, and you think, well, that's a really fair assessment because they've had a chance to discuss it. They've seen somebody else having a go at it, even if they haven't had a go themselves. If that comes up in the final OSCE, that's really great. So I'm really keen to really align the teaching and assessment so it's really transparent for the students. And also, I think the formative feedback really here is the most important part of it. And so as part of this whole training, I think they need to write the scenarios think about delivering the training, think about what kind of feedback they're giving formatively in teaching, and then also think about how you would summatively assess this. Because what we want to write into the summative assessment criteria is things like, are they making empathic comments and so on. Now, just a couple more slides. So, formative assessment.
Time is up, Peter. Thank you.
In the teaching,
can you give us a summary, please?
This is a supportive environment where you're really helping them. Weaknesses, mistakes are just a starting point. They're not a sign of failure. The students, and this comes back to questioning medical authority. I mean, they should be able to question each other and question their teachers and try out different things. As I say, it's a safe place. It doesn't matter if they get things wrong, if things go horribly, pear-shaped, they can still rescue it. I think we ask a lot of medical students. They are young. I mean, what 20-year-old has really thought through their own death? Not many, I would have thought, unless they've really had some terrible experience happen to them. And I think quite often they're thinking through those issues as they're working with patients, which is not really fair on them or the patients. So I think this is also an opportunity to give learners just the opportunity to talk through the emotions that they have. Where else do they get it in the curriculum to explore these kind of issues?
Can you hear us, Dr. Washer?
Yes.
Can you
I'm
hear
just
us?
about to finish. Yeah. I've got one more slide. So some final thoughts. It's a serious subject, vitally important to medical practice. There's an evidence base. Medical teachers need to be role modelling their enthusiasm for this subject, and we need to move beyond simple history taking. And the diagnosis is part of it, but the process is really important as well. And at that, I will stop. Thank you very much.
Thank you very much. Actually, I would like to thank all the three speakers for their very interesting speeches, and for the audience to be very patient with us, because to have a continuous 120 minutes presentation, I'm sure it is a very big challenge for all the brains here, but I can see the faces are still awake and they are interested, and I think one reason for this is our marvelous speaker, they made it very intriguing and very interesting. Now we come to the period of discussion, open discussion for the floor, and I will ask my colleague Dr. Mona to lead the discussion period with all the three speakers, and the floor is open for that for the next 20 minutes.
Yeah, we come to the conclusion of the first session, which was a very rich session. We had three eminent speakers. The first topic, I just remind you, was Prof. Lambert Schurth on programmatic assessment tips for application. The second speaker was Colin Greengrass, and the topic was about how to design a curriculum towards clinical reasoning. The third talk was about the science and art of communication skills. So please, if you have a question to any of the three speakers, just go ahead. Yes, please. Please.
Thank you very much for the three speakers. Let me direct my question to Professor Lambert. I know the assessment is a quite challenging topic in undergraduate education. Now, what I can understand from your talk, that although it is really difficult to judge on the learning outcomes out of the program or the course for the students, and sometimes it's not fair to just pass the students, although some areas it's not really achieved out of the program because the performance of the students maybe it's not up to that level. My question is, do you recommend to go for the grading system or just pass or fail in the undergraduate? Because I guess that pragmatic system goes with the pass or fail. Thank you.
Yes, thank you very much. I think that's an incredibly important question. Can I draw it a tiny bit bigger than that? Because when we grade or score students, we actually force that complex competence onto a single scale. And what you produce then is what is called a deficiency model. So you've got a scale, let's say you want to achieve 100% competence. John has 80%, Jim has 76%, so Jim is 24% defective or deficient and John is 20% deficient. If you use a pass-fail, but with the richness of all that information, then you can assume that John is ready to progress to a next phase and Jim is ready to progress to the next phase, but with a different set of strengths and weaknesses. Compare it to working as a clinician. If you're a hospital clinician, at one point in time, you have to decide whether your patient is ready to go home, yes or no. But you wouldn't do that with a measurement scale. What you do is you have the rich story of your patient. You say, well, both patients can be discharged, but this patient I want to see back in a week, and I want to continue the treatment with antibiotics. And this patient I want to see back in 2 weeks or 3 weeks, and they're on a regimen of NSAIDs, for example. So thinking about assessing competence in the same way as you think about assessing the health of your patient is the analogy that works. You wouldn't rank your patients, so you wouldn't rank your students. That's the philosophy. So thank you for the question.
Second question, yes, please.
Thank you very much, Dr. Greengrass.
Can you please introduce yourself?
I'm Mohammed Al-Na'mi from King Saud University. I'm very pleased to be joining this conference. And my question directed to Dr. Greengrass. It was interesting to link the neurophysiology to the teaching, learning, and assessment, as well as curricula. However, really we need your opinion regarding educators, how they can revise their curricula to delete some of the unnecessary information or maybe topics, especially with the availability of technology, that knowledge is accessible by just pressing a button. So what do you think we should do to revise our curricula on this regard? What are the areas and what is important to consider? Thank you.
Thank you very much indeed. That's a very good question. I mean, there's a shortcut, and the shortcut would be to take the common clinical cases which your students, your graduates would be expected to experience, and go back through the curriculum to see what is covered which isn't really related to those cases at all. That's very much a shortcut, and that's more or less how people do things, I think. But the more sophisticated way would be, as I described, to build up the curriculum through a series of concept maps, interrelating everything really within the curriculum, and then trim it back, then do that streamlining. Because what that would really, it would do more than just removing, it would also minimize content. So if we're trying to do that in a way which is not really organized systematically, we may miss things which should have been, which are not a component of that particular case, but they're a kind of subcomponent of case you do need to cover. By doing it systematically through that series of concept maps, It's like a fail-safe in that way, that you'd be looking at it for the whole time. You'd be looking at it from the point of view that you'll be streamlining it through a map, so retrospectively going back through the curriculum and streamlining it. So in short, there's an easy way, there's a shortcut. You just look at what is not covered in those cases, which your students will be expected to cover. The long way around, the more effective way of doing it, is a systematic approach of building up those concept maps and then streamlining it backwards retrospectively. I hope that made a bit of sense.
So, Colin, what is the closest existing curriculum to the curriculum you're describing?
I wouldn't say there are many, to be honest. There are courses, there are modules which are designed. I mean, certainly I design my modules very much with that in mind. We have a map, a concept map, which describes everything in the neuroscience module. And it's working very much with that ethos in mind. And also addressing some of the prerequisite sciences which are required for understanding of the area. An entire curriculum. Universities hold on tightly to their curricula, so you can't really see exactly what's going on in any curricula. But there's not a great deal of to have an entire curriculum based on that is rare, is very rare. Individual modules, yes, but an entire curriculum is rare.
Thank you. There's one question here, please. Can you have the microphone?
Thank you very much, Ali Shehri. It's really a pleasure to be with you, and thank you, distinguished speakers, for intriguing, as the chair of the session said. And we are really happy to have this gathering after COVID. So I take this opportunity to thank the organizing committee, particularly Dr. Abdulaziz and Dr. Mina, for a well done job. It's very, very important topics we have discussed here, or you presented: assessments, curriculum, and communication. As you have indicated, assessment determines learning, whether it's deep or superficial. But as Lambert said, that in assessments, the sum of parts do not equal the whole. So my question here for Lambert, is there a role for technology, particularly artificial intelligence, and sorting that issue? And it fit well with Colin's presentation and very complex curriculum schema. I like the schema, which is a systematic, structured way of enabling our students to think systematically and structurally. But also it's pose questions of validity, reliability, generalizability. So back to you. Maybe this question relates to the three speakers. Thank you.
Do you mind if I give it the start? Because I think absolutely. What we tend to do is, if we want to collate and synthesize information, we're looking at things that are obvious to us. And I won't talk about schemata. Colin knows a zillion times more about this than I do. But we look with our scripts and our schemata, and we look for things that we can connect. But if you talk about learning analytics, for example, you get a different way of connecting information. The risk or the danger in that would be just trusting the learning analytics and leaving out human judgment. And I think when you combine learning analytics and you combine human judgment and you extend the number of possible patterns that you can see in the development in the competency domains, you actually have a complementary system. There's one other thing that, and we're currently working on with an industry partner, we're working on that, is having a system where you enable the clinicians, for example, in a clinical placement, to quickly record their feedback, their observations, and what have you, and to automatically collate that. So where you can use your learning analytics or your AI approaches to pre-sort that, have the learner synthesize and triangulate and make meaning of the patterns themselves, and then discuss with a coach, a mentor, or a supervisor. That would be my ideal situation if I had time and money enough.
Colin, do you have any comment?
Yeah, I mean, I think from an assessment point of view, it's very valuable indeed, because you can certainly generate a profile of a particular learner in regard to their performance across multiple facets. So that's fantastic. In respect of using machine learning to generate a curriculum, might be easier to do it using human beings, to be honest. It would be difficult to have that running. Possible, but I think that the human being would do better.
Doctora, can I ask?
Yes, please.
I do have a question here. I think one of my colleagues, Dr. Al-Na'mi, raised an issue regarding deleting or adding to curriculum and the changes. I would make the question even bigger. I know there is many medical schools, they are changing the story of changing their curriculum. And this can be a very devastating experience. This can be a very devastating experience regarding resistance, the way to do it, the best way to do it, and I'm sure it's a common concern among all medical schools. This is an open question for all our speakers here. Do we have a magic prescription that you can tell us some secrets how to make these changes doable in a reasonable time and successful with the minimum victims down the roads?
I could go ahead on this one, maybe. Yes, I have the experience. And in Saudi Arabia also, introducing these concepts into some of the universities which I collaborated with and worked at. I think it does work. Certainly if you're having a systematic approach, you get people on board. If it's based on mere opinion, taking ideas out of the ether, and it's difficult to get people on board. So having that systematic approach can carry people with you. Of course, there's always resistance, and there are people who have their pet subjects which they love to teach, but they're not really that relevant. Well, in that case, the system has to drive the curriculum reform process rather than individual preferences, and you have to be a little bit strict in that respect.
Just make one comment. If we adopt this scheme-based curriculum or illness script-based curriculum, don't you think that it will align best with an assessment format like the script concordance? Because you have made a very nice, important comment that if we design the curriculum towards clinical reasoning, and if we implement it properly but assess superficially with a very low taxonomy, then probably we are not achieving the target.
Yeah, I mean, I certainly think it would be a valid approach to use script concordance testing. I think there are ways, I mean, lower down in the curriculum, at lower levels in the curriculum, we would be aiming towards that. We'd have a lot of conceptual system-based questions. Occasionally, of course, you do need just facts and figures which are explored and assessed. But I think we over-egg that one. We use that far too much. So yes, script concordance, but that's at the higher level in the curriculum. It's not at the earliest levels. But you would prepare for that with similar types of questions, problem-solving questions, prior to that.
I think, Lambert, you were shaking your hand, so I'm sure you have a comment. Go ahead.
Yes, and I mean, in assessment, we tend to make a distinction between clinical decision-making and clinical reasoning. And if I'm being a bit facetious, I would say that the issue of assessing clinical decision-making has been solved in the late 1990s, early 2000s with key feature approaches, extended matching, etc. That is, research shows that the cognitive operations when having to deal with the problem and having to combine that information are fundamentally different to a just factual knowledge. But people were still unhappy with that. And especially Bernard Charlin was unhappy because he said, you're not capturing the process and you're not capturing the complexity of the process. The dilemma that script concordance test phase and that Bernard faced is the fact that the stimulus in the script concordance test actually is derived from a complexity narrative where the process is creative and divergent. But the outcome, the scoring, is from a more linear process and convergent. And therefore, there is a mismatch between the way you evaluate and score or reward the outcome and the way you stimulate the outcome. What we've come to understand, and that's not criticism of the work of Bernard Charlin, because that was the thinking in that time. What we've come to understand is that clinical reasoning, if you talk about it as a creative process, is managing a complex adaptive process. And to use an example, there are many randomized controlled trials on drugs, and that fits very well in a linear process. But there are no randomized controlled trials on history taking. What should you say at 2.2 minutes and 30 seconds? Because that is an interactional complex process. So what we've come to understand in assessment, that if you want to assess these complex adaptive processes, these creative processes, there are multiple ways of solving the same situation. Therefore, it is having multiple solutions rather than one single best solution. It is about the situational awareness and the recognition of boundaries. And that's where human judgment and fairness have come back into assessment. And I think that fits seamlessly with Peter's talk.
Yes, thank you.
Can I I was just going to say, in terms of managing change, faculty development for that, I think I said in my talk, go with the enthusiastic, the champions first, but when you need to get everybody along with you, I think you need to give people an opportunity to let off steam and to really lance a boil. You know, if they are really keen on what they're doing at the moment and they don't think that the change is necessary, I think, you know, sometimes as a facilitator in those sessions, you just need to stand there and just let people say their piece and then say, hang on a minute, no, what are the problems? What is the problem we're trying to solve here? And then move forward. I think the last thing you want to do is have reluctant people thinking, well, I'm actually going to change because I think things are okay as they are. So yeah, I would say, obviously, you know, the enthusiastic people will be hopefully like ripples in a pond. But when you need to get everybody else along with you as well, just give them an opportunity to say their piece and then say, okay, and this is why we need to change. You know, show them that it's not change for change's sake, and then you hopefully will move forward with everybody.
Go ahead, please.
Thank you very much, and thanks for the organizing committee for this well-prepared conference. And thanks for all the speakers for the elegant presentation today. We enjoy it much. And my direct question to Professor Lambert. As far as we know, in order to ensure...
Can you introduce yourself, kindly?
Sorry, Dr. Karim Eddin, University of Bisha, College of Medicine, Pediatrics and Medical Education Department. So directly, Prof. Lambert, we know that in order to ensure a valid, reliable assessment, you need to link and to align the outcome with the assessment and even with the learning tools. So do you want to stress on this fact, or as far as I understood, you are going to say performance of any one of the aspect of assessment will anticipate the performance on the other assessment. For instance, a good performer in OSCE is going to perform better in MCQ and SE, or what do you mean? Can you clarify it to me? Thanks again very much.
Thank you for the question. Yes, unfortunately, the literature is quite unanimous and quite contradictory or quite counterintuitive. So as long as the content is the same, correlations between assessment formats are incredibly high. I'm not saying that every content fits every format. So if you present a case to a student and you want them to spontaneously diagnose a masked depression, a multiple choice option or multiple choice question clearly is not going to cut it. But adapting the format to what you try to ask is better than adapting what you want to ask to a format, or believing that multiple choice questions are better or worse than open-ended questions. The literature, unfortunately, doesn't say so. And the example I used with the diabetes mellitus and the history taking and the physical examination shows that rather than saying your sodium level is too low and your glucose level is too high, so because those are both lab tests, we're going to average them, it's much more useful to look at pieces of different information and construct that meaningful schema, narrative understanding. And that's counterintuitive. And that is going to be a big problem in implementation because, as Stella Wozniacki researched, looked at our naive beliefs about how the world works, we are used to thinking about what is good education based on our own experience in education. But for me, that's 40 years ago, and we don't practice medicine we did 40 years ago. So why would we consider practicing education like we did 40 years ago? So the literature is sometimes contradictory to what our experiences are, what our beliefs are. And the question is, do we accept the evidence in the literature or do we continue our beliefs?
Lambert. There's another question. Yes, go ahead, Prof. I'll come to you, Dr. Adif. Just one question before.
عمر الفكي الريان Medical Colleges المدينة المنورة. My first question is on communication. And it's about the role of language in communication. What do you think? Is there any negative a role in medical students being graduated on studying by not their mother language, by a foreign language, and at the same time, of course, practicing with their people in the same community? And on the other aspect also, if these graduates are grown by or educated on their same language, mother tongue language, and they
Dr. Ammar, if you can make it short because we have to stop in 1 or 2 minutes because there is a ceremony going on. So just make it quick and we need a quick answer.
So the role of language, both sides, on the graduates not being...
Yeah, question is clear.
And the question is clear. And the
you,
other
Dr.
is in the assessment.
If you can answer, Peter.
What is the new added value of programmatic assessment, which is already added on a well-recommended assessment for medical education going for years, aligning all the things with aligning with the different learning outcomes and this. So what is really new? Thank you very much.
Okay, I'll answer very quickly. I don't really feel like I'm qualified to talk about learning in a second language. What I would say, though, is that, I live in Germany at the moment. All undergraduates are expected to speak English because the textbooks are not translated, and that's in any subject. So I think, when we talk about in a foreign language, we're talking about English, and I think maybe we just need to think of that as the lingua franca for research and scholarship. There is obviously a different issue about talking with patients, but I think the important thing, you've got Arabic-speaking patients with Arabic-speaking doctors, and so I think the language of instruction is hopefully will not impact that negatively.
I think we are coming to the end of the discussions because we have to abide by the time. I would like to thank all the speakers and all the audience for this excellent presentations, excellent active participations. And I guess we have to conclude at this moment to finish the first sessions today. And I think the rest of the program with the program directors that there will be some opening ceremony at this time. Thank you very much for everybody. Thank you.
Thank you.
Thank you very much.
Thank you.
بسم الله الرحمن الرحيم.
طه ما أنزلنا عليك القرآن لتشقى إلا تذكرة لمن يخشى تنزيلا ممن خلق الأرض والسماوات العلى الرحمن على العرش استوى له ما في السماوات وما في الأرض وما بينهما وما تحت الثرى وإن تجهر بالقول فإنه يعلم السر وأخفى الله لا إله إلا هو له الأسماء الحسنى.
بسم الله الذي جعل في أول تنزيله باب الحياة ومفتاحها بالمعرفة والحث لها، والحمد للذي بانت جمائله واستبانت بلطيف حسنها جمائله، والصلاة على من بين فضل العلم ومن حمله، أذن للفرح أن يكون للبشرى رفيقا ومصاحبا، حمدا يليق بذات الروح واستبشارها وبكل معاقل اللغة واستعلائها على واستعلائها على رقاب القوافي يقف الفؤاد عاجزا عن إيضاح شعوره وانتشائه في وقفة للعلم والمعرفة التي تنبع من القمم بين أهل الشيم والقيم، وبقول أهل الجنة بعضهم لبعض: السلام عليكم ورحمة الله وبركاته، برعاية من صاحب السمو الملكي الأمير تركي بن طلال بن عبد العزيز أمير منطقة عسير حفظه الله، للمؤتمر السعودي الدولي للتعليم الطبي في هذا اليوم البهيج. سعادة الأستاذ محمد بن سلطان بن جريس وكيل إمارة منطقة عسير، معالي رئيس جامعة الملك خالد الأستاذ الدكتور فالح بن رجل الله السلمي، معالي رئيس جامعة الحدود الشمالية الأستاذ الدكتور محمد بن يحيى الشهري، أصحاب السعادة وكلاء الجامعة، أصحاب السعادة عمداء كليات الطب في الجامعات السعودية، أصحاب السعادة أعضاء هيئة التدريس، أيها الحفل الكريم، عندما تنفتق الكلمات وتبدي من خواف شعورها أنغاما بكم يا قادة العلم والتربية، وتقول لكم بكل حب وعرفان: مرحبا ألف، وحللتم أهلا ووطئتم سهلا. وبعد، هناك أياد بالخفاء تعمل لنهضة وتقدم، وها هي تترنم كحمام الأيك نشوانه. كلمة لرئيس الجمعية السعودية للتعليم الطبي ورئيس المؤتمر سعادة الدكتور عبد العزيز العمري.
السلام عليكم ورحمة الله. الحمد لله وكفى، والصلاة والسلام على المصطفى. سعادة وكيل منطقة عسير الأستاذ محمد بن سلطان بن جريش، معالي الأستاذ الدكتور فالح بن رجل السلمي رئيس جامعة الملك خالد، معالي الأستاذ الدكتور محمد بن يحيى الشهري رئيس جامعة الحدود الشمالية والرئيس المؤسس للجمعية السعودية للتعليم الطبي، أصحاب السعادة عمداء كليات الطب المملكة، أصحاب الفضيلة والسعادة، ضيوفنا الكرام، السلام عليكم ورحمة الله وبركاته. يأتي انعقاد المؤتمر السعودي الدولي للتعليم الطبي SIMEC متزامنا مع الذكرى العشرين لتأسيس الجمعية السعودية للتعليم الطبي، حيث تأسست هذه الجمعية العلمية في العام 2002 ميلادي في كلية الطب في جامعة الملك خالد، والتي ينعقد مؤتمرنا هذا العام تحت مظلتها. وقد لا يكون من الخطأ القول بأن أبها عاصمة التعليم الطبي. اليوم يعود مؤتمر SIMEC من جديد ليعقد في أبها بعد انعقاده في عدد من الجامعات السعودية خلال السنوات الماضية، ولذلك نعتبر هذا الحدث فرصة مناسبة لمراجعة التقدم التي تم إحرازه إلى الآن، وأيضا نتذكر ماضينا وما بذله مؤسسو الجمعية وقياديوها من جهود كبيرة في خدمة التعليم الطبي من خلال هذه الجمعية. ضيوفنا الكرام، يعد هذا المؤتمر أكبر تجمع علمي في مجال التعليم الطبي على مستوى الشرق الأوسط، وسوف يناقش بشكل أساسي التطورات الأخيرة والأبحاث المتعلقة بالتعليم الطبي، ومنها مواضيع الابتكارات في التعليم الطبي، اتجاهات المناهج الحديثة لكليات الطب، تطوير مهارات الأكاديميين، التحديات والفرص المتعلقة بالاختبارات والتقويم وغيرها. كما أنه من الجدير بالذكر أن المؤتمر في هذه النسخة سيركز على مواضيع التعلم عن بعد، خصوصا بعدما أخذ هذا الجانب مكانة مهمة خلال الجائحة العالمية، وسيتم تبادل الخبرات وتبادل الآراء والتوصيات حيال هذا الموضوع، بالإضافة إلى مواضيع أخرى تخص القيادة الأكاديمية، التدريب السريري والتعليم المهني. أيها الحفل الكريم، استقبلت اللجنة العلمية للمؤتمر أكثر من 300 بحثاً علمي في مجال التعليم الطبي، وقد تم قبول 250 منها للتقديم والمناقشة والطباعة في كتاب المؤتمر. وبلغ عدد المسجلين في المؤتمر إلى الآن أكثر من 2000 مسجل، كما أن اللجنة شرفت بمشاركة أكثر من 20 متحدث من خبراء التعليم الطبي في الوطن وخارجه. تجدر الإشارة إلى أن المشاركين والمسجلين في المؤتمر ينتمون لأكثر من 30 دولة حول العالم، مما يؤكد مكانة هذا المؤتمر على المستوى المحلي والدولي. ضيوفنا الكرام، مما يزيد مؤتمرنا هذا تميزا وتألقا هو حضور أصحاب السعادة عمداء كليات الطب المملكة، حيث سيعقدون اجتماعهم الدوري 51 وسيسهمون في إثراء المؤتمر بآرائهم وخبراتهم ونقاشاتهم بلا شك، ومن ثم سيدعمون النتائج والتوصيات بنقلها إلى جامعاتهم المختلفة تفعيلا وتطويرا. كما أن مما يميز هذا المؤتمر في هذه النسخة هو إطلاق مسابقات مختلفة بجوائز قيمة في مواضيع مختلفة، منها مسابقة كتابة المقال الطبي للطلاب والطالبات، وقد تم استقبال 90 مشاركة، ومسابقة الكتاب المنشور في مجال التعليم الطبي، ومسابقة التميز البحثي في التعليم الطبي. لا أود أن أطيل عليكم، أود أن أشكر كل المشرفين والعاملين واللجان المختلفة التي اجتهدت كثيرا لإقامة وإنجاح هذا الحدث المهم، وعلى رأسهم معالي رئيس الجامعة الأستاذ الدكتور فالح بن رجال السلمي، الذي حرص دائما على تدليل كل التحديات ومنح هذا المؤتمر اهتماما خاصا يذكر فيشكر. شكرا لك معاليكم ولمعاليكم كل الشكر. كما نرجو من الله العلي القدير أن يحقق أهداف هذا التجمع العلمي الكبير، وأن تتم الاستفادة القصوى مما يطرح فيه، وأرجو لكم إقامة طيبة في أبها البهية، والسلام عليكم ورحمة الله وبركاته.
وقمرة تلتقط من أبهى الصور أجملها، فيلم تعريفي عن الجمعية السعودية للتعليم الطبي وأهدافها.
بمناسبة مؤتمر التعليم الطبي في هذا العام 2022 أن أستذكر مع زملائي في اللجنة التأسيسية وفي مجلس الإدارة الأول في مرحلة التأسيس الأهداف الطموح الذي كنا نملكه لاتجاه هذه الجمعية الوليدة، حيث أن الاجتماع الأول والثاني كان في أبها منذ ما يقرب من 20 سنة تقريبا، ثم كان الاجتماع الخامس في مدينة الملك فهد الطبية في كلية الطب. وفي تلك المناسبة تم استخدام اسم سايمك لأول مرة.
شرفت كلية الطب بجامعة الملك خالد بأن تكون الحاضنة والراعية لفكرة إنشاء الجمعية السعودية للتعليم الطبي منذ عقدين من الزمن، وذلك عندما رأى نخبة مباركة من المهتمين بالشأن التعليم الطبي ضرورة إنشاء هذه الجمعية التي تهتم بكل ما يخدم التعليم الطبي وتطويره. وهذا ما أكدته جامعة الملك خالد بدعم هذه الجمعية وتحقيق أهدافها. كما أن كلية الطب تعتز كثيرا بأنها كانت المنطلق لعقد اجتماعات لجنة عمداء كليات الطب في المملكة العربية السعودية عندما لم يكن هناك سوى 4 كليات طب. وها نحن اليوم نشهد وبسعادة غامرة افتتاح المؤتمر السعودي الدولي للتعليم الطبي، وكذلك الاجتماع الدوري 51 للجنة عمداء كليات الطب في المملكة. هذه اللجنة الرائدة التي أخذت على عاتقها الكثير مما يهم شأن كليات الطب وتحقيق التعاون المستمر والمثمر والنهوض والتميز في مجال التعليم الطبي وتبادل الخبرات الأكاديمية في مجال التعليم الطبي والاستفادة من التجارب الناجحة.
ويأتي انعقاد المؤتمر السعودي الدولي للتعليم الطبي SIMEC 2022 متزامنا مع الذكرى العشرون لتأسيس الجمعية السعودية للتعليم الطبي، حيث أنها قد تأسست في عام 2002 ميلادي في جامعة الملك خالد في أبها. والجدير بالذكر أن من أهم المواضيع التي سيناقشها المؤتمر في هذه النسخة هو موضوع التعلم عن بعد، خصوصا أن هذا الموضوع قد أخذ حيزا كبيرا واهتماما بالغا خلال الفترة الماضية، فترة الجائحة العالمية، ولذلك ما سيصدر من نتائج وتوصيات في هذا الموضوع سيؤخذ بعين الاعتبار في رسم مستقبل التعليم في الوطن واستراتيجياته بإذن الله تعالى.
أيها الحفل الكريم، والآن مع تدشين الشعار الجديد للجمعية السعودية للتعليم الطبي والمجلة السعودية للتعليم الطبي. أيها الجمع الكريم، إن آيات النسج أوضحت عن بهاء معانيها، وكأنها العقود المنظمة، بانت مشاعر سارت بها الركبان، فكانت بيانا لأفكار الروح في سوانح الوقت واتقاده. كلمة لمعالي رئيس جامعة الملك خالد الأستاذ الدكتور فالح بن رجل السلمي.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على خير الخلق محمد بن عبد الله وعلى آله وصحبه وسلم. صاحب السعادة وكيل إمارة منطقة عسير الأستاذ محمد بن جريس، أصحاب المعالي والسعادة، ضيوف الجامعة الكرام في المؤتمر السعودي الدولي للتعليم الطبي ولجنة عمداء كليات الطب المملكة، الإخوة والأخوات، الحضور الكريم، السلام عليكم ورحمة الله وبركاته. وأرحب بكم في جامعتكم جامعة الملك خالد. نسير جميعاً بخطى واثقة لتحقيق رؤية بلادنا الغالية وتعزيز الحضور العلمي والبحثي في أحد أهم المجالات، وهو التعليم الطبي الذي يعد جوهر العملية التعليمية والمهنية للمتخصصين في المجالات الطبية، مستلهمين العمل والعطاء في هذا الوطن المعطاء والدعم اللامحدود من قيادتنا الرشيدة بقيادة خادم الحرمين الشريفين الملك سلمان بن عبد العزيز وسمو ولي عهده صاحب السمو الملكي الأمير محمد بن سلمان حفظهم الله. أيها الأخوة والأخوات، يحظى هذا المؤتمر برعاية كريمة من سيدي صاحب السمو الملكي الأمير تركي بن طلال بن عبد العزيز أمير منطقة عسير ورئيس هيئة تطوير المنطقة حفظه الله، في سياق اهتمامه الدائم ورعايته المستمرة لكافة برامج الجامعة. ونسعد بانعقاد المؤتمر ووطننا يرفث في ثياب العز والسودد، ومشاريع التنمية تتوالى، ومنطقتنا منطقة عسير تتطلع إلى مستقبل مشرق بعد إعلان استراتيجية تطوير منطقة عسير. وجامعتنا جامعة الملك خالد بدأت في الانتقال إلى مدينتها الجامعية الجديدة. كما يشرف المؤتمر بمشاركة نخبة متميزة من العلماء في مجال التعليم الطبي، ولا شك أن المجال الطبي من أكثر المجالات حاجة إلى وجود مثل هذه الفعاليات العلمية والبحثية والمؤتمرات باستمرار، نظراً لما يستجد فيه من تطورات علمية ومهنية. ولا شك أن أصداء المؤتمر التي حققها بعد الإعلان عنه والتي لمسناها تعكس مدى أهمية والحاجة إلى إقامة هذا المؤتمر. أيها الحضور الكريم، إن الاهتمام الكبير الذي توليه وزارة التعليم ممثلة بصاحب المعالي وزير التعليم الدكتور حمد بن محمد آل الشيخ، ومعالي نائبه للجامعات والبحث والابتكار الأستاذ الدكتور محمد بن أحمد السديري، للعملية الأكاديمية والتعليمية والتركيز على جودة المخرجات أحد ثماره انعقاد هذا المؤتمر. وإن موضوع المؤتمر بما يتناوله من بحوث وأوراق علمية حول مجالات تطوير المناهج والخطط واستراتيجيات التعليم وطرق التدريس ووسائل وتقنيات التعليم وبرامج التطوير في هذا المجال ونحوها من المحاور، وهي ركائز أساسية في مجال التعليم الطبي، ولها انعكاساتها الواضحة والمهمة في جودة مخرجات نوعية تحقق أهداف التنمية ورؤية المملكة العربية السعودية 2030، وتعزز النجاح في المجال أو الميدان الطبي والمهني. أكرر الترحيب بكم جميعاً في جامعتكم، وأشكر الجمعية السعودية للتعليم الطبي وكل من كان له دور في إقامة هذا المؤتمر من اللجان والجهات بالجامعة والمتحدثين في هذا المؤتمر من داخل وخارج المملكة. كما أشيد بالحضور الفاعل لطلاب وطالبات كلية الطب وإسهامهم في تنظيم المؤتمر مع بقية الجهات بالجامعة، وأدعوهم وبقية زملائهم في الكلية والكليات الطبية والصحية الأخرى إلى تحقيق الفائدة القصوى من هذا المؤتمر. والشكر موصول لجميع من حضر من مختلف القطاعات والجهات، والسلام عليكم ورحمة الله وبركاته.
أيها الحفل الكريم، وإن من حسن شكر المعطي في جزيل الكرم والإغداق الشكر لمن عمل وقدم تكريما لأولئك الذين تفانوا فيما قدموه. يتقدم سعادة وكيل إمارة منطقة عسير ومعالي رئيس جامعة الملك خالد ومعالي رئيس جامعة الحدود الشمالية لإضفاء العطاء لمن يستحقه، فليتكرموا بالشكر محفوفين. أولاً، مؤسسو الجمعية السعودية للتعليم الطبي ورؤسائها السابقون الأستاذ الدكتور محمد بن يحيى الشهري، الأستاذ الدكتور سعيد أبو عشي، الأستاذ الدكتور محمد الحمراني، الدكتور سمير خير الله، الأستاذ دكتور عدنان مرداد. الأستاذ دكتور عبد المنعم الحياني. الدكتور سعيد الأسمري. الأستاذ الدكتور خالد بن عبد الغفار آل عبد الرحمن. الدكتور خضر الزهراني. الأستاذ دكتور حسن الزهراني. الدكتور طلال المالكي. الأستاذ دكتور إسماعيل بن جالية. الأستاذ دكتور عبد العزيز بو بكر. الأستاذ دكتور علي بن محمد آل بن علي. الدكتور خالد با حمدان. الفائزون بجوائز المؤتمر: جائزة الجمعية السعودية للتعليم الطبي لأفضل كتاب منشور. الفرع الأول جائزة النسخة الإنجليزية، الدكتور أحمد إبراهيم فتح الرحمن من جامعة الطائف. جائزة النسخة العربية، الجائزة الأولى الأستاذ الدكتور عبد المنعم بن عبد السلام الحياني من جامعة الملك عبد العزيز، يستلمها بالنيابة عنه الأستاذ الدكتور محمد حسنين والدكتور مروان عدنان. الجائزة الثانية الأستاذ دكتور محمد النعمي من جامعة الملك سعود. جائزة خاصة مجموعة حباني. مجموعة حباني هي قصة بدأت فصولها منذ 6 أعوام عندما اجتمع 10 طلاب من جامعة الملك خالد ليكونوا مجموعة تساعد الطلبة عن طريق إثراء المحتوى العلمي في أثناء السنوات الإكلينيكية وخضم مسار العمل السريري، حين قرروا أن يبنوا مجداً وأن يتركوا أثراً. وخلال 2 استطاعوا تأليف كتاب حباني للفحص السريري الذي تجاوز عدد مرات تحميله إلكترونياً بفضل الله 21,000 من أكثر من 44 دولة على مستوى العالم. والفريق أحد الأقسام المشاركة في معرض كلية الطب. جائزة الجمعية السعودية للتميز في بحوث التعليم الطبي الأستاذ دكتور محمد حسنين من جامعة الملك عبد العزيز. جائزة الجمعية السعودية للتعليم الطبي لكتابة المقال النسخة العربية الجائزة الأولى ميعاد عوض الدايل من كلية الطب بجامعة الملك خالد. الجائزة الثانية ريم بدر مسيب من كلية الطب بجامعة الجوف. الجائزة الثالثة غدي خالد من كلية الطب بجامعة الملك سعود. النسخة الإنجليزية الجائزة الأولى ريم من كلية الطب بجامعة الملك سعود بن عبد العزيز للعلوم الصحية. الجائزة الثانية أحمد بن علي دكسوم من كلية سليمان الراجح الطبية. لارا عبد الله محمد من كلية الطب بجامعة الملك سعود بن عبد العزيز للعلوم الصحية. الجائزة الثالثة ريناد عبد الله سليمان عباس من كلية الطب بجامعة الملك سعود الصحية. ثالثاً أفضل فرع للجمعية السعودية للتعليم الطبي فرع الرياض. يستلمها الأستاذ الدكتور خالد بن عبد الرحمن. يا جمعا نضاهي بهم أعالي الشم وتتلألأ البروق لرعود هممه الملأى بالقوة والعلو. يا من نحسبهم أطهر من الثلج في حال ذوبانه. يا رواد التقدم والتطور من كل حر أبي لا ينحني إلا لفالق الحب والنوى. لكم من ترادف الكلمات ونظمها أجل تحية وعبير مسك. نقدم لكم من أجزل الشكر نصيبا وافيا ومن ألطف الكلمات حظا وارفا. أدام الله على موطن الأمجاد عزة وأطال في بقاء الخير على حكامه أبلج صوره. شكر الله سعيكم وبلغكم ما تتوق أنفسكم له وجعل البسمة رفيقا لإطلالاتكم البهية. والسلام عليكم ورحمة الله وبركاته. الآن سيكون إن شاء الله صلاة الظهر والغداء. المتحدثين وكذلك عمداء كلية الطب في الدور الخامس، والبقية يكونوا هنا في البهو إن شاء الله.
play the video, and then I'll be live for questions and answers. I'm not sure if you can hear me or anybody is listening to me, but I'm obviously keen that the presentation goes ahead, and that all you need to do is play the video I sent to the organisers several days ago. But let me know if there is a problem.
Hello, Prof. Richard. I am Tawheed, calling from the organizing committee here. Hello.
Yeah,
yes, yes.
So I have sent a pre-recording. My connection here is not good enough to present live from.
Is your network fine? Is your network
fine? No, my network is very unstable, which is why I've sent a recording. It's probably, I can't broadcast sufficient, I cannot.
Hello, hello. Yes. Off.
أنا ماني طيب بسم الله الرحمن الرحيم. Good afternoon, ladies and gentlemen. I am Professor Mahmoud Al-Ahwal, Dean Faculty of Medicine at King Abdulaziz University. I would like to start the session for the afternoon, starting by Professor Richard Fuller. Professor Richard Fuller, he is professor and the director of Christie Education in Manchester in UK, with an innovative portfolio, local, national, and international education work focused on realizing learner potential and improving healthcare outcomes, in association with Manchester Cancer Research Center and major partner, including the University of Manchester. He has held senior educational roles at the universities of Leeds and Liverpool, contributing to the domains of curricular assessment systems, etc. Dr. Richard, he practices clinically as a consultant stroke physician and geriatrician. He holds a number of national UK educational advisor roles, including acting as an assessment expert for the General Medical Council and leadership of the GMC test competence panel. He is the current chair of the Aspire to Excellence Panel in Health Profession Education Assessment, set up by the Association of Medical Education in Europe. He is going to talk about the online, offline, or off-message, the good, the bad, and ugly of assessing clinicians' competence using technology. He's going to talk to us on this subject as pre-recorded video from UK.
Hi, I'm Richard Fuller from Christie Education in Manchester in the United Kingdom, and it's a pleasure and a privilege to be with you as part of SIMEC. I'm going to switch off my camera now, but I'll be available at the end as part of the Q&A and the live discussion. But the talk today is going to focus on some learning and reflection and thoughts around how we use technology to assess clinicians, and particularly reflecting on some of our experiences of the last couple of years. I'm going to start by some thoughts and reflections about our understanding of the benefits and pitfalls of technology in assessment before COVID, some reflections on what we've learned over the last couple of years, and to try and pull that together with some recommendations and guidance from the Ottawa Consensus Group, which have been focusing on the use of technology to enhance assessment within health professions education. So it's fair to say this is a reasonable representation of where we were in the time before COVID. The increasing use of mobile technology, whether that was in the classroom or in healthcare settings, the rise of virtual and other types of simulation, and as we'll talk about in more detail in a second, the real growth of online technology-based and e-portfolios. And it's perhaps easy to look back at that time with rose-tinted spectacles as we almost became accustomed to using technology more and more to engage learners with both learning and assessment. But what I'd like you to do over the next few minutes is to challenge some of those thoughts that this was a happy future and think carefully about what the literature said in relation to some of our approaches to assessment technology in health. So I'm going to start by looking at the e-portfolio. I think because there's such a great wealth of evidence about both the benefits and the challenges. And it's easy to look at the e-portfolio and recognize the real wealth and reward that we can get from using it as part of assessment within health. That sense of connectivity, how we can set tasks, we can work with our learners, the learners can use the portfolio themselves for their own learning and curating of activity. And we can put all of that data under one roof. And all of that data really is helpful in terms of actually understanding how learners are learning and behaving, perhaps using more machine learned or augmented intelligence approaches to guide us more. As we understand that learner behavior, how do we use the portfolio to almost trigger much more customized interventions around feedback and guidance and coaching to support our learners to move forward? I think a much more balanced and appropriate sense of what Bowd and others might describe as sustainable assessment. Well, that's what it seems like. If we shine a spotlight on what we're doing, though, and we actually look at some of the theory that underpins the tool, well, unfortunately, it's less positive. There's in fact very little strong evidence that actually using artificial intelligence to actually manage some of this big data actually has meaningful outcomes in relation to education. There's an emerging and rather disturbing group of evidence that suggests that this sense of actually just measuring what learners do can be very, very unhelpful, either because we're recognizing, or we're failing to recognize, should I say, approaches to learning that aren't effective, but we're not correcting learners. So they just carry on thinking that submitting everything the night before is absolutely okay, or that the focus on measuring actually leads learners to become more and more anxious. I'm scared of making a mistake. What if I upload the wrong thing? What if I don't do very well on this piece of work? What does that mean? Well, what Archer and Prinsloo demonstrated was, in fact, that some learners can actually deteriorate in terms of their development as a consequence of that big brother approach to understanding what's going on with technology. And it's not just learners who suffer when this goes badly. Work from an Australian university demonstrated nicely, but also rather sadly, how when we as faculty misunderstand the data that's produced from portfolios and analytics, we get it wrong in terms of how we apply that to learners themselves. So does technology naturally innovate assessment? Does it make our assessment more authentic? Well, the e-portfolio work would suggest not. And I think these words from Eric Dreesen from a couple of years ago, I think demonstrate where we've gone wrong with technology. We're much more focused on process rather than the pedagogy and practice that drives good quality assessment. And if we're not careful, particularly in health, I think this could be one of the problems we see with technology-based assessment, that we end up with system failure. And there are lessons there for patients in terms of safe care, but also for learners in relation to their trust in assessment and ourselves. So moving forward, did COVID really help us understand and do better? Well, I put this slide up because this work from the Royal Society of the Appreciation of Arts in the UK demonstrated really very well how we've managed over the last couple of years in terms of crisis response. And particularly with an assessment, a large underpinning factor to that crisis response has been this. It's been about the use of technology-based devices and the Internet of Things to really think differently about how we practice. And some of the things in relation to our assessment practices have been great. You'll be pleased I'm not here in person, otherwise I might be attempting a Clint Eastwood impression, so you'll be glad I'm not. But what was good? Well, I think the C's, the communication, the creativity, and the collegiality around assessment development over the last couple of years have been really useful. Better assessment talk, improved discourses and discussion between faculty and learners about assessment, and an opportunity to really engage learners in a co-design process with an assessment have been very powerful messages over the last couple of years. And that creativity has really expanded into how we practice and deliver assessment. We've no longer been bound by some of the challenges of booking large assessment spaces and big exam halls. We've been able, because we've not undertaken as much high stakes, large scale assessment, to focus much more on assessment for learning, really using much of the work that Dylan has pioneered to inform, I think, more engaging, more creative ways of assessing our students with and alongside them. And as we'll talk about a little later, focusing on newer ways of much more customized testing as a consequence. And alongside that, the good has been about how we've developed as faculty and innovation in terms of our innovation and development, both in terms of disseminating really quite interesting practice, but also reflecting on how organizations have started to support faculty to really maximize how they understand and practice technology-based learning and assessment. Those things were good. Some things were perhaps less so. And unfortunately, we've seen a rise of things that I think reflect the opportunity of using a tool rather than using theory. We've heard lots of talk over the last couple of years in particular about this sense of a virtual performance test, the OSCE. My concern is that the principles that governed really high quality practice before, when we assessed students face to face in relation to patient care, have rather been ripped up and forgotten. That we can just use an iPad and a simulated patient, and we can do a couple of those encounters, and we can then make a judgment that that student is competent and can move on and progress within their program of study. I don't think that's what we intended and sought to do, but unfortunately that seemed to be what we achieved. Certainly in the UK in health, we made life difficult by misunderstanding ourselves as faculty and assessment experts about what open book tests were. That as we move many of our knowledge tests online, we call them open book tests. That really mystified our students who in health had not really had any experience of open book tests, but the whole pedagogy and good practice around the design of open book tests was ignored, and that caused an awful lot of confusion. We use learner analytics in a particularly poor way, with some universities making judgments about progress and student promotion based on evidence that was not really designed for that purpose. And I think it really reinforces what Meredith Broussard has highlighted as a sense of artificial unintelligence, poor machine learning, but also, as we pointed out in the earlier slide, poor application by faculty, poor consequences for learners. And what were some of the unintended consequences of this rapid upscaling, should I say, of technology for assessment? Well, I think two. The Ottawa Consensus recommendations, where an international group got together over 10 years ago to think about technology-enhanced assessment, warned us about the sense of transmediation. Just simply dropping an assessment online does not make it better, or in fact, we've seen, actually makes it worse because we don't think about the systems and processes that govern our assessments alongside that. So we saw more transmediation, and we also saw error, as faculty and students learned very, very quickly how to use technology whilst juggling high stakes assessments. And unfortunately, the issues around construct irrelevance have become more and more important. Because we've chosen tools because they seem shiny and innovative and exciting, we've forgotten that we move away from an authentic construct of assessment, particularly when that assessment looks nothing like how we might practice in a healthcare setting. And that leads to major problems for learners and faculty. So it's felt that the last couple of years, certainly for students, have felt like this. They're not quite sure what assessment looks like. They're not quite sure how it's going to seem. And Clint Eastwood again, do I really feel lucky? One thing depressing for me is this, that in 2 years of commentary in health professions around how we've used technology for learning and assessment, almost nothing has been written about digital equity. Yet this report and many others, some of which predated COVID, have really highlighted a growing digital divide between those who have and have not. And it's not about devices, but about the skills, the literacy, the space and the environment to use technology successfully for assessment and learning. And that's been a compounding challenge on top of some of these poor assessment design issues. Here's the ugly though, and this is about professionalism and our views of student behaviour around using technology. And as you'll see from one of the cartoons there, it's not just an issue for health. We're seeing this, for example, in online chess. But the narrative is this, that if I use technology for assessment, I have to be worried about student cheating. And because I'm worried about cheating, I develop very, very complex systems that all shout about mistrust. Not just mistrust between faculty and learners, between learners themselves, and sometimes the organisations we all work and study within. And that those adversarial systems, unfortunately, have led to more risk. Again, because we're grappling very, very quickly with tools we've never used before, we make errors. Our students are trying to manage assessment alongside how do I do this on Zoom with my camera on? And on top of that, as we gather data, what data are we actually measuring when these proctoring systems are actually hoovering up an assessment period? And what's the security about that data? Often we're measuring things that we would never have looked at before in a face-to-face assessment. Body position, eye contact, all of those are perhaps the personal space in which a student might be doing the test online. None of the things that we looked at before, but many things that are highly personal and I think quite challenging to deal with. So where might we move forward? If I use the technology analogy, how can we reboot? Well, I want to share some thoughts and outcomes from the broader literature in relation to technology learning and assessment and the work of the Ottawa Consensus Group that's been running over the last couple of years. And the first message is this, is that before we pick up the shiny tool of technology, we actually pop it down and we think about whether our assessment is fit for purpose. Is it fit for purpose, full stop? And is it ready to be transformed with technology? That we engage with many of the principles, not just within health professions education about good assessment, but we really embrace the learning from wider educational assessment about many of the principles that you're going to hear next in relation to assessment for learning, about good quality feedback, about the importance of really understanding what authentic assessment is, because just popping it online or popping it on an iPad doesn't make it authentic. Arguably, it's making it less authentic. And this issue about how we're creating assessment cultures that really shape and drive learner behaviour in a positive way. So the work of David Bowden and Rebecca Sola around sustainable assessment. Our first conclusion within the consensus group was actually dealing with the digital divide before we did anything else. And that was more than just giving students an iPhone or an iPad or whatever else. In resource-poor times all over the world, that's clearly not an appropriate solution, and that we need to think much more about how we design programs to use technology alongside assessment and minimize some of those issues about digital inequity. We think about the skills and literacy that people need to be able to assess online, about how that is linked with how they practice authentically in healthcare settings with devices, of which more in a moment. But also we're thinking about what is simple and effective, that has an evidence base and has a track record with other people using it. And the work by Hart and the concept of, say, the modern professional learner's toolkit has been revolutionary for me, because it reminds us that how many of our simple tools, Microsoft Office, YouTube, that we are more familiar with, that we have already, can be very, very powerful in supporting assessment. And finally, we think about the processes that sit around assessment. So again, avoiding some of those transmediation errors that Ottawa talked about 12 years ago, we make sure that our assessment systems are actually fit for purpose to adopt technology. And again, learning for me is actually thinking about frugal innovation cultures that are resource poor, that have adopted technology very, very carefully and very effectively, because they've had to think very, I think very differently and with a degree of agility about how they manage the processes around learning and assessment when using technology. And we can learn much from them. The second message was to use assessment in a wise and effective way across the whole assessment life cycle. So it is not just about saying I'll use an iPad for assessment in anatomy on a Friday for one module. How can we think in a much more impactful way? Well, the first was to think carefully about what assessment authenticity is and what we're trying to achieve with assessment, and how technology can support rather than hinder some of these messages around personalization and creating more ability and more space and learner agency in terms of managing their own progress, my apologies. That we place learners and faculty at the heart of design. Too often we see that we buy the technology or we procure the technology, and then we're thinking downstream about whether this is going to work effectively. And I mentioned this before, but we need to think carefully about where we're using technology clinically within our healthcare practice and ensure that we're really aligning our assessment around this. So do I know how to use the technology with and around patients and colleagues to provide better care? And as a practicing physician, I think about my ward round just yesterday, where this was pretty routine, about using devices to look up scans and blood results, access guidelines, consult with colleagues, and even with patients and relatives. It's really important that our assessment actually meets and aligns with this level of practice. A key message for me in terms of using assessment technology wisely is that learner engagement really, really matters. And again, as we've moved away from high stakes tests, particularly over the last couple of years, there's been a welcome growth in good assessment for learning. And I think a great example for me comes from Alex Webb and colleagues in the Australian National University, where they were looking at anatomy assessment. So rather than the tired and familiar old ways of an essay or a multiple choice question, they looked at a much more assessment for learning type approach, asking learners to create their own videos of explaining and teaching anatomy using YouTube. The outcome of that was fantastic in terms of creativity, in terms of learner engagement and activity, but also the perceptions of the learners themselves, whilst also assessing a number of constructs, not just my knowledge of anatomy and my application of it, but my ability to seek out resources and to pull all of this together to create my own learning material. I'm deliberately not talking about tools as we work through this section, as you will note, because it's thinking about the principles that make our assessment technology fit for purpose in terms of looking at clinical competence. And there are four big questions that I think we need to answer as we adopt technology about the when of testing. And I think this really dovetails with the emergent work around programmatic assessment and much more personalized approaches to testing, where we're gathering data from multiple sources at different times and ways to make an overall, perhaps more holistic judgment of a learner's progress rather than just a high stakes test alone. From the when to the how, and interestingly, even before COVID, we were seeing a rise in more sequential, customized and adaptive forms of testing, where we were effectively investing assessment in those who needed it most, but also customizing some of the output of that to support learners at different stages of their journey. Whilst I talked perhaps slightly negatively about the experience with open book over the last couple of years in health, it is recognizing that there is a bigger and I think really quite exciting opportunity to engage with open book testing to reflect the real world of work. And I turn to my own practice, where routinely I'm using technology to look up guidelines, to perhaps balance out quite complicated risk stratification, where I'm consulting with colleagues in the wider nursing and therapy team for the care of quite complex patients. And you can see how an open book type approach might allow us to test the ability of learners to actually undertake some of those activities, to gather, to access, to process often quite diverse pieces of information to solve a very realistic patient-related problem. From the how to the where, in fact, COVID has really challenged us in a good way about this. Pre-COVID, we were seeing the rise, as Sungar and colleagues have highlighted, of the bring your own device generation, where we could use the smartphone in everybody's pockets to really engage with remote assessment, learning and feedback. But what's come out of COVID is two things. A, the importance of equity and access, as we've highlighted before, but B, some really interesting perspectives about the environment in which testing takes place and the psychological comfort of perhaps doing your assessment in an environment that feels more familiar and can be controlled, rather than, say, the anxiety of the large testing hole. But importantly, the need to support learners throughout that process. And finally, the what am I testing? Am I testing just competence? Or, as we've highlighted, the additional skills about using technology to access, to retrieve and process information, and in a portfolio, for example, to be able to curate that. Let's return to this issue about trust and professionalism and the need to rebuild faith in our assessment partnerships with our learners when we use technology. Well, I think these are the 5 key points that have emerged from the literature. And not, as I said, trust not just between faculty and learners, but learners themselves and our organisations. That issues about professional behaviour and how we deal with issues are as much the responsibility of faculty and organisations as students. And there are clarity of consequences in relation to the positive and negative behaviours and outcomes that follow that when cheating and malpractice may have taken place. And as I highlighted before, that our proctoring is proportionate, it's sensible, it's thoughtful, and we think very, very carefully about the issues around data and processing in relation to capturing things that we weren't doing traditionally when we did face-to-face assessment. I guess finally in this short section of recommendations, it is about achievement and improvement. It's asking some of these questions. Where we are gathering extensive data, can we use our technology more wisely than perhaps what I've highlighted as a profile and punish type approach to what increasing the literature would highlight a gather and guiding approach, where we're thinking carefully about the data that we can gather around assessment, and we're visualizing and understanding it better. We're using it to guide learner agency and choice, and also thinking more creatively about how we support improvement, e.g. in relation to, say, remediation or mentoring or nudges. And we remember that that data is not just for our learners. It is, whether that's short or long cycle assessment related feedback, it's thinking about our own practices and how we improve what we do. But as we engage more positively with some of these discussions around machine-based learning and big data, we're seeing 2 outputs. Number one, that when it's done thoughtfully and it's designed well, we can help learner groups or particular learner groups in a bespoke way, whether that's learners who are struggling, learners from particular ability backgrounds. But also an emergent discourse that I think we've yet grappled with in health professions is when we're gathering that data, whose data is it? And a final call then, as we re-engage with assessment technology in a peri-COVID way, is a call for evaluation and dissemination. So little is shared in terms of both good pedagogy and good practice within health professions education. And I think there's a need for us to research more wisely, but also disseminate more effectively. So what could the future look like? Well, what people are really highlighting in this period, which we know as the 4th industrial revolution, this fusion of person and machine and the Internet of Things, is that humans and people are increasingly important when we're using technology for assessment and learning. And Gert Leonhard, who is a technology futurist, highlights something that's very appealing to me, this sense of human-only traits. The things that we can't automate and we can't use a machine for are going to become really, really valuable. So I think there are some interesting questions for assessment around some of these areas, such as creativity and ethics. And how do we assess the decision not to use a guideline or a machine to actually make a decision about a patient? How do we test when we abdicate from that system and do something differently? Because again, for many of us, that reflects the real world of practice. So can we look towards a better technology future? Some concluding remarks for me are around this. That we need to rethink about what assessment is. That assessment is not the adversarial form that many of us have encountered and our students still experience, but it is about engagement in relation to learning and a diagnostic process that helps us answer, how am I doing and where do I go next? That feedback supports that journey, and that our systems are much more about learners and patients, and perhaps far less of a focus on the needs of the testing organisation in relation to their own processes and demands. And I guess with that thought in mind, an opportunity as we go forward, as we embrace technology, to change our assessment culture, to think much more about assessment as that partnership with learners and patients. Because my final words are these from William Pollard 150 years ago, the sense that we need to grapple with change, primarily because learners and faculty have experienced a very different taste of assessment over the last couple of years. We really got to engage with that and get it right going forwards. For which I thank you very much for your attention. I look forward to questions, and please do reach out and get in touch if you have reflections after the event. Thank you very much.
Thank you. Thank you very much, Professor Fuller. And we would like to leave the questions till the end of the second presentation. So please, Professor Hamza.
Thank you. السلام عليكم ورحمة الله وبركاته. معكم حمزة عبد الغني, College of Medicine, King Saud University. We are going to for the, I think, final session in the assessment. Very interesting topic, and very expert person in that topic, assessment for learning. So I have a great pleasure to introduce to you Dr. Dalian William. He's the Emerite Professor of Education Assessment at University College of London. He started his academic activity as a teacher of math and physics at a private school. And from there, he started moving from different places to improve mainly the assessment. So in 1984, Chelsea College of University of London, he was there as again in education. In 1996 to 2003, he acted as a dean of School of Education and assistant principals. In 2003, he moved to USA as a senior research director at the Education Testing Center. Again, in 2006 to 2010, he was a deputy director for Institute of Education of University of London. Now, since 15 years, his work is focused on the assessment for supporting learning. That's what we call it, the formative assessment. So now his whole working is with the expert in all over the world. He's working that how we can move from assessment of learning to assessment for learning and to promote the formative assessment previously and now is the assessment for. So give a big hand for Professor William to start his topic.
Thank you. And so my talk is going to be somewhat more general than that of Professor Fuller. I'm going to try to give you a framework for thinking about change. So I am going to talk about assessment for learning, but I'm also going to talk about curriculum and pedagogy, because I think it's very hard to separate pedagogy from assessment and to separate pedagogy from curriculum. So I'm just going to share my screen. And the PowerPoint slides will be available later on. So the outline of the talk, I want to talk about two overriding issues that should govern our thinking about any change in medical education or indeed in any other kind of change. We need to understand why things are as they are, and we need to understand that improving our system involves making trade-offs. There is no perfect assessment system for medical education or for anywhere else. What we have are trade-offs, and so we can plan these trade-offs. We can say, yes, we're going to have more of this, but less of this. Or we can just take decisions without understanding the trade-offs, and we just end up somewhere that we don't really plan. They emerge as unintended consequences of other decisions. I want to spend a little time talking about what educational research can and cannot do to inform medical education in particular. And I want to suggest there are three best bets for improving medical education, focusing on curriculum, focusing on pedagogy, and focusing on assessment. So let me turn to a framework for thinking about change. There's a wonderful short story by G.K. Chesterton, and The idea is that somebody sees a fence in a field and they can't see the purpose of it. And they say, I don't see what that fence is good for. Let's take it down. Let's get rid of it. And Chesterton says, in the matter of reforming things as distinct from deforming them, there is one plain and simple principle, a principle which will probably be called a paradox. There exists in such a case a certain institution or law, let us say for the sake of simplicity, a fence or gate erected across a road. The more modern type of reformer goes gaily up to it and says, I don't see the use of this, let us clear it away. To which the more intelligent type of reformer will do well to answer, if you don't see the use of it, I certainly won't let you clear it away. Go away and think. Then when you can come back and tell me that you do see the use of it, I may allow you to destroy it. And I think that's a really important framework for thinking about change in medical education. There are things that we do, we say, well, I don't see the point of this. Well, in that case, you probably haven't understood how the system works, and changing it might actually lead to these so-called unintended consequences. The big idea here is there are no perfect solutions, there are only trade-offs. And when people come up with new ideas, say for assessment in medical education, they're usually very clear about the things that the old system did badly and how their system will do something much better. They're usually silent about the things that the old approach did well and the new proposal did less well. So we could take, for example, a movement from multiple choice testing towards OSCEs, objective structured clinical examinations. And people say, well, the OSCEs are much more authentic. That's true. But what are the trade-offs? What's the downside? And so if you're not clear about what is going to be worse and what is going to be better, then you're not really in a position to make any smart choices about change. So I suggest that whenever somebody comes up with a new idea for medical education, or indeed anywhere else, they should be asked two questions. What would be better if we make these changes? And what would be worse if we make these changes? And if a person comes back and says to that second question, nothing, then I think they need to go back and think again. The point is, there'll always be trade-offs. The question is, are they explicit and planned, or do they just emerge as unintended consequences of decisions taken elsewhere? The other thing that I've become really convinced of in my work in education over the last 40 years is that the most important concept in education, particularly in improvement, is opportunity cost. Every hour we have our students doing one thing is an hour they don't have to do something else. Every hour that our lecturers spend doing one thing is an hour they don't have to spend on something else. And so that's why I think we need to be very careful about where we focus our efforts. And I think in education, it's really difficult because it's a very messy thing to research. So as Robin Hogarth points out, learning from practice to improve practice involves making inferences, drawing conclusions. And he points out there are two settings involved. The information is acquired in one setting and is applied in a different setting. So what's important for the learning organization is what's the match between these two settings? The setting where you learn about what works and the setting where you apply your ideas about how to improve things. And I would say that education in general is much more complicated than people suggest. So Hogarth suggests there are two kinds of learning environments. A kind learning environment is one in which there's a close match between the two settings. So chess is a kind learning environment. What you learn in one setting is probably applicable in another chess game. Tennis is a kind learning environment. What you learn in one setting is probably applicable to the other games you will play. A wicked learning environment is one in which there's a poor informational match. In other words, what you learn in one setting may be completely inapplicable or even counterproductive in a different setting. And my argument is teaching in medical education and elsewhere is a wicked learning environment. So for example, when teachers are teaching highly achieving students, they get higher ratings as teachers. Not because they're better as teachers, because they look better because their students are so smart. The hardest thing in education is that performance, how well people do in a learning task, is not learning. So every teacher has had the experience of explaining things to students, and the students seem to understand it. They can do it at the end of the session, and 2 weeks later, it's as if that session has never taken place. The point is that performance is not learning. Learning is a change in long-term capability. Performance is the performance in the learning task. And not only are they different, recent research from Robert Bjork, a psychologist at the University of California, Los Angeles, has suggested that they're inversely related. Unless students struggle somewhat, what he calls experiencing desirable difficulties, then their learning will be less permanent. There's some nice studies from the US Air Force Academy that shows that teachers who are more successful in the short term and get higher ratings from their students are actually less effective in the longer term. Students like teachers who make things easy, but making things easy often doesn't lead to good learning. When things work or don't work, without good theories, we might learn the wrong lessons. So there's a good example here in coronary bypass grafts. A study in Pennsylvania looked at the success rate according to how many procedures the surgeon did in a month. And if they did 20 or more per month, then the mortality rate was 2%. If they only did one a month, it was 3%. So 50% high mortality rate if the surgeons didn't do this procedure very often. And people assumed this was a practice effect. But some subsequent analysis showed that it wasn't that at all. If somebody did 20 procedures every month in different hospitals, the mortality rate was 3%, the same as for people who only did it once a month. It was a team effect. So unless you realize that this might be a team effect rather than a practice effect, you will draw the wrong conclusions. Doctors need lots of practice. No, maybe they need to work with the same team. So without good theories, we will draw the wrong conclusions. And of course, we all know about things that work in some contexts, but not in others. So that's why people have suggested, well, we shouldn't look at one study, we should look at meta-analysis. And what I'm going to suggest here is that meta-analysis is a very good framework for research in medicine, but not a very good framework in medical education, because the contexts that are being aggregated are too similar. So the first is, how do you select all the studies? How can you be sure you've got all the studies? There are also problems with studies working in some contexts and not others, what researchers call aptitude in treatment interactions. A huge problem for meta-analysis is this file draw problem. It's much easier to get studies published if they're significant. One estimate in health education is that it's 12 times easier to get a paper published if the result is significant. And so a lot of the other studies don't get published, they are in the researcher's file drawer. And a recent analysis by Kvaven and her colleagues looked at psychological studies, and they looked at the effect sizes that were reported and the effect sizes that were found if you limited the analysis to the studies that were replicated in multi-site settings. And what they found was that the studies that were well done gave much smaller effect sizes. So the green squares here are the replication studies, the red squares are the published results. And the true effect is about 1/3 the size of the published effect in the meta-analyses, because the meta-analyses gave weight to badly designed studies and didn't include, and there weren't many replications. So in education, we make inappropriate comparisons. The point is, we might compare two different studies on cooperative learning, but unless you define cooperative learning, you don't know you're comparing like with like. Sometimes the intervention is of different intensity. So if we took a look at small group learning, you're talking about 8, you're talking about 4. We often have issues with less variable populations. So in medical education, because they are usually fairly high achieving students, we get a very narrow range of achievement, and therefore the effect size calculation gives you a much bigger effect size because the denominator of the effect size calculation is so small. But most importantly, and most challengingly, I think, for medical education, the outcome measures we use to measure the effectiveness of our interventions aren't standardized, and therefore some are much more sensitive to the effects of our teaching than others. The paradox here is that in education, effect sizes are justifiable only when they're unnecessary. So that's why meta-analysis works well in medicine. If we compare 5-year survival rates, if we compare time to discharge from hospital, then we're using the same outcome measure in different studies. But if we have a medical assessment, then we don't know that the assessment is measuring the same thing in different studies. So some problems are avoidable. There are ways of overcoming these things, and some problems are unavoidable. The challenge is, for me, the reason that meta-analysis is really hard to do well in medical education, most meta-analyses don't avoid the avoidable problems and don't discuss the unavoidable problems. Meta-analysis is, in my view, currently an unsound basis for making policy in education. So what is the role of research? Well, the first thing to recognize is that evidence-based is a continuum, not a category. You know, people say we want evidence-based approaches, but that's not a thing, it's a degree. And so research can tell us where efforts are unlikely to improve education. For a while, people thought that teaching students in their preferred learning style might be helpful. We now know that's unlikely to be the case. It can tell us when things will work and when they don't. It can tell us how much improvement we'll get, and it can tell us about the costs. And that's the important trade-off, costs versus benefits. So the questions we should ask of research is, does it solve a problem we have? Because if you've already solved the problem, it's not going to help. How much does it cost? In out-of-pocket costs, sure, but more important in terms of educator time, how much extra achievement will we get? Not in effect sizes, but in extra months of learning per year. Purists say, well, it's very difficult to get those estimates. Yes, it is, but it's the only metric that matters because any improvement in medical education manifests itself as students learning more in the same amount of time or learning the same amount in shorter time. So how many extra months of learning per year, and then will it work here? Can we implement it here, and do we know what to do? And when we actually ask those questions, when we become critical consumers of education research, it's clear there are 3 best bets: improving curriculum, improving pedagogy, and thinking carefully about assessment. So why is curriculum important? Well, there's a famous TV show in England called Countdown, and in one of the segments of the show, they ask people to construct a given number, in this case 127, by combining different numbers using the rules of arithmetic: addition, subtraction, multiplication, division. And the question is, can you make 127 using those numbers? Even if you haven't solved it yet, I'm pretty sure that for most of you, the fact that 25 times 4 was equal to 100 just leapt into your brain. It just came there without you thinking about it. And that's why it's very dangerous to say people don't need to know the multiplication facts, because experts always see things because the environment triggers their expertise. So the model of human memory that actually explains this very nicely is we have the environment triggering things into short-term memory, and long-term memory also triggers those things. And the important point is that short-term memory is limited in capacity and in duration. Long-term memory is pretty close to limitless. We've never found the limits of human memory. There are some people with a condition called highly superior autobiographical memory. They can remember every single thing they've done on a particular date. And so, as far as we know, the human brain doesn't have any limits in terms of its capacity. The main purpose of medical education is to enhance the contents of long-term memory. I don't just mean memorization, but I mean the concepts, the way that things fit together, the connections between bits of knowledge so that you can make those kinds of diagnostic leaps. And I think we have to remember this. It's not really about making people more skillful and better thinkers. It's giving them more to think with. This is, I think, brought home by John Sweller, Richard Clark, and Paul Kirshner. They describe learning as a change in long-term memory. If nothing has changed in long-term memory, nothing has been learned. And John Sweller points out, novices need to use thinking skills. Experts use knowledge. I think that's a really important point. Thinking skills are what happens when you don't have enough knowledge to solve this by recognizing it. So one of the kind of more pernicious myths we're hearing these days is knowledge isn't important, you can always Google it. Yes, but the point is you won't know what to Google and you won't make those connections unless you have that long-term knowledge. We often think that learners should be involved in authentic tasks, and that's engaging. The challenge is that often those authentic tasks lead to students being successful without actually having any learning. People say we should be teaching skills, not content. I don't think there's a meaningful distinction between the two. As E.D. Hirsch says, skill is content, content is skill. And so I think the main purpose of the curriculum is to enhance the content of long-term memory. And so there's a couple of things here we need to be aware of. One is how to get things into long-term memory. John Sweller suggests that a powerful framework is to think of our brains in terms of their evolution. There are some things we're evolved to do, like speaking and listening. And we acquire these things naturally if we are exposed to a suitably rich environment. There are some things we are not evolved to do, reading and writing. If reading and writing were natural, we'd have figured out how to do them earlier than 5,000 years ago. So he suggests there are 5 biologically primary principles. I'm not going to go through all of them in detail. I want to highlight one of them here. The narrow limits of change, the bottleneck principle. It turns out that we don't really understand how things that we experience get transferred into long-term memory. It's quite a mysterious process. And that's why it is that students can be successful in a task that we give them to do. Their performance on the task is high quality, but they don't remember anything of it 2 weeks later. The fact is that not all of our experiences get through the bottleneck. And one of the things that's been shown recently by John Sweller and his colleagues is that the amount of cognitive capacity that you have for processing is crucial. So some things are just hard because they're complex. They involve processing things at the same time. Some things are hard because we make them harder than they need to be, extraneous cognitive load. So for example, if we give students a diagram with text on one side and the diagram on the other side, then they have to split their attention between the two, and that makes it harder. For people with lots of cognitive capacity, with high working memories, it doesn't affect their learning. For people with less working memory, it makes it much more difficult and they end up learning less. So extraneous cognitive load is reduced through good instructional design, not making things harder than they need to be, but then making things harder in a good way by careful instructional sequencing and making sure that as much as possible that they need to use to solve this problem is already in long-term memory. So for medical education, particular strategies, we decrease extrinsic load. We give them worked examples and ask them to complete problems. So we actually show them one worked example, and then we actually show them a similar example, but we leave out the last step and then the last 2 steps. Reduce split attention effects, where they have to split attention, and also reduce redundancy, where you actually talk and write at the same time, because that seems to make processing more difficult for some people. And of course, using multiple channels, making things visually present as well as using auditory channels at the same time, again, in a smart way. For medical education in particular, progress from low to high fidelity cases. So start from simple cases and let people build up those ideas, progress from simple to complex, and then optimize germane load, the relevant load. So we start off with simple cases, and then we make them much more complicated. We chop them up and change them about, and we increase the variability of the cases. And these are the suggestions from researchers in medical education about how to make instruction more effective in medical education. The other thing, of course, is the expertise reversal effect. Worked examples are more effective than problem solving for novices. The reverse is true for experts. So as our students get more expert, we should move away from worked examples to challenging problems. But, and this is, I think, is the most counterintuitive feature of cognitive load theory. The best way to get good at solving problems in medical education is not to have students solve problems, at least not to begin with. And that, I think, is quite a counterintuitive solution. Having students solve real problems is engaging, it's exciting, it feels authentic, but it doesn't seem to lead to the kind of learning that we want, especially in students with less working memory. The second strategy for pedagogy is making our teaching more responsive to our students' needs and more engaging. And so that's where the formative assessment part comes in. We think about where the learner is, where they're going, and how to get there. The role of the teacher, the peer, and the learner gives us 5 strategies. So first of all, we clarify, share, and make sure that our students understand the learning intentions. We elicit evidence of learning, not just questioning, all the things that we can do to help our students, to help us learn what our students are thinking, observing, noticing, providing feedback that moves learners forward. I think this is really very important. In medical education and elsewhere, we tend to assume that the purpose of feedback is to help the student improve their work. It's not. The purpose of feedback is to improve the learner. The purpose of feedback is to help that student do a better job on a similar challenge at some point in the future. And too often we think of feedback as looking backwards, telling the student how their work could have been better. In fact, feedback should look forwards. And then we have to use peer assessment to help each other improve their learning. And finally, self-assessment, students as owners of their own learning. And in many ways, this is the most important strategy of all. I'm often asked to observe people teaching. And when I observe somebody teaching a lecture or a session, I can guarantee that the first question they will ask me is, how did I do? To which I say, how do you think you did? I'm not doing that to avoid the question. I'm doing that because if that teacher can give me a good answer, my work here is done. That person knows what they need to do to become more effective. That person is becoming, in the psychological jargon, a self-regulating learner. I think this is the really important point. The purpose of feedback is actually to promote more effective self-assessment. Good feedback works towards its own redundancy. Good feedback equips learners with the skills they need to manage their own learning more effectively. And if we keep those things in mind, I think we will actually make better decisions. So the number to think about this is the second and the third strategies are responsive teaching. The second and third rows are the learner's role. The point I want to stress is that formative assessment, assessment for learning, doesn't tell you what to teach. It doesn't tell you what your students should be learning. It doesn't tell you what happens when learning takes place. It's just a recognition of the fact that learning is complex and our students often don't learn what we teach. As David Ausubel said 50 years ago, good teaching starts where the learners are. Ascertain this and teach accordingly. But because different students will make different sense of what we say, we need to use assessment to make our teaching more effective. Assessment is the bridge between teaching and learning. It is only through assessing that we can figure out whether what we just did has actually had the intended effect. So before you can even begin to use formative assessment, you have to be clear about what it is that you want your students to get better at. I take no view about what medical education should seek to achieve. This is a framework for helping people once they're clear about what they want to achieve. So some good ideas for feedback. A reminder, the purpose of feedback is to improve the student, not the work. The only thing that matters with feedback is what students do with it. A lot of people ask, should feedback be immediate or should it be delayed? Should it be specific or should it be generic? Should it be constructive or should it be critical? It doesn't matter. Those things have very small effects compared to whether the students use the feedback. So now there's been a lot of interest in focusing not on getting the feedback right, but getting the relationship between the teacher and the student right, so the students actually welcome feedback. And that's where growth mindset comes in. If you have a fixed mindset, then feedback is potentially unwelcome because it might show you're not as smart as you thought you were. If you have a growth mindset, then you're always going to be hungry for feedback because you know you can get better and the feedback will help you channel your efforts more effectively. And so I think one of the things we've learned over the last 10 years or so is that attention paid to helping students get ready to receive feedback is usually better spent than worrying too much about getting the feedback exactly right. My criterion is this: if you're getting more of what you want from your students, it's good feedback. If you're getting less of what you want from your students, it's bad feedback. And as a general idea here, I think it's a good idea to keep in mind this idea that feedback should be more work for the recipient than the donor. Feedback should cause work for the learners to take their own learning forward. As I said earlier, feedback should work towards its own redundancy. Then in terms of pedagogy, and this actually overlaps into curriculum, how to strengthen long-term memory? Well, in a rather interesting study, some undergraduate students attended a 45-minute lecture on meteorology, 4 sections. They were tested on material, half low-order questions, half high-order questions. Students then reviewed half the material. That would enable the researchers to determine the effectiveness of the review. Half did so after 1 day, half after 8 days. They were all tested on everything after 35 days. Now, obviously, you'll be surprised the students did better on the low-order material than the high-order material. They did better on the stuff they reviewed than the stuff they didn't review. What is interesting is what happened according to the review interval. When the material was reviewed after 1 day, they did as shown in that chart. If they reviewed the material 8 days later, they did better. In other words, reviewing the material 8 days after the initial lecture had a bigger long-term effect than the reviewing the material 1 day later. Why? It's because of what we're learning about how our memories work. So as Robert Bjork says, your memory is not a hard disk. So we think of our memories as hard disks, we store things there and we retrieve them. Retrieving something from a hard disk has no impact on what's on the hard disk, but your memory is not like that. Any item in your memory has 2 characteristics. The first is how well it was learned, how well it is connected to other things in your memory, and that can only go up. Retrieval strength is how easy it is to retrieve at any particular time, and that goes up and down. Here's what's really important about memory. Storage strength, how well it's been learned, and retrieval strength, how easy it is to retrieve, can be increased by restudying an item or by retrieving it from memory, but retrieval has a greater impact than restudy. So successfully retrieving things from memory has a greater impact than restudy, and retrieval and restudy increase storage strength more when retrieval strength is low. And that's the reason that we saw those students doing so much better if they reviewed the material after 8 days rather than 1 day. Because they had begun to forget it, the same amount of time studying that material had a bigger effect if they restudied it after 8 days than after 1 day. And this has major implications for our curriculum in medical education. We need to be having a kind of little and often approach where students revisit stuff constantly, because that then produces a bigger increase in how well they've learned it, what is called storage strength in this model. So that means we need distributed practice and practice testing. In other words, we should actually have the same thing repeated over many sessions, ideally quite a long way apart, and lots of practice testing. The idea is you retrieve things from memory, and that makes your memory stronger. Then finally, I just want to close with a few words about assessment. My framework, I think the one I prefer for assessment is to say that an assessment is simply a procedure for drawing conclusions. We give students things to do, we look at what they did, we draw conclusions. That's it. And so really, the important thing is, what conclusions are we allowed to draw? People often say, is this a valid assessment? Well, it will be valid for some conclusions and not others. So in the last 50 years, attention has shifted away from validity as being a property of an assessment and towards a property of conclusions. Once you see what the student has done, what are you allowed to conclude? Some conclusions are warranted, others are less so. That's why validity, I think, is a property of conclusions, not assessments. It makes no sense when somebody says, is this a valid assessment? Talking about validity as a property of assessments is what Gilbert Ryle calls a category error. It's giving something properties it cannot have. So there's a particular paradox in medical education, which is sometimes called the validity reliability paradox. So we try to make our assessments a bit more valid, moving away from multiple choice questions, for example. And So basically what we see is that attempts to improve validity by using more authentic assessments tend to reduce reliability. But the paradox is reliability is a prerequisite for validity. Because if you have unreliable data, you cannot possibly draw valid conclusions. So the reliability validity paradox is that attempts to increase reliability tend to reduce validity, while at the same time, reliability is a prerequisite. And so my resolution of this is to think about reliability. We increase reliability, it strengthens some conclusions and weakens others. So one way to think about this is stage lighting. We could use a floodlight to illuminate all the stage with some light, or we could use a spotlight to get a lot of information about one part of the stage, but then the rest of the stage is in relative darkness. So with multiple choice tests, we get a lot of information about a narrow part of the domain, but we don't get very much information about whether students can apply this in other settings. If we use broader assessments, then we get information about everything, but often the information is rather coarse-grained, and therefore we don't get a lot of strong conclusions about any particular aspect of the domain. The important point is the intensity of the lighting is the proxy for the amount of testing time. Obviously, we can make our assessments better by having more time testing, but there's better things to do with our time, like teaching our students. So the two main threats to valid interpretations that come from the literature is to suggest that there are two ways that assessments can be problematic. They can be too big or they can be too small in intuitive terms. So scores could depend on things they shouldn't depend on. So for example, if there's a very tight time limit, we might actually be giving an advantage to the quicker students. In other words, the score you get depends partly on how good you are at medical education and partly on how quick you are. If we have open-ended writing questions, then maybe handwriting matters. So basically, an assessment is too big when scores depend on things they shouldn't, like handwriting or speed of response. An assessment is too small when it depends on things they should. So another example is luck. So students have good and bad days, who actually marks the work, which particular tasks were set. Those are irrelevant to how good that person is going to be as a doctor, but they can often affect the performance. The assessment is too small. The problem there, of course, is we rely on multiple choice tests because other assessments are too difficult. So we assess only the things that are easy to assess. Paul Newton has suggested that we can think of these two things as signal contamination. The signal we get, the information we get is contaminated with the relevant factors, and signal deficiency. If you want to look this up in the jargon books, then you can call them, they're called construct relevant variance and construct underrepresentation. Those are the technical terms here. The idea is we want the variation in student scores to depend on how good they are at medicine. That's the construct. If the scores vary on other grounds, then that's irrelevant to the construct, so it's called construct irrelevant variance. If the scores don't vary enough because you didn't assess important aspects of what you should be assessing, that's construct underrepresentation. So, some implications for assessment. There's no such thing as a valid assessment. Validity is a property of conclusions, not of assessments. Reliability is part of validity. Specifically, it's the random part of construct irrelevant variance. And there's no such thing as formative assessment. Formative and summative are descriptions of the conclusions that we draw from assessment information. So we can actually use the assessment outcomes summatively to say this person passes, this person fails, or we can use it formatively. That person needs to spend more time on this topic. The important point is summative and formative are not descriptions of the assessments themselves, they're descriptions of the conclusions we draw, they're descriptions of inferences. A couple more points and then I'll conclude. I want to point out how difficult this area is in terms of trade-offs. So here's a nice study from Brian Klauser and his colleagues. They chose 200 medical students who'd completed a performance assessment of patient management skills online. They then selected 100 of the students to use as a kind of benchmarking sample. They had 4 university professors then assess the 100 of these responses, and these responses were used to construct a scoring algorithm, and then this scoring algorithm was used to score the other 100 students. They then looked to see what causes the difference in scores. You see, what we want is the differences in the scores in an assessment of patient management skills should be entirely caused by differences in that student's ability to manage patients. That's the construct. So we want most of the variation in scores to be construct relevance. The difference between students in terms of their difference between different scores should be how good they are at patient management. That's not what they found. So some students did better than others, which we'd expect, because some doctors are better than others. The task they were given, whether they were actually got this task or that task, was actually a bigger factor. Which group of assessors assessed it had not much difference. Whether the particular task they got suited them, whether they were lucky in the task that they got, had a huge effect. And so here's the important takeaway. The person-task variance, as it's called, was larger than all the other sources of variance combined. In other words, how good you were at patient management, how hard the task you were given, who scored it, mattered less than whether you were lucky. And this is the challenge with performance assessment. Performance assessment is engaging, it feels authentic, it's popular with students, it feels real, but yet it has this massive hidden source of unreliability. Again, I'm not saying we shouldn't do these things, it's a trade-off. So, just a concluding framework for thinking about assessment. First of all, assessment systems should be distributed. We shouldn't just assess students at the end of the course, we should collect evidence over the whole of the course, so we get a distributed assessment system. But it also has to be synoptic. We can't just assume that if they did it in their first year, they still know it. So we actually have to make sure that we're accumulating knowledge. We have to assess all the important things, not just the things that are easy to assess. It has to be manageable, so that it doesn't drive lecturers crazy, and it has to be trusted. No assessment system can do all of these things, but by using these 5 principles as a way of thinking about the trade-offs we're making, we may be able to come up with ways of assessing our students in medical education that are, I think, better suited to the task. There will always be trade-offs. We can make them explicitly, or we can actually end up somewhere and with no idea of how we ended up there. So I'll stop there and hand back to see if there's any questions.
Thank you very much, Professor William. Very thought-provoking delivery. Thanks a lot, and thanks for Professor Fuller also. Can both of you can join us for answering the questions and answers? We'll start with that.
Yeah. We'd like to open the floor for discussion, please. Yes, please. Dr. Mona? Can we have the microphone here?
My question is to Prof. Dylan William about the learning tasks. How do we draw that thin line between a learning task that is too easy to initiate learning and a one that is too difficult with a high cognitive load to inhibit or hamper learning? I mean, do we gear the level of difficulty to the level of the students or to the target that we want to reach? What indicators can help us decide on the difficulty of the learning task that we want our students to go through? Thank you.
I think there's no simple answer to your question. I think that the reason that the research on cognitive load is important is not because it tells you what to do, because it doesn't, we can't measure cognitive load, it tells you about things you need to be aware of. And so I think the one important consequence is the fact that the students successfully completed the task does not mean they've learned it. It doesn't mean they've learned it, they'll remember it 2 weeks later. So I think that would mean let's check our students' understanding sometime later. The second thing to think about is obviously, even though medical students are quite highly selected, they're still quite varied. And therefore, I suggest as a general strategy, starting with challenging tasks of moderate challenge, and then thinking about ways in which you might support the people who are struggling and add challenges to the ones who actually find it a bit easy. So let me give you quite an easy example from my own high school teaching. I gave my students the task of estimating the heating requirements of the school building. And it was a big, large, rectangular building. And so I told them, there's 20 points for this. Every time you ask me for some information, it will cost you 1 point. And so it turned, the reason I'd chosen this task was because I wanted them to discover for themselves the concept of specific heat capacity. Because at some point, to do this, they would have to figure out how much energy does it take to heat 1 cubic meter of air by 1 degree. So nobody was going to get 20 points, but some groups managed to get 19 because they realized the only piece of information they needed was the specific heat capacity of air. So by having that kind of challenging task where everybody can start on it, but you can provide more support to some of the learners may be helpful, but we have to be very cautious. Sometimes our support, our help, helps the student complete the task, but because the help we gave them was too helpful, they're successful in the task, but they don't learn it. And so I think the major contribution of cognitive load theory, as I said earlier, is not to tell us how to teach, it's to tell us to be skeptical about our students' understanding. Yes, they completed the task, but let's check they still understand this 2 weeks later, because performance is not the same as learning.
Okay, thank you. Is there any other question anywhere? Yes, please.
Thank you for this informative lecture, talk. My question is to Dr. William. Did you just say, this is my second question, that assessing performance is not learning? Or?
Yes.
Yes.
That's right. So let me be clear. Psychologists use 2 different words. Performance is how well students complete the learning task. Learning is the changes in long-term memory that result. And what the work of Robert Bjork and others has shown is you can have learning without an increase in performance. And you can have an increase in performance without any long-term learning. So the important point is, as I said earlier, the thing to be skeptical about, but the fact that students complete a task, this is the thing that really made me reject cognitive load theory for a long, long time. I could not believe that students could satisfactorily complete a task on their own that was designed to teach them something. They could actually complete that satisfactorily and yet not learn it. But that is what the research shows very clearly. And that's what my experience showed. I was just mystified. How can they do this today and not do it 2 weeks later? This is why teachers get joked at for saying, I taught it, they just didn't learn it. Well, yes, I taught it and they performed appropriately, but the long-term learning wasn't there. And I think that's what we have to be cautious about.
Okay.
We're seduced by this idea that if they could do it at the end of the lesson, it was a good lesson, but it might not stick. That's the problem.
That leads me to the main question, is that I know you mentioned that teaching or curriculum should focus on long-term memory, or modalities that will lead to long-term memory, and you showed us like 4 or 5 theories about that, but in terms of practicality we did not see much. So my question is that what's your advice in terms of practicality, and especially when it comes to performance, where you were surprised that it does not lead to any form of learning? So how are we going to enhance long-term learning and long-term memory? Because most of the studies says that you cannot retain more than 25% of what you have learned, regardless of what you do. So as put aside all these theories, in terms of practicality, how can I improve or design my curriculum to improve long-term memory and learning?
Yeah, basically there are lots of studies out there that have very strong conclusions. You remember more of what you do than what you see, and more of what you see than what you hear. And there's this famous cone of learning from Edgar Dale, which is absolute nonsense. There is no evidence behind that. So I think that I wouldn't take those figures at 25% seriously. So that's what I was saying earlier, is that research can never tell medical educators what to do. Your contexts are too complex. But what it can do is suggest some priorities. And I think that right now, the two things that seem to have the best evidenced impact on long-term learning are distributed practice and practice testing. And there's a third idea, which is interleaved practice. So in a lecture, for example, you might, rather than doing 1 hour on one thing, you might do 20 minutes on one thing, 20 minutes on a second thing, and 20 minutes on a third thing, and then the next day, come back to those things. So the idea that the learning is interleaved, so interleaved practice, distributed practice, and practice testing have all been shown to have really major effects. And they certainly seem to make learning sticky. But there's a wonderful book called Make It Stick, written by 2 psychologists and a journalist, so it's quite readable. Make It Stick, the first author is Brown, and that actually is a very nice summary of what we know about how to make our teaching more memorable.
Okay, any further questions? Yes, please.
Thank you very much. My question is about a formative assessment and continuous assessment, or classwork, as we call it sometimes, and the final or summative assessment. How could we really strike a balance practically? Because we have challenges in practice. Striking a balance between not causing too much assessment or excessive assessment for the students, which could have a negative impact, of course. And especially if you add some motivation, some weight of scores for your formative assessment. So in real practice, you have formative assessment, continuous assessment, and final or summative assessment. And sometimes this really looks too much for the students. Thank you very much.
Richard, do you want to start? Have a go at that?
I'll let you kick off, Dylan, and maybe pop in with some observations from practice. I don't want to disturb your flow.
Okay, so the first thing to say is that, as I said earlier, I don't think it's helpful to think of formative and summative as kinds of assessment. So I think we could think about continuous assessment and terminal assessment. I know it's an unfortunate word to use, but we can have assessment throughout the course and we can have assessment at the end. So here's the challenge. If we have continuous assessment, some of our information is out of date. If we assessed it 6 months ago, it might no longer be an accurate portrayal of that student's capabilities. It could be that they've actually learned some more about that, or it could be they've forgotten it. So this is what I meant by having to have assessment systems that are both distributed and synoptic. We have to make sure that we're not collecting information just at the very end, but we also have to require that students integrate all their thinking that they've learned over the whole course towards the end. And as I said, there's no simple way to do this, but I think that first of all, I would say there's a real problem in medical education because our students are so smart that they're very strategic. And so they say, will this count? And if it doesn't count, they won't do it. So, I think there is, well, the purist in me says formative assessments should not be graded or scored. I think it's good for the students to do it, and therefore some way of actually making it count towards the final score, I think is very important. So I think that there's a trade-off here But the important point is it's about evidence. Basically, assessment is a process of reasoning from evidence. And so we have to think about how good is our evidence, how recent is our evidence, how extensive is our evidence. And if we think about the conclusions we draw at the end in medical education, are we going to let this person become a doctor? Then we need to think about all the evidence we can bring in, and we make those trade-offs. Yes, this is more recent, that's a longer ago, but that was a high performance. So again, it's a messy business. But I think if we think about the idea of assessment as a process of evidentiary reasoning, we will generally make smarter decisions. But I do suggest that we stop using the terms formative assessments and summative assessments, and rather talk about assessments used formatively or assessments used summatively.
I'd really like to echo many of those thoughts, and a bit like Dylan, I tend to work in frameworks because all of our contexts are difficult. I like the sense of it being messy. That certainly summarises the clinical practice aspects of my life, to be honest. But I think we can focus much more on some of those theoretical frameworks to sort of govern what we do. And the key thing for me is the purpose of assessment. We do an awful lot of mislabeling, which means that we understand it poorly as faculty, and our students get very, very confused. So that literacy is important. I think thinking about the value of assessment, for me, really matters. And the difference between doing too much and too little assessment for me is not about the time that this occupies, but it's the value that we get out of it as teachers, but particularly the value that they get out of it as learners in terms of moving them forwards. A thing that's been very, very appealing for me is that sense of, okay, assessment that's used for formative purposes, so for learning, or as I seem to remember in one of your talks, Dylan, you talked about assessment that was fit for learning, which I've always really liked as a sense of, this has got to be good enough to drive learning forwards. And there's a sense that we can use that throughout the lifespan of a module or a curricular year, but we're very, very clear that we're taking these multiple biopsies of quite integrated knowledge at the right level and at the right time. So we're moving our learners towards that higher stakes test that our regulators require us to do. But we're clear, and our learners are relatively clear about what that assessment's going to look like, and that we hopefully have a reasonable expectation that they'll get through. And that when we're making a decision overall, we're using all of that data in a very, I guess, a measured way. And for me, that speaks back to curricula and a need to move away from these very specialty block-based curricula that lots of people use. So, this is my 2 weeks in cardiology, my 2 weeks in big toenail surgery, my 2 weeks in surgery of the left ankle or something like that. Well, as you've seen very neatly from Dylan, retention and learning from that is going to be very, very poor. So let's think about how we practice, and that increasingly we practice in a very integrated fashion. And there's the opportunity to say, for me, I work in stroke and neurosciences in my clinical life, that I might have some elderly medicine, some radiology, some stroke, some neurology, but those things are interleaved in that longer placement. And what I can do is I can start to set out different types of assessment throughout that placement that are capturing both that discipline-specific context that I guess we're interested in, but we can build that sense of difficulty. So like Dylan, I really like Bjork and Bjork's sense of desirable difficulty. As the learners become more experienced in that placement, you're adding to some of that complexity, because it links to the kind of things they're seeing in practice. And I think if you can get that framework right, it becomes the least, I guess, the least worst attempt at assessment in your curriculum. So for a long time, I've said we shouldn't be seeking perfection. Perfection is the enemy of the good. And show me a perfect assessment system, you show me somebody who's probably lost in their own fantasy. So it's largely about how we make it better. And I think how our narratives are about helping learners move forward. Because in MedEd, we've tended to forget about that. We've been focused on very structured, very standardized tests. It's all about me and my organization and my reliable test. And I guess less about the learner. But I'll hand back to the floor to see if there are any other questions.
Okay, yes, go ahead, please. Can you have the microphone here?
Thank you very much. Dr. Ali Al-Ghamdi, Al-Baha University. I would like to thank the speaker for the nice presentation we had. My question is to Professor William. You stress in the long-term memory, and we know that the long-term skill and memory will affect the eventual practice for the health practitioner. And as you know that the design of most of the medical curriculum is based on integrated modules, and some of them are small and short modules. Does this, contradictory the theory you are talking about, and what are the practical solution or the advice for designing curriculum in order to really have a long-term, knowledge and skill for the student to be retained? So the advice for the curriculum design.
One of the big arguments in medical education was the move towards more integrated curricula, which when I was at King's College, we had a real challenge with 3 years of biomedical sciences, and then students going out over the wards in their 4th year, and suddenly discovering they didn't really want to be doctors after all, because they were spending a lot of time with sick people. Yeah. So, I think that the idea of integrating, but I think what Richard said is actually the best framework. It's to think about, yes, these short courses don't achieve what they want. They make us feel good because we taught our content, but it's focusing on what the lecturer is putting into the process, not what the students are getting out of it. And so I think thinking of a structure that will allow us to have these more authentic experiences, but then to make sure that we don't lose the disciplinary content. And I think that's the challenge, is to get the authentic experiences which are engaging and motivating and help students think about how this might really apply, but also they need those content segments in there, and those things need to be reviewed regularly for that knowledge to become integrated. I remember talking to Paul Boughton, who was in charge of the undergraduate medical education degree at King's, and he was saying that his sense was that medical practitioners reintegrated most of what they learned over their 5 years of medical training in England over the next 5 years. So basically, the pieces were kind of coming together because their experiences at college had been so kind of fractured that the links between the contents weren't there, and they were left to make those connections for themselves, which they obviously did in practice because they were forced to think about these things in an integrated way. And I'm just thinking, just following what Richard was saying, I think we could do a lot better in pre-service medical training. I think we could actually make it more relevant, more integrated, and not lose the disciplinary content. And that seems to be the challenge. It's not going to be easy, but I think it's going to be worth doing because that's what the research says makes for sticky learning.
And if I can come in there, just again to echo that the big challenge for me is when we have that very fractured learning that you described, and certainly I recall going through at medical school myself, Dylan, is from a patient safety perspective, I land in service and I actually have no sense of sometimes how to make all this stick together when I get the first or the second patient on my shift is somebody who doesn't fit the nice narrow box of the cardiology take or the surgery take. And I think that perhaps it's less evidence-based, but certainly some nice approaches to practice, I think, appearing all over the world, whereas you move learners through that 5 or 6 year curricula, the placements in the last couple of years in particular become much more focused on, as you say, being sticky and actually posing, well, I guess, and again, starting to introduce at that sort of 4th, 5th, 6th year level, that sense of bringing problems in that people solve. So I moved from moving through my worked examples that I looked at in 1st and 2nd year med school into some of those real life patient problems. They're authentic because they're sat there on the ward in that respect, but they're authentic because we're asking people to learn how to approach and solve problems they're going to be routinely dealing in practice. And for me, it's also been a great way of engaging faculty in wards and clinics, because we're thinking about nesting that teaching, that learning, that assessment opportunity in the work that they are doing routinely. I'm not dragging them into a lecture theatre to deliver the talk. I'm not asking them to go off and write 100-item single best answer question, as valuable or otherwise as that might be. And we're not over-relying on the challenges of the OSCE. And for 15 plus years now for me of working in that field, I've slowly but surely become more and more disillusioned in terms of what the OSCE can and can't do, and perhaps the need for us to challenge some of what I'm going to call a sacred cow in that respect, and think differently about our assessment. But the key message for me is it all comes back to learning design. The assessment just needs to sit and nestle with that, rather than sat as something separate that we do and we sort of bolt on to the curriculum.
But I think just to add one more thing onto that, that's why I think it's important to recognise that we can't be evidence-based in our practice, because when we go to the evidence cupboard, we often find there's nothing in there. And so we are forced to rely on our professional judgment. So, but what I would argue is that when the research is there, we should use it. But we should also be aware that the research actually often isn't there. And we do have to rely on clinical judgment, on our experiences, on the experiences of those around us. But we need to be careful about, are we comparing like with like? And that's why I come back to this phrase. Medical educators need to become critical consumers of educational research. We need to say, well, that study produced a different result, but that was in a very different context. So how can I be sure it applies here? And there's no simple fix here. We have to become critical consumers of research.
Okay, because of time, we'll take the last question, please. Professor Badr.
Okay, thank you. First of all, I would like to thank both professors for very interesting presentation that we have enjoyed. My question really is about the change that Professor Fuller mentioned. When do you change and why do you change? If you are in a situation where you are assessing the assessment methods that you are currently using, do we have any certain indicators that we should look at to say that our assessment methods now are in a stage where we have to change? The indicators that we should look at in a process assessing our current assessment methods. Are we satisfied with the current situation and we keep it? Or we say, depending on these indicators that we have seen now, we think that we are in a state that we have to change. Can we have like some idea about these indicators that we should carefully look at, please?
Yeah, I think it's a brilliant question, and I get where you're coming from, because after a year of delivering a curriculum, you've got your multiple assessments out of the way. The place is still standing. Faculty haven't quite fallen out, and there's not been a student revolution. It's easy at that point to think we've survived another year. I think it's critical to look carefully at our assessments, but I think the first question I would ask is how clear we are about the purpose of what we do. And it's when I've worked with colleagues all over the world, and I've soul searched myself with our own practice, there is that sense of how clear are we about why we are doing this and what we're seeking to test. And it's often one of the things that people fail on at that first hurdle. They're very good at telling us they do an OSCE and some workplace assessment and they use technology and whatever. But that critical, the what, really is quite challenging. So I think the opportunity to take a life laundry, if you will, about assessment is useful around the purpose. How clear we are as faculty and how clear our students are. But also picking up with Dylan, there is a proportion of good evidence out there that we can look at with perhaps a critical eye. I think some of the big consensus statements on what make good assessment frameworks are really valuable to look at. So the work that John Norsini and colleagues refreshed at the last Ottawa Consensus Conference, which is it's 2018, I think for me was still very valuable because it didn't narrow context. It talked people through a framework about how good is your assessment, focusing on the purpose, the design, the scheduling, but particularly about the outcomes. And I like it because it didn't necessarily talk about tools. We're very, very focused on our tools, aren't we? And we're very tribal with tools in medicine, that I'm a physician, I must have this set of tools. The surgeons have got something else that's named something else. The gynecologists name their own versions. And that isn't helpful for learners and not particularly helpful for patients. So I think the evidence is out there to go and have a look. And I'd recommend in medicine those consensus statements. However, I'd also encourage us to, as I said in my talk, look outside of medicine, because we don't do theory particularly well. Many of the things that Dylan has been talking about, which have been nested in the literature for a long time, some of us are only just discovering. So we're very, very conservative as a profession, and particularly in relation to education. So it's look outside of the box, and to what extent we're comfortable with some of those theories about authentic assessment, that assessment's fit for learning. Is our assessment, as David Bowder would say, truly sustainable? Are we designing systems that are moving our learners forwards? We're thinking about the environment, the feedback, that sense of understanding longitudinal learner progression. So I think we need to look in a different way to say, well, is this just a collection of single best answers and OSCE assessments in a toolbox? And I think there's the frameworks that are out there can be a good place to start.
Just at one point, and if that wasn't hard enough, I think we also need to take into account the fact that assessments are important not just for what they mean, but for what they do to our students. So as Richard Stiggins said now nearly 30 years ago, assessment literacy involves asking, does this assessment have utility for its intended purpose? Does it tell us what we need to know about our doctors? But what is the impact of this assessment system on the key stakeholders? And I think, you know, if we don't take that question into account, then we might end up with solutions that are fine on paper, but just really don't work in the real world. So I think that, you know, this idea of what do assessments mean and what do assessments do, I think provides a very useful framework for thinking about this.
Okay, with that, I'd like to thank you all, both Professor Fuller, Professor William. Many thanks for you being with us here, and I would like to thank also Professor Hamza and all the audience for being here until now. We look forward to have a break for 15 minutes, and we will be back at 4 o'clock sharp. Thank you.
Well, thanks, Dylan. That was fun.
It was, wasn't it? Yes. Not much disagreement, but you know.
Well, I guess.
قصدي السلام عليكم ورحمة الله وبركاته. It gives me great pleasure to introduce our session this afternoon. The session will be about the abstract presentations for the selected papers and contributions from our colleagues in the Arab countries for oral presentation. As Dr. Al-Amri mentioned in the introduction, that there were 300 applications and 250 were accepted, some of them as posters. Also, the organizing committee would like to announce also that all the posters are posted at the back of the podium here, and you can scan them by scanning the QR codes. Also, it is available in the SIMEC web page. It gives me great pleasure to introduce myself. I'm Dr. Nimin Kani, the Dean of College of Medicine at Taif University, and to introduce my colleague, Dr. Al-Fi'i. Our first presentation is by Dr. Abir Al-Ahmadi, who's from the Ministry of Health, Jeddah. And her paper is about evaluation of learning environment of different family medicine programs, Jeddah KSA 2021 PhD prospective in the category of teaching and learning. Dr. Abir, we welcome you.
Assalamu alaikum. Is my voice clear? Assalamu alaikum. Good afternoon, everyone. I'm Dr. Abir Al-Ahmadi from Jeddah, and today I'm going to present my master project, which is evaluation of learning environment of different family medicine program. My research team is Dr. Anof Al-Baz and Dr. Anof Al-Harbi. So as we know that family medicine program are different from any other specialty in its shorter duration and its broader learning spectrum. Usually the training takes place in both hospital and the primary healthcare center, where educational environment play an important role in resident satisfaction and performance, and eventually lead to better patient outcome. The researcher went through extensive literature review, and we found two main studies which make the base of our research. which first one was done by Khoja in 2015, and it's stated that the family medicine learning environment fails to meet the need and expectation of the learner, and there is urgent need to change. Another research was conducted in 2019, and it showed better improvement, but still the resident struggle to reach its intended goal. So this study focused on evaluating the learning environment in primary healthcare in 3 domains: perception of autonomy, teaching, and social support. Our aim is to compare and evaluate learning environment of different programs in Jeddah in different primary healthcare settings and make practical recommendation for improvement. The study design is causal comparative study at postgraduate family medicine program, and our tool is FEAM questionnaire, which is postgraduate hospital educational environment. Regarding our sample size and technique, the total number of residents in Jeddah is 283 family medicine residents, and we decided to include all the family medicine in our study. Our study area and setting is the 3 programs in Jeddah. First one is King Abdulaziz University Program, National Guard Family Medicine Program, and joint program of family medicine, which include MOH, Military Hospital, King Faisal Specialist Hospital, and International Medical Center, which is a private hospital. We include all family medicine from R1 to R4. Our main outcome variable is the resident perception, and the main independent variable is the family medicine program. So our tool is FEAM, which is self-administered questionnaire. It's composed of 40 items and 5-point Likert scale. It's practical, valid, and the most widely used questionnaire to evaluate different department, different center, and different program. The total score is 160. 0 to 40 indicate very poor learning environment, while 121 to 160, it's mean excellent learning environment. This is the score of different domain. Each domain composed of 13 to 14 question, and it's range from very poor to excellent learning environment. We use SPSS for our data management and analysis, and Shapiro web test used for testing the normality of our data. And since our data was not normally distributed, so we use Mann Whitney to compare 2 groups and the Kruskal Wallis test to compare more than 2 groups. Categorical data as the resident level was presented as a frequency and percentage, while numerical data such as the score of perception was presented as median and interquartile range. This is the demographic characteristic of our participant. It's 262 family medicine resident. And as you see here, the number of residents in joint program, it's the largest number because it's the biggest program in Jeddah. So this is the result of perception, or score of perception in different domain. In all 3 domains, around 80 to 90% of the residents, they perceive their learning environment as positive, while around 11 to 13% they think they have their environment was not a pleasant place and having a negative perception toward their learning environment. The item which got the highest score is the resident think they have appropriate level of responsibility and the protected educational time, and there is no racism in their program. The item which got the lowest score is that the resident have interruption during consultation. There is no access to an educational program and no regular feedback, and there is no good accommodation for junior doctor. Regarding the factor associated with the perception, there is no significant difference between male and female. There is significant difference between the junior level and senior level. Junior level R1 and R2 have more score, and maybe because they are following the new curriculum, which is only 3 years, while it's R3 and R4 following the old curriculum, which is 4 years, and
Thank you, Dr.
and they
Abir.
are
Can
under
you
stress of
conclude,
the
please?
final exam. Regarding the residency program, National Guard program get the highest score, and there is significant difference between the National Guard and the other program, which is actually expected result because National Guard have more resource and more stable system.
Can you hear us,
Ministry
Dr.
of
Abir?
Health get through a lot of change through a transformation and vision of 2030. This is the score of joint program and King Abdulaziz program, which is indicate that they have more positive environment than negative, but
Dr.
still
Abir cannot
space
hear
for
us.
improvement. National Guard program get 127, which means excellent learning environment. Our study limitation, we missed the qualitative part, which could give more holistic approach, and it can be suggested for future study. Corona pandemic also could affect the resident perception toward their learning environment. So in conclusion, the dissatisfaction was observed in some area, and junior and resident of National Guard program more satisfied compared to their peers. So our recommendation, poorly rated issues should have attention from high authority, and the family medicine opinion should be taken in consideration in any plan for improvement of their learning. And we need continuous assessment for our program and further study, including in another city, to have more comprehensive approach. And this is my reference, and thank you. I'm ready for any question.
Thank you very much, Dr. Abir. Our second presenter is Dr. Salma Saadeddin. Dr. Salma is from Western University, London, Ontario, Canada, and her research is on team-based learning in orthodontics courses. Students' satisfaction. Welcome.
Assalamu alaikum. Can you please give me permission to share my screen?
Yes, please.
Yeah.
You have the permission to share the screen, please?
Yeah, good afternoon. I would like to start my speech by sharing this picture that I took it when I visited the edge of the world area in Riyadh, and always I show it to my students and I remind them that the best view comes after the hardest climb. Today I will speak about student experience and satisfaction regarding introducing team-based learning in prosthodontics. Team-based learning is used extensively in several countries across the world for healthcare education. It shifted the learning pendulum from passive faculty-centered to active student-centered. It created a mature, confident class participation and interaction, and enhanced students' critical thinking, teamwork, and communication, as well as interpersonal skills that are important to improve the clinical performance for the healthcare provider. There are 3 phases of the TBL: the preparation, readiness assurance, and course objective. TBL methodology introduced to teach part of preclinical and clinical prosthodontic courses for 2nd, 3rd, 4th, and 5th years at College of Dentistry. The TPL sessions were either 3 hours, we call it the conventional, or that were taught to second and fifth year, or 1 hour, we call it mini TPL, that were taught to third and fourth year. Class were divided into teams composed of 5 to 7 students that they were from different levels, A, average and below average. The material of each session sent to the student 1 week before the session. At the beginning of the session, short MCQ quizzes were solved individually, and then we took the same quizzes as a team. Then a discussion session will be open regarding to the questions and answers and justification of the answer, as well as introducing clinical cases related to the session. At the end of each course, students completed a self-administrative questionnaire regarding their TPL experience. Student answers would be anonymous and confidential. The questionnaire had 20 statements measured on a 5-point Likert scoring method, and it has a 4 parameter. We noticed that for the 4 parameters, the response was almost the same, where for the traditional TPL, which is 3 hours, the response was ranging between strongly agree or agree, while for the mini TPL, which is 1 hour, usually it ranged between it's usually agree. There were a couple of responses that was a neutral. This is the second parameter, which is interpersonal skills improvement. It's also the same, but here the second and the fifth year were all strongly agree with the statement of this. The class environmental also, it has the same result, strongly agree for the traditional TPL, while agree with the mini TPL. And the student instructor interaction also, it was the same as the previous parameter. So we can conclude that in general, students were satisfied and they have a pleasant experience with the TPL, although longer sessions received more satisfaction than the short sessions. And this can be attributed that there was more time for engagement and discussion and providing the constructive feedback. And here I would like to share some of the notes from the student that they were written on the questionnaire part. Thank you, and I wish you have a great day.
Thank you very much.
You're welcome. Thank you very much. We'll leave the questions to the end of the session. It gives me great pleasure to introduce our next presenter, Professor Zainab Qasimi from Manoufiya Faculty of Medicine, Jbin al-Qom, Egypt. She will talk about perception of educational environment with an assessment of motivational learning strategies and emotional intelligence as factors affecting medical students' academic achievement under the category of academic guidance. Prof. Zainab?
I'm with you. Thank you so much for the kind invitation, and I am so happy to participate at your great conference. May you allow me to share my screen, please? Am I ready to talk right now?
Dr. Zainab, you can start.
Yeah. My presentation title is Perception of Educational Environment with an assessment of motivational learning strategies and the emotional intelligence as factors affecting medical achievement. In my introduction, I will talk about the integral education, which is a concept that includes the curriculum of an educational program in which the whole is greater than the sum of the parts. Teaching integration is defined as the organization of learning materials to link or combine frequently taught topics into separate academic courses or departments. In other meaning, it means bridging the links between academic knowledge and the practical applications. So what about Egypt? In Egypt, we adopt new trends and strategies for medical education due to changes in the needs of the society and the expansion of understanding that require the development of existing teaching curriculum of new methods. So, in my topic, I will talk about 3 important parameters: learning environment, learning strategies, and finally, emotional intelligence. Learning environment is defined as it's a concealed curriculum that has a significant impact on student learning. An outstanding atmosphere can demonstrate a high-quality curriculum, although this may be difficult to quantify. Learning strategies are defined by Oxford as engages in activities to assess the acquisition, storage, retrieval, and use of information. Also, they are specific acts made by the students to bring learning to new states that is faster, easier, more successful, pleasurable, self-directed, and finally more convenient. If we talk about emotional intelligence, it's the perception, accessibility, and generation of emotions. For what? To help thought, comprehend, and govern emotions, to help or to improve development intellectually and emotionally. So, in our study, we aim to study the perception of educational environment with assessment of its effects, together with motivation, learning strategies, and emotional intelligence on the most important outcome in the student life, which is academic achievement. We conducted a cross-section study on 3,384 students at randomly chosen Egyptian faculties of medicine from the second to final year, who have experienced both basic and clinical teaching and appear in at least 3 professional examinations. We use 3 tools: Dundee Ready Education Environment Measure, known by DREAM Scale, which is divided into 5 subscales of 50 items. Then we use the Motivated Strategies for Learning questionnaire of 81 items, divided into 2 sections, the motivation one and the learning one. Finally, we applied Emotional Intelligence Questionnaire, which is a self-assessment questionnaire of 50 items. It addresses 5 more important areas, which are self-awareness, managing emotion, motivating oneself, empathy, and social skills. So, what we found? This is a table demonstrating the baseline characteristics of our students. And in it, we could find the following. A total of 3,084 students were recruited, and female represented 63.5 with an overall mean of age of 21.42. 52.2% of the students were of residency, and 88% of them had enough income. The most important parameter in our study is academic achievement, and we could find that 32% of our students achieved excellent score. We conducted a pathway analysis, which is a linear regression analysis of the main factors that stands on the academic achievement, and we find that motivation took the first rank by beta equal to 0.68, followed by learning 1.19, then emotional intelligence, and finally educational environment. So, from the study, we can conclude that a student's motivation was the highly significant predictor to academic achievement, followed by learning, emotional intelligence, and educational environment, although it comes last, but it provides us a very, very significant implication to our study, as the finding reflects the advantage of integrated student-centered system, which improves the student perception of learning environment in an atmosphere of motivation and emotional intelligence. Thank you so much for your listening and paying attention and allowing me to participate at your great conference. A special thanks also to Professor Dr. Hassan and Professor Dr. Minashir, who provide me a great help and support during this study. Thank you so much.
Thank you very much. Our next presenter is Dr. Majid Wadi from the Medical Education Department of College of Medicine of Qasim University in Buraydah. And the topic is on assessment unit in medical education, structure and function. Welcome.
Thank you for introducing me and also for this great opportunity to present my humble work with my colleagues today in the SIMEC conference. Would you please let me share my screen? Yeah, that's good. Thank you. So actually, this work is kind of a reflection what we did in order to share our experience in developing and maintaining also assessment unit in medical education. We will describe structure and function and the perspectives of the assessment unit. Yeah, this is the outline that I would like to share with you, importance and rationale behind developing or launching the assessment unit, organization structure, the framework of the unit, and the resources that we have, and the challenges and opportunity of the unit. The importance, as we know that assessment is a vital part for any educational process. Medical education assessment is crucial and has additional value because graduates of medical school will serve as caregiver, so that it means they are responsible about human lives. So assessment of medical students should be designed and implemented and evaluated very meticulously. Existence of a central body to govern the assessment process in medical school is very recommended. The assessment unit is the location or the place where the utility of assessment, that means the 5 principles of utility of assessment: validity, reliability, education impact, and visibility and cost, can be quantified quantitatively as well as qualitatively approved, so that it can be like a sort of quality assurance process and monitoring. Second point about the organization structure. So in our experience in the developing assessment unit, we launch assessment unit and has some subcommittee. The first one is student assessment committee, which is dealing with scientific part of the exam. That means test item review as well as development. This committee is responsible for providing continuous faculty development program in terms of planning, developing, and evaluating assessment, as well as responsible for conducting a regular meeting pre-exam to check the whether the items as well as other part of assessment or exam are up to the guidelines. The central exam committee, that means dealing with logistics in terms of infrastructure required for running any exam. The third committee is question bank committee, just to keep the questions based on certain criteria that agreed by the unit. And we have finally the formative assessment subcommittee, dealing with assessment for learning and enhance the formative experience of the medical students. Organization, our framework of the unit. In this figure, you can see how the assessment unit work together with these 3 committees. For example, starting from the getting the question from the corresponding course organizer or sometimes from the question bank, then review the question based on the guideline for best quality, review the exams with course organizer based on the ILOs as well as the blueprint, and then psychometric analysis after the exam, reviewing and finalize the result considering appeal of general study student body, and then result approval. This is the main function of the student assessment committee. Central exam committee prepare all logistic for exam as calendar, venues, invigilator, printing, copying, and preparing exam material, supervising the process of exam conduction, and supervise the checking for exam papers. After exam, keeping exam material and results as quality as sorting in the unit, and dealing with appeals from the individual students. Question bank is just receiving input from teacher and submitting items to the student assessment committee for revive. sorting and appropriately tagging for items, and then keeping these items all together within locally developed software. Sometimes we're using the Excel sheet as well as Word file. Of course, all these committees work together in order to run and implement the principle of assessment. And then some question released to the student assessment for formative assessment committee in order to be posted for the student in the learning management system. We use Blackboard, or previously we use other platform. The third point about the resources of the assessment unit, we have human power as well as infrastructure. In terms of human power, we have full-time member as well as part-time member from other departments. Regarding infrastructure, it should be a physical spaces in order to keep everything related to the assessment inside one place, so that we can prove our credentials, as well as facilitate facility and equipment in order to run the exams smoothly. Last point, challenges and opportunity of the assessment unit. Of course, any unit or any newly established body has some challenges. For example, we face some resistance because the student assessment committee related to reviewing the item and then recommend or sometimes delete the items based on the guideline, as well as after exam if there is anything with the psychometric property.
Sorry, Dr. Majid. Please, Dr. Majid,
yes.
Try to conclude.
Yeah, of course. Another challenge is regarding the resources, limited resources. The opportunity for the assessment, it can be a corner for the Aspire recognition by the EMI, as well as international collaboration, as well as local collaboration. So the design, implementation, and evaluation of assessment in medical school is challenging. Establishing an entity for assessment and evaluation of medical students should be a high priority. Assessment unit or similar entity should be lead the all assessment activity. The assessment unit should serve as a consultant for all discipline in the college and provide clear guidance and training assessment practice. Thank you for giving me this chance. Already we published this small paper about the assessment unit. Here the access. Thank you for sharing. Thank you.
Thank you.
Our next presenter, Ms. Noura Benaoun, from the Saudi Council for Health Specialties, Health Academy, Riyadh, Saudi Arabia. She will speak about Healthcare Transformation Initiative, Structured Education Support for National Allied Health Programs in the category of Faculty Development. Ms. Noura?
Thank you so much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to thank you very much for giving me this chance to speak. And also thanks to all of the attendees for your time and attention. It's a professional pleasure for me to speak to you today about Healthcare Transformation Initiative and how we structured education support for National Allied Health Program. In this presentation, I will take you through the background, aim and objectives, methods, results, and conclusion of our work. Health Academy is one of the outcomes of KSA Vision 2030 that contributes to healthcare transformation as education sector for allied health education. The purpose is to fill the job need gap by creating a new vocational training programs and with employment in healthcare sector. These programs target unemployed bachelor graduates and prepare them with the knowledge and skills not limited to clinical coding, dental assistant, patient care technician, and healthcare security that were launched throughout Saudi Arabia at different training centers. A structured framework has been established to facilitate the education and support the training site. The aim of our work is to provide a comprehensive structured education support for these programs. And to achieve this, there are 4 objectives. First, to prepare faculty and the training centers with educational resources. Second, to provide learner support related to needs and challenges. Third, to monitor the implementation of the program. Fourth, to engage learners in extracurricular activities to enhance the sense of belonging in healthcare. There are 4 main activities that represent our work, our methods. Number 1, signing service level agreements with each training center aimed at increasing the performance level, enhancing work quality and consistency, and ensuring to submit the work and requirement on time. 2, assigning health academy coordinator to be fully responsible to follow up a certain training program and manage the day-to-day task through supporting the trainees and the training centers. 3, conducting a kickoff meeting before the start of the program to demonstrate the curriculum and administrative needs, including scheduled dates for collection of education activity data. 4, sending surveys on regular basis to the trainees and faculty for quality and monitoring reasons. Meanwhile, the coordinator retains up-to-date files with relevant program information regularly. Ladies and gentlemen, this methodology results in generating reports, solving training problems and the challenges, achieving standardization, and we realize that we are responsible for quality monitoring as we have a clear and sufficient database of relevant information on a certain program. Last but not least, all of this leads to a smooth education journey from start to finish. Finally, a process was established with a systematic framework to improve the training and delivery and to ensure effectiveness and efficiency. Thank you for your listening, and now back to the moderators.
And of course, we'll allow around 10 minutes for discussion if you have any questions or comments to all the presenters.
Thank you very much for the chance, and we enjoy the presentation, which is really focused and informative. My first question to the abstract regarding evaluation of program of family medicines. I'm asked the presenter, do you consider in your questionnaire DREAM? Because the questionnaire is a standardized and structured questionnaire which allow a better reflection, or you modify it. Number 2, many studies conducted here in Kingdom of Saudi Arabia. One of them is Bisha University for undergraduate. They have a study published here in Kingdom of Saudi Arabia with good result in comparison to other study. And as far as I know, in this university, King Khalid University, Department of Medical Education, they have similar study. So it will give a good opinion and idea when you compare with the setup here locally. The second question regarding the team-based learning, I think by Dr. Abir. We want to know, as a reader, I want to know who was the target? Which level of the target? Second year, third year, fourth year? This will give good impression of how people, they perceive team-based learning. Number second, is it the sole modality or strategy of learning, or it is concomitant with other, like problem-based or lecture-based? And I think the perception will be better if it was comparing team-based learning with other set of study. Another question for the abstract regarding the structure of the assessment unit in Al Qasim University. I think 2 things miss for me. Is this subdivision of quality or subdivision of medical education. However, we want to know the reflection on psychometric analysis. In this unit, when they did their psychometric analysis, how they manage it. Thank you very much.
Thank you. So I hope our presenters are with us online still.
Assalamu alaikum.
Sorry, we'll allow just 1 minute for the answer. Sorry. Yes.
Okay. So regarding the research evaluation of learning environment, you ask about if the questionnaire is modified or actually it's only one question was modified related to the on-call, because in family medicine we don't have in on-call, and I mentioned in the limitation the qualitative part was missing. So in the future maybe mixed method to enlighten more on the other area. And regarding the other question, it's related why we compare it in we have a previous study, because in family medicine program the previous study the result was not the one we want, and there is many change in the family medicine program, a change of the curriculum from 4 years to 3 years. Within the transformation system there is many change, including the primary healthcare setting. Also in Saudi Arabia many program of family medicine was changed to academy and Jeddah in the process. So that is why we do this study. I hope I answer you.
Thank you, Dr. Abir. The second speaker from Qasim University Medical Education Unit.
Assalamu alaikum. Thank you for this two important questions. Really, I missed to stress about it. Regarding the first one is regarding about the place of assessment unit in the college organization chart, whether it is belonging to the quality or the medical education department. In reality, the assessment unit is in between two bodies. The first one is under medical education as a subunit, and as well as it's directly run as independent body by the academic affair. That means Vice Dean of Academic Affair. The relationship between the assessment unit as well as quality assurance unit, of course, we provide the evidence that quality assurance requested, either in terms of report exam, in terms of reporting the item review process, all things that related to the quality assurance. We provide these documents, and we keep also a copy in our unit. The second point about the psychometric property or analysis of the items, of course, we run it after exam. Based on this psychometric property, we either delete the questions, or those questions with good criteria we keep in our question bank for further use, maybe the next exam or other exams. Or sometimes, if the misconception among the students, we provide this question to the formative assessment unit so that they can post it in the learning management system. We're using Blackboard in order to make the student able to see their answers and how they perform. This is about the psychometric property as well as the place of assessment unit in the college organization chart. I hope I could answer the question.
Thank you, Dr. Majid. The third question is for Dr. Salma regarding the team-based learning. Dr. Salma, are you with us?
Yes, Assalamu alaikum. Regarding to the question whether we introduce this method of learning, yes, it was integrated. So we had TBL, we have traditional lecture, and also we have PPL, because we have to fulfill all the needs of the student, and we know that the learning method for students are totally different. Some students, they are really shy, and some of them, they have visual or auditory learning. So we introduce this part as a part of the courses, and actually we target all the students at the dental school at PNU, second, third, fourth, and fifth. And as I mentioned, we use the different sessions, either the traditional way, which is 3 hours, and then we introduce a new one, which we call it mini TPL, to see if introducing a new one with limited time, because the third and fourth year they have really very tight schedule, and they don't have that space in their curriculum. So we target all the dental students, and as I mentioned, the result and the response from the dental student, all of them, they agree that it improved their skills, although the traditional, which is a 3-hour sessions, were get or received more satisfaction from the student.
Very much. Professor Zahir, you have some comment for us.
السلام عليكم جميعا ورحمة الله وبركاته. أنا أسأل الله أن يكون كلامي سهلا لينا على القلوب، وألا يثير ضغينة أو عداء من أحد. دكتورة، تعدوني بذلك؟ يعني أقدر أتكلم براحتي، ما علي إشكال. ما أنا خايف والله خايف. أنا سؤالي: ما الذي يحثنا في مثل هذه اللقاءات على التحدث باللغة الإنجليزية؟ أنا أبغى أسأل نفسي السؤال. كل المتحدثين كانوا بارعين وكانوا ممتعين، لكن هل كان بالإمكان أن يكونوا أكثر إمتاعاً لو تحدثوا باللغة العربية؟ هذا أول سؤال. نمرة 2: هل الحاضرون كان ممكن يكونوا أكثر استمتاعاً ومتابعة لو كان الحديث باللغة العربية؟ نمرة 3: كم في المية من الأشياء التي قيلت من صباح اليوم إلى الآن لا يمكن أن تقال باللغة العربية؟ يبغالنا الليلة قبل ما ننام نسأل أنفسنا كل واحد: إيش معنى السويد، النرويج، الدنمارك، هولندا، إسرائيل، كلهم يعلموا ويتعلموا الطب بلغاتهم المحلية مع إجادة لغات أجنبية. طب وليه لا؟ إحنا أمة من 400 مليون نسمة، لماذا؟ بس. والسلام عليكم.
يمكن لاحظتوا اليوم في الجوائز في جوائز لكاتيجوريز باللغه العربيه او لاشياء باللغه العربيه، وهذا لفت نظري صراحه في البرنامج. فان شاء الله انه هذه تكون يعني برضو يعني خطوه اولى لتعريب بعض المحتوى. يعني احنا عندنا كان اليوم في بعض المتحدثين من خارج المملكه ونفهم انه يعني لازم يكون بالانجلش، لكن انا لاحظ لي في الجوائز لو شفتوا في الصفحات الاولانيه من الكتيب في جوائز للغه العربيه، الكتب باللغه العربيه، الرشر باللغه العربيه، الاسيل او اللي هي المقتطفات اللي كاتبينها الطلاب باللغه العربيه. فهذا اصلا لفت نظري، واتوقع انه الجمعيه السعوديه للتعليم الطبي حاطه هذا الموضوع في يعني تحت عيونها، بدليل انه ظهر في الجوائز اليوم. شكرا بروف، شكرا جزيلا، وان شاء الله ندعو للجلسه القادمه.
السلام عليكم ورحمة الله وبركاته، مساكم الله بالخير جميعا، ويسعدنا أن نكون في هذه الجلسة المباركة ونتكلم عن التعليم الأونلاين ليرنينج. وحقيقة أن نعجز عن تقديم الزملاء المقدمين وعلى رأسهم سعادة البروفيسور زهير السباعي، وأنا حقيقة أشعر بالفخر أني أقدمه كشخصية هذا اليوم، وسأحاول تقديمه باللغة العربية نزولا عند رغبتي. وسوف يتكلم اليوم عن الواقع الافتراضي في التعليم الطبي. الدكتور زهير أو الأستاذ الدكتور زهير معروف للجميع جميعا، وهو من مؤسسي الطب في المملكة العربية السعودية. لديه الزمالة الملكية البريطانية للأطباء بريطانيا سنة 93، دكتوراه في التخطيط الصحي جامعة جون هوبكنز، ماجستير في الصحة الدولية، دبلوم طب المناطق الحارة، وبكالوريوس طب والجراحة عام 63. رئيس الجمعية السعودية لطب الأسرة، مدير إدارة التخطيط والبرامج بوزارة الصحة، العميد المؤسس لكلية الطب في أبها، والتي نحن اليوم في ظل هذا المؤتمر الجميل من ثمراته وإن شاء الله سبحانه وتعالى تكون في ميزان حسناته. أستاذ طب الأسرة والمجتمع بجامعة الملك سعود، رئيس تحرير مجلة طب الأسرة، عضو مجلس الشورى، رئيس مجلس إدارة معاهد السباعي، رئيس المجلس العربي لطب الأسرة، عضو مجلس أمناء جامعة الخليج العربي، رئيس مجلس إدارة الشركة الاختصاصية المتميزة، ورئيس جمعية تعزيز الصحة، ورئيس مجلس إدارة شركة الأحماض الحيوية. سوف يتكلم هذه الجلسة عن الواقع الافتراضي في التعليم الطبي، ونتشرف بوجود البروفيسور زهير السباعي معنا لهذا اليوم. ونظرا لضيق الوقت حقيقة فسوف يختصر الوقت إلى 25 دقيقة، وأتمنى من سعادة البروفيسور الوقت هذا بإذن الله سبحانه وتعالى على أساس نمشي مع بقية البرنامج المحدد للجميع. شكرا لكم، ويسعدنا الترحيب بسعادة البروفيسور زهير السباعي.
موضوع حديثي ليس عن التعلم عن بعد، لأنه مع إيماني بأن التعلم عن بعد هو طريق المستقبل، ولكني ذكرت للجنة المنظمة أني أنا أقترح موضوع آخر وافقوني عليه، بس عاد يعني انكتب بالخطأ، معلش اعذروني. هذه أول واحدة. كمان تعذروني أن أنا حتكلم باللغة العربية، وما ذاك إلا إيماني العميق بأننا كلنا يعني قادرون على التعبير عن أنفسنا باللغة الأم أفضل بكثير مهما كان تعليمنا باللغات الأجنبية، وكلنا أقدر على المتابعة والاستمتاع بما يقال بلغتنا الأم أكثر من أي لغة أجنبية. وهذا لا يعني إهمال اللغات الأجنبية، بل حتمية إجادة اللغات الأجنبية لغة وأكثر، حتمية. ولكن يجب أن نفرق بين أن نتعلم لغة وأن نعلم لغة، أن نتعلم لغة أو نتعلم بلغة. التعليم بلغة الأم هو القاعدة، خاصة إنه أساس التعليم هو الحوار وليس المحاضرات. كلنا نعرف، أنتم كلكم أساتذة في هذا المجال. الحوار، والحوار لا يتسنى لطلاب الطب بلغة أخرى غير لغة الأم، الانطلاق في التعبير. فمعليش اعذروني واستحملوني. حديثي اليوم عن الرحلات اللي كنا نقيمها لطلاب الطب في جامعة الملك سعود زمان. نعم، بدأتها الحقيقة واستمرت سنويا، ناخذ الطلاب إلى مناطق المملكة المختلفة لمدة 10 أيام يلمسوا عن قرب أسباب المشاكل الصحية في المجتمع، القضايا الاجتماعية والاقتصادية والبيئية والأسرية. بيحسوا فعلا بأنهم هم بيعايشوا المشكلة الطبية من جذورها. ما زلت أتذكر، طبعا أنا إن شاء الله أخلص في 25 دقيقة وقبلها، لكن برضو لي اعتراض من ناحية المبدأ. قبل ما أجي تقولوا لي ترى أنت حتقدم في 25 دقيقة وليس 30 دقيقة. 5 دقائق 30 نبقى على شرط. وأنت كمان تديني 5 دقائق. لا أنسى أول مرة فكرت في أني أنا آخذ الطلاب، وكانت سابقة طبعا، ما كانت غير كلية طب واحدة في المملكة جامعة الملك سعود. فأول مرة فكرت آخذ الطلاب إلى الحقل وجدت معارضة شديدة جدا في مجلس الكلية، وكان رأي الزملاء خاصة الشباب يا أخي هذا تضييع وقت، تخرجهم من الفصول وتخرجهم من المستشفى وتوديهم. فقمت في ثورة الشباب، طبعا أنا كنت في الشباب الأول، دحين في الشباب الثاني. قلت لهم أنا يؤسفني أن أنا أنتمي لمثل هذه الكلية التي لا تدرك أن أسباب المشاكل الصحية في المجتمع وليس في داخل الفصول وردهات المستشفيات. فحنوا علي وخلوني آخذ مجموعة الطلاب في سنة رابعة كلية الطب بأقل الإمكانات، ما فيش إمكانات الدونية، وأخذنا الطلاب والطلاب استمتعوا. أخذتهم على خيبر وعلا والمناطق دي، وفحصنا مجموعات من السكان للبلهارسيا والملاريا، ودخلوا البيوت وسووا تطعيمات وجلسوا مع الأسر. رجعوا هم في غاية السعادة. بعد كده تكررت رحلاتنا إلى تمنية هنا في الجنوب، إلى وادي فاطمة. كل سنة نطلع برحلة، وكل سنة نتعلم شيء جديد، كل سنة نتعلم جديد وندرك النواقص اللي كنا فيها، إلى أن جاءت آخر رحلة أخذتهم فيها كانت إلى القصيم. وبعدها أكرمني الله بأننا جيت إلى أبها، وكنت أتمنى استنى في أبها بس ما أهلوني الجماعة اللي هنا، ما يجرى شيء. هذه الرحلات أثرتنا كثير. آخر رحلة اللي سأتحدث عنها كانت إلى القصيم، وخليني أتكلم عن تفاصيلها أثناء السلايدز اللي أعرضها. هذه التقنيات الحديثة دي أنا ما أعرف لها. مين هنا يجي يدلنا كيف؟ بس هنا ما هنا ثابتة. هي لا طيب هي طيب هذه القصيم. لا قبلها الحقيقة أخذنا طلابنا من الرياض. كنا أول رحلة كانت إلى خيبر والعلا والمدينة، وكانت هذه فاتحة جميلة جدا. ثم بعد كده أخذناهم إلى وادي فاطمة، ثم إلى تمنية في الجنوب، ثم أرسلت مجموعة منهم مع أحد الأساتذة إلى المجمعة، ثم رحنا إلى القطيف. فكانت الحقيقة فيها إثارة وفيها علم وفيها. وأجمل شيء أنا شفته في هذا المؤتمر إلى جانب الحضور الكرام هو الطلاب الحقيقة اللي قاموا وكانوا العماد الأساسي لنجاح هذا المؤتمر، ونعتبره جدا ناجح. هذا شيء جميل، هذا شيء جميل جدا. نأتي إلى رحلة القصيم اللي هي فيها اللي حنتحدث عنها. القصيم وهذا وإحنا في طريقنا القصيم. الإعداد لرحلة القصيم أخذ 4 إلى 5 شهور، لأن تعلمنا من تجاربنا السابقة. كنت أروح معايا بعض الأساتذة وأحيانا بعض الطلاب في رحلات مكوكية بالسيارات من الرياض للقصيم للإعداد لمشروعنا هذا. نعم. لما سافرنا كنا 70 واحد، وكان عندنا ميزانية شبه ضخمة من الجامعة. آمنت الجامعة بأنه والله اللي بيصير هذا له قيمة. 70 واحد ما بين طلاب وما بين أساتذة وما بين مساعدين مختبر وإلى آخره. نعم. من قبل رحلتنا ب5 شهور وزعنا الطلاب على مجموعتين، كل مجموعة 3 أشخاص أو نحو، كانوا حوالي 30 طالب، كانوا 20 مجموعة. كل أستاذ أخذ مجموعة عشان يدربها على الموضوع الذي سيشتغل عليه في القصيم. أحد الأساتذة كان مهتم بأمراض الطفيليات، فدرب طلابه على أمراض الطفيليات في القصيم قبلها بعدة شهور قبل ما نذهب. أحد الأساتذة كان يعني أمراض العيون، أخذ طلابه ودربهم. أحد الأساتذة كان عن أمراض الأنف والأذن والحنجرة، يعني أقصد فحص طلاب المدارس. أستاذ الجراحة كان عنده اهتمام بالطب الشعبي. على مدى عدة شهور كانوا الطلبة في هذه المجموعات يتدربوا على الشيء اللي حيسووه. ثم قبل ما نسافر بعدة شهور وزعنا مجموعات الطلاب وحطينا عليهم المسؤوليات. هذه المجموعة عليها السفر، وهذه عليها الإقامة، وهذه عليها السكن، وهذه عليها المعدات. يعني أحمد الله إنه كان، وهذا كله مسجل في كتاب اسمه قصيم هيلث إن قصيم، أوريكم صورته فيما بعد، بالإضافة إلى فيلم 16 ملم أتسجل في هذه الرحلة. هذه كلها كانت نتيجة تجاربنا المتعاقبة في العمل الحقلي. نعود إلى الشرائح. أمارة منطقة القصيم، مركز أمارة الخصيبة. الخصيبة هي القرية التي اخترناها، ولكن حرصا مننا على مشاركة أفراد المجتمع، وعندنا إحنا ميزانية من الجامعة، كنا بنقول وإحنا بنزور القرى: ترى يا جماعة إحنا لن نختار القرية اللي حنجري فيها هذا التدريب الطلابي ونجمع معلومات طبية إلا القرية التي تعطينا إمكانات. إيش الإمكانات؟ السكن مجانا وسيارات، ما عندنا فلوس، لكن كان الغرض هو إشراك المجتمع نفسه في هذه القضية. كانت لقاءات متعددة بشيوخ القبائل. هذا أمير الخصيبة، رجل كمل يعني، وجلسنا معه عدة جلسات قبل ما نذهب بالطلاب والأساتذة للتعريف بمشروعنا ما هو وإيش اللي نريد وإيش النتائج التي نتوقع. مو بس الأمير وإنما أفراد المجتمع. فالحقيقة كان اجتماعات متتالية معاهم: إحنا إيش جايين هنا نسوي وإيش أهدافنا وإيش نبغى نحقق. طبعا أنا ما راح أتكلم بالتفصيل، وإنما رؤوس أقلام عشان بعد كده نترك فرصة للحوار حول الموضوع ده. المشاركين الفاكولتي ممبرز كانوا 13، والسبيشاليست كانوا 5. أقصد سبيشاليست برا أسوار الجامعة. حرصنا على أن نستقطب ناس من غير الجامعة، من أمانة مدينة الرياض، من غيرها، برضو لذابة الفواصل ما بين الجامعة والآخرين. بعدين عدد الطلاب كانوا 30، وهيلث أسيستنتس ما بين مساعدين مختبر وممرضات وإلى آخره كانوا حوالي 22. المجموع كانوا 70 واحد. النشاطات التي مارسناها هي كلينيكال اندسز، حنشوفها الآن، anthropometric measurements عشان الويستنج والستنتنج وإلى آخره. ما علينا ساعات بغلط ما بين العربي والإنجليزي، بس الإنجليزي جدا في حدود ضيقة. الأميبا، دكتور فالح الفالح على ما أذكر كان عنده اهتمام بالأميبا. أوكولار ستاتس كان الله يرحمه الدكتور حسام بدر توفى،
كان عنده اهتمام هو استشاري العيون. ENT الدكتور سراج زقزوق أستاذ الأنف والأذن والحنجرة. السوشيو ايكونوميك انفيرومنتال هيلث هذا كان الاستشاري اللي جبناه من أمانة العاصمة. النشاطات اللي في البرايمري هيلث كير، الهيلث مان باور اللي موجودين في القصيم، نيتيف ميديسن هذا كان أستاذ الجراحة، الحوادث السيارات. بدون أن نطيل، كل هذه النشاطات تولاها الطلبة بتدريب حوالي 3 شهور قبل أن نذهب إلى القصيم. الأهم ملامح الموضوع إنه المانجمنت كان بالطلاب زي ما سووا الإخوة المسؤولين عن هذا المؤتمر. بعدين integration between departments، كنا حريصين مو بس طب الأسرة والمجتمع، لا إطلاقا، وإنما معانا حقون الجراحة وحقون الباطنة وحقون الأنف والأذن والحنجرة وهم كانوا بيقبلوا عليه لأنه عندنا تاريخ طيب قبلها ب4 5 سنوات. بعدين كانت القضية problem solving أكثر من أي شيء آخر، لأنه كنا في الأمسيات نجلس ونتحدث وكل مجموعة تعرض إيش اللي شافته، وطبعا كان في تهريج وضحك ولعب يعني شيء بالمرة، كان جلسات جميلة ممتعة وفي نفس الوقت والكوميونيتي بارتيسيبيشن، وهذا جزء أساسي ححدثكم عنه الآن. يعني مثلا هنا كان القصيم أيوه عدد السكان يعني سووها الطلاب، لكن اللي وبعدين الايج جروبس كل هذه الطلاب هم اللي سووها. ناتي هذه لها قصه. ما كان في خريطه للخصيبه، طب ايش نسوي؟ فاتصلنا بمدير المدرسه وابدوا مجموعه من الاساتذه استعدادهم انهم هم ينمروا البيوت، وهم اللي جابوا الالوان والفرش ومروا على كل بيت في القصيبه عشان ينمروه. بعد كده جبنا واحد فني من البلديات سوى لنا هذه الخريطه. فهذه مشاركة المجتمع يعني أثمرت. طبعا في الفحوصات الطبية، في الهيلث بيرسونيل الديستريبيوشن حقهم في المنطقة، في الاوكيبانسي ريتس بتاعت المستشفى، في ادميشنز ديسشارج في البريدة هوسبيتال، كلها سووها الطلاب. البريدة جنرال هوسبيتال مان باور، لا أريد أن أطيل وإنما هي الملامح، النمبر اوف بيشنتس اتندينج. بعدين حاجة زي كده ما كانت تمر كده بسهولة. الطلاب طبعا هذه صارت فيما بعد التيبلز والأشياء دي، ولكن النتائج كانوا بيلاحظوها الطلاب، فكانت في الأمسيات نتناقش طيب قديش معدل المرضى اللي بيشوفهم الطبيب، طب الطبيب قديش يبذل بالنسبة للمريض، طيب إذا كان في دقيقتين كما إحنا لاحظنا يا طلاب، هل الدقيقتين تكفي ولا ما تكفي؟ كل هذه الأشياء كانت تثار وتطرح للحوار والنقاش. بعدين البرايمري هيلث كير برضو عدد المرضى والافريج بير يونت الى اخره، كل هذه الاشياء. بعدين في عندنا العين والخصيبه، مركزنا الرئيسي كان في الخصيبه والعين كان قريه الى جانبها، فابتدوا الطلاب يحطوا الارقام التشخيصات. واضح انه التشخيصات هي عباره عن تشخيص الاعراض، ما هي تشخيص المرض. طبعا ليش؟ هذه قضيه تطرح للسؤال، ليش؟ ايش اللي بيصير؟ ايش اللي بيحصل؟ انه في بعض العين فيها مجموعه من التشخيصات التي سجلت، مثلا كونجنكتيفايتس 212 وهناك ولا واحد. يا هل ترى هل هذا صحيح؟ هل هذا مضبوط؟ هل هذا مبني على اسس علميه؟ هذا كان مدار الحديث ومدار الحوار للطلاب، ما هيش مجرد جمع معلومات. الدراجز بريسكرايب، الانتيبيوتكس، بعدين تجد فوارق كبيره جدا ما بين العين والخصيبه. ليش هذه الفوارق؟ هل هي حقيقيه؟ هل هي فعليه؟ هل قريه بتصاب بامراض القريه الثانيه ما تصاب بها؟ لا، مو معقول، لان يعني هذه في فتره قصيره محدوده. اذا المساله ترى يبغى لها اعاده نظر. طبعا هذا كله سجل في الكتاب وارسل وطلب منه وارسل، عاد النتائج هذه ما هي بيدنا احنا. نعم. أنا والله لا أريد أطيل عليكم. طبعا توزيع على الأطفال ما بين وايت ونقروا المنطقة فيها مستوى الهايجين ما بين الطلاب جود مودريت باد، الانثروبومتريك ميجرمنت عشان نقيس الستانتنج والويستنج، وبعدين تحليل للموضوع، برضو تحليل. أنا بستعجل إنما هذه كانت يعني هذه ستول اكزامينيشن كانوا بيفحصوا البراز أكرمكم الله وبيتحدثوا بيشوفوا الانتميبا هيستوليتيكا والجيارديا لامبسس والهيمينوب بسنانة بين أطفال المدارس إلى آخره. بعدين كان عندنا خدمات للمجتمع لأنه كانت نسبة التطعيم قليلة جدا. هذا قبل ما يصدر القرار بأنه كل طفل قبل ما يروح المدرسة لازم يطعم، فكنا الطلاب أيضا كانوا بيطعموا. نعم. فحص الأنف والأذن والحنجرة، هذا أستاذ الجراحة بيدرس مع مجموعة من الطلاب الطب الشعبي. هذه لها قصة، ما كان في حسبان أن احنا نكشف على السل وتصوير الصدر. لما رحنا هناك وجدنا الإمكانات موجودة فجبنا الإمكانات ودخلناها معانا في المشروع، ما أدخلناها في نتائج الدراسة، ما كنا مخططين لها سابقا بشكل جيد. وجدنا أن مجرد وجود آلات وصور أشعة هذه يعني ما هي داخلة في ضمن الاندسز، الهيلث اندسز او المعايير الصحيه اللي احنا كنا حاطينها لانفسنا. فاضطرينا بكل المجهود اللي سويناه حطينا على جنب لانه النتائج ما هي علميه، ما نستطيع ان نحن نستفيد. هذا يدلنا على اهميه التخطيط المسبق في اي شيء. الرود اكسيدنتس ما بين بريده وعنيزه والرص المين اوت كمز. كل أستاذ نشر مجموعة من البحوث وشكر فيها مجموعة الطلاب اللي شاركوا معه. طلعنا كتاب هيلث بروفايل اوف قسيم، انطبع مرتين. طلعنا 16 ملم دوكيومنتري فيلم. صار في كوميونيتي اويرنس. هذا يذكرني، بس هنا ما سويناها في القصيم. في الأربع المرات السابقة، لا 3 مرات منها كنا نتفق مع مدير المدرسة في القرية اللي فيها، وإحنا أقرب واحدة كانت تمنية هنا في الجنوب، وجانا الأمير خالد الله يحفظه وزارنا هناك. خرجنا مجموعة طلاب والأساتذة المشرفين عليهم وطلاب المدارس وأساتذتهم نكنس الشوارع، ننظف الشوارع. والرسالة كانت إنه مهمتنا كأطباء للمستقبل ليس فقط إننا نشوف المرضى داخل غرف مكيفة، وإنما لابد نخرج إلى المجتمع. وهذا يذكرني بطرفة أخرى، طرفة لأنها كانت فعلا يعني شيء يهز. كنت بأدي دورة في الرعاية الصحية الأولية في قرى بنغلاديش، والطبيب في الأطباء اللي في القرى، والطبيب في بنغلاديش كثير من الدول النامية يعني استغفر الله نصف إله، لا يتصور نفسه إلا يعني في معزل عن العالمين. اللي موجودين كانوا 20 في الدورة أو 25. ففرضت عليهم في أحد أيام الدورة أن نحن نخرج كلنا ببكرة أبينا وننظف القرية. ساروا شيء. أنا طبيب، لا اللي يبغى شهادة ينزل معانا الميدان يا حميدان. واضطروا ونزلنا الميدان، جبنا المكانس والهذا. طبعا الجمهور شافنا، اهالي القريه طبعا تسارعوا يحطوا يدهم مع يدنا. هذه كانت الرساله. طبعا ما ادري استمرت ولا ما استمرت، لكن على اقل تقدير كانت محاوله لاشعار الفريق الطبي، ترى فريق طبي مكانك ليس فقط داخل 4 جدران وتعالج المريض بعد ان يمرض. ترى انت لك دور كبير في حفظ الصحه. وقالها ابن سينا قبل 1000 سنة: الطب وحفظ الصحة وبرء مرض. بس إحنا بننسى. هذا صورة الكتاب، وأنا أشكركم جزيل الشكر. هل كانت انتم متابعتكم بالانجليزي؟ ارجوكم بكل امانه، اللي يعتقد انه حديثي باللغه العربيه وصل الرساله بشكل افضل، ارجوكم يرفع يده، ارجوكم. طيب جزاكم الله خير. واللي يعتقد اني لو تحدثت باللغه الانجليزيه افضل، بالله يرفع يده وبكل امانه. أرجو أنها تسجل لصالحي هذه. واحد هناك لا استنى، احنا ما ترى لابد بيني وبينك شيء. الله أعلم. يا جماعة، يا إخواني الكرام، أنتم عارفين إنه نسبة كلمات العلمية في كليات في كتب الطب كلها في متوسطها قديش؟ في بعضكم قرأ كتابي ويعرف الإجابة. 3 أو 3/10%، إذا استثنينا التكرار. أرجوكم أعيدوا النظر. شكرا لكم.
شكرا بروف زهير على هذه المحاضرة القيمة، ونعتذر أن ضغطنا عليك في الوقت، لكن كان في تأخير شوية، فبارك الله في عمرك وجهدك وجزاك الله خيرا. ويسعدنا أن نستضيف المتحدث الثاني الأخ الدكتور سامي الحيدر ليحدثنا على undergraduate students perceive online learning. لا ممكن يجلسنا كان يخلصون. الدكتور سامي الحيدر is physician educator, consultant interventional pediatric pulmonologist and associate professor of pediatric. Dr. Haider comes with extensive experience in undergraduate and postgraduate education. He served as program director and chair of Scientific Council in Saudi Board of Pediatrics, Saudi Commission for Health Specialty. Also, he is the director of Continuous Medical Education Department in King Faisal Specialist Hospital and Research Center. He holds a Master of Science in Medical Education, University of Calgary, and a Master in Business Administration, University of Tennessee. Currently, Dr. Haider is Executive Director of Training at Saudi Health Commission and Chair of National Central Training Committee, and involved with many national initiatives that include well-being and support of trainee competency-based education curriculum, development improvement and training quality, establish of new postgraduate program, faculty development, national matching system, government training, economy, postgraduate educational, and other. We are honored to have you with us today, and the floor is yours. Thank you.
بروف علي. السلام عليكم ورحمة الله وبركاته، وأسعد الله مساءكم جميعا بكل خير. ويتنج بانتظار الشرائح. سيكون موقفي أصعب بعد الدكتور مصطفى. أسعد الله مساءكم جميعا بكل خير، وبانتظار وجود الشرائح على العرض. نعم. طيب. الحقيقة بداية أشكر الجمعية السعودية للتعليم الطبي على إتاحة الفرصة للمشاركة في هذا المؤتمر الرائع الحقيقة، وشكرا على هذه الأجواء اللي افتقدناها مع ظروف الجائحة. سعدت بلقاء مجموعة من الزملاء والزميلات المهتمين بالتعليم الطبي، وهنيئا لهذا الوطن المعطاء بهذا الحراك العلمي الرائع. القطاع الصحي الحقيقة ينتظر الكثير، ومنظومة التحول الوطني تنتظر الكثير من مخرجات التعليم الجامعي والتعليم العالي كذلك فيما يخص إيجاد الكوادر والقدرات والإمكانيات للموارد البشرية في القطاع الصحي. الحقيقة الموضوع ضخم، يعني طلب مني الحديث عن achieving excellence in health specialty training at the national level, the way forward. وأتمنى خلال الدقائق القادمة أني أخذكم برحلة ستكون سريعة. أنا فقدت السيطرة على الشرائح، لا يمكن تغييرها للأمام ولا للخلف. إذا ممكن مساعدة طيب. بداية الحقيقة nothing specific to disclose except أني أنا أحد خريجين الهيئة السعودية للتخصصات الصحية throughout البايبلاين. حظيت وسعدت بتجربة أن أكون في يوم من الأيام طبيب متدرب، وبعدها انتقلت إلى تمثيل متدربين، ثم مشارك في العملية التدريبية، ثم مدير للبرنامج، ثم حظيت بثقة زملائي في المجلس العلمي لطب الأطفال، ورأست المجلس العلمي لفترة من الفترات. ومن ثم الحقيقة حملت مسؤولية ليست هينة في الهيئة السعودية الإدارة التنفيذية للتدريب. سأحاول خلال الربع ساعة القادمة أن أخذكم في هدفين كبيرين. الهدف الأول Saudi Commission for Health Specialty Evolving Strategy and Experience to lead postgraduate health training to meet national healthcare demands, and the national state of postgraduate health training in Saudi Arabia based on real data. الحقيقة الهيئة السعودية للتخصصات الصحية أحد مكونات الجهاز الخاص بالتعليم العالي للقطاع الصحي، بالإضافة إلى دور منظم رئيسي فيما يخص التصنيف والتسجيل للممارسين في القطاع الصحي. قبل 30 سنة بالضبط تم صدور القرار بالمرسوم الملكي في عهد المغفور له خادم الحرمين الشريفين الملك فهد بن عبد العزيز، ونص الحقيقة ذلك المرسوم على مهام نوعية سبقت بها المملكة المنطقة، ووضعتها في مقدمة الدول التي ترعى تنظيم التسجيل والتصنيف، وكذلك وضع أسس التعليم الطبي في الدراسات العليا على مختلف التخصصات. في الفترة الأخيرة الحقيقة حظيت الهيئة بتحول كبير شمل بناء مؤسسي مبني على خطط استراتيجية حتى تواكب هذا الحمل الوطني الكبير لتحقيق الطموح فيما يخص تأمين القطاع الصحي بالكوادر البشرية ذات الكفاءة والجدارة العالية. رسالة الهيئة كما يعلم الجميع هي مجتمع صحي بكفاءات مؤهلة على أفضل المعايير، ورسالة الهيئة هي حماية وتعزيز الصحة بقيادة ممارسين صحيين يخدمون المجتمع بإنسانية وكفاءة. وتشاهدون بشكل واضح جدا تكرار عبارات الكفاءة والجدارة، عبارات الإنسانية في تقديم الرعاية الصحية، وهو ما انعكس على عمليات وخدمات وأدوار الهيئة السعودية وشركاء الهيئة السعودية الذين يتوزعون في مختلف مناطق المملكة. أحد أكبر التحديات التي واجهتها الهيئة هي الوضع الفريد للهيئة السعودية في التعامل مع مختلف المسارات الصحية، ليس فقط للطب فقط بتخصصاته وفروعه المتعددة، بل شمل ذلك تخصصات طب الأسنان، العلوم الطبية التطبيقية، التمريض والصيدلة. لعلي أبدأ رحلتي في رحلة المملكة إن ساق لي اختصارها في هذا اللقاء، وهي ضخمة الحقيقة، وأعتذر إن فقد العرض جزء أو مكون رئيسي. لعلي أبدأ بالخطط الاستراتيجية التي حصلت في آخر دورتين استراتيجيتين في الهيئة السعودية على مدى السبع سنوات الماضية. أحد أهم المخرجات المرتبطة بالتدريب في القطاع الصحي كانت هي برنامج التميز الوطني في التدريب الصحي، وهي الحقيقة رحلة أود مشاركتكم إياها. انطلقت بواكير تلك الرحلة في 2018، وكان جزء منكم من الحضور جزء ممن شارك في توجيه الهيئة تجاه هذه الرحلة. واكبت هذه الرحلة التحول الضخم الذي تشهده مملكتنا الغالية في إطلاق برامج التحول الوطني وإطلاق الموديل اوف كير أو نموذج الرعاية الصحية، وكانت فرصة للهيئة السعودية أن تواكب هذا النموذج من التحول الداخلي في الهيئة مع نموذج الرعاية الصحية. وكان سبب هذا التحول هو تحقيق هذه المستهدفات: ضمان أفضل بيئة تدريبية، تخريج ممارسين صحيين أكفاء، تحقيق أفضل قيمة محصلة للرعاية الصحية، وحماية وتعزيز الصحة بتوازن لا يخل بتحقيق أحد تلك المكونات دون الآخر. كيف يمكن تحقيق هذا التميز الوطني في التدريب الصحي؟ كان ذلك عن طريق استهداف التمكين. لن تستطيع الهيئة كجهة مركزية أن تحقق هذا الأمر بدون تمكين الشركاء المنتشرين في مختلف القطاعات والمناطق في المملكة، سواء في قطاعات التعليم العالي سابقا أو وزارة التعليم والمستشفيات والكليات في الجامعات، أو كذلك القطاعات المقدمة للصحة وفي مقدمتها وزارة الصحة، والقطاعات الأخرى في القطاعات العسكرية في وزارة الدفاع والحرس الوطني ووزارة الداخلية، وكذلك القطاعات الأخرى وفي مقدمتها الدور المتنامي للقطاع الخاص. كذلك كان المستهدف هو التميز وليس فقط بتحقيق الحد الأدنى من تلك المنجزات، أن يكون ذلك مصاحبا بقياس لنتمكن من معرفة أين نقف وكيف نتجاوز التحديات. اتضح جليا أن هذا التحول يتطلب كثير من الدعم لمكونات متفاوتة في نضجها في القطاع الصحي، وكان هنالك واضح جدا أن هنالك حاجة ليس فقط لبناء مكونات جديدة، بل eliminating أو إزالة مكونات قد لا تكون من الفاعلية أن تبقى في هذا الوقت من تطور المنظومة الصحية والتعليمية. استهدف برنامج التميز الوطني ببساطة 3 مستهدفات رئيسية من مكونات العمل داخل الهيئة فيما يخص برنامج الدراسات العليا: الأكريديتيشن أو الاعتماد، تطوير التدريب والعملية التدريبية، وكذلك استهداف الجودة بطريقة ممنهجة وفق مفاهيم الجودة. كيف توصلت الهيئة إلى هذه المبادرة وهذا المشروع؟ كما ذكرت في بداية أو منتصف 2018 الحقيقة الهيئة أطلقت حملة كانت جالت المملكة من شرقها إلى غربها. كان هنالك ملتقيات للاعتماد التقى فيها مختلف المهتمين وقادة التدريب الصحي في المستشفيات والمراكز الصحية، وكان خلال هذا النقاشات الحقيقة النظر في إمكانية التحول الذي يمكن أن تقوده الهيئة مع الشركاء لتحقيق ما نصبو إليه في برامج الدراسات العليا. قد يكون بعضكم في أحد هذه الملتقيات التي انتقلت ما بين الدمام أو الخبر على وجه الخصوص والرياض وجدة، وأتت الحقيقة ب3 مستهدفات تحت كل إطار من الأطر ال3 في الاعتماد والتدريب وتحقيق الجودة. فيما يخص تطوير الاعتماد، استهدفت الهيئة ذلك الوقت إنشاء نظام شامل للاعتماد، وما نعني بنظام الاعتماد الشامل هو النظام الذي يقوم على مبادئ الاعتماد المؤسسي أو الانستتيوشنال اكريديتيشن، بالإضافة للاعتماد البرامجي الذي يقوم على البروجرام سبيسيفيك اكريديتيشن ستاندردز، كذلك أن يكون discipline oriented، وأن ندخل في مرحلة الخصخصة التي تواكب احتياجات القطاعات الصحية في المسارات المختلفة من طب بشري وطب أسنان وصيدلة وعلوم طبية تطبيقية وتمريض، وبما يواكب احتياجات تلك البرامج، والتركيز على التطوير المستمر للاعتماد. وسأطلعكم خلال نهاية العرض على بعض التقدم الذي حصل بعد إطلاق هذا المشروع قبل 4 أو 5 سنوات. فيما يخص تطوير التدريب، كان هنالك حاجة ملحة إلى إعادة النظر في حوكمة العملية التدريبية والإشراف على العملية التدريبية، والري جوفرنانس كانت جانب ملح جدا، لأنه كان واضح للجميع أن الهيئة السعودية وصلت إلى مرحلة بعد تقريبا 28 سنة من إطلاقها في تلك الفترة من أدوار مركبة وتتقاطع فيها الأدوار التنظيمية التشريعية مع الأدوار الإشرافية التطبيقية، وجاء الوقت الذي يجب أن يمكن فيه القطاع الصحي والجهات المدربة بالأدوار الإشرافية باستقلالية كاملة تليق بالاستقلالية والنضج الإداري والقيادي للإدارات في الشؤون الأكاديمية. تم إعادة تعريف الأدوار والمسؤوليات بناء على هذه المنظومة التي أعيدت حوكمتها، وكذلك تم كما حصل في الاعتماد والأكريديتيشن أن تكون discipline oriented، وأن لا تكون حل موحد للجميع بل يواكب الاحتياجات الخاصة لكل مسار. فيما يخص عملية التدريب في قضية الدراسات العليا، تم فرز الأدوار التنظيمية عن الأدوار التنفيذية أو الإشرافية، وبناء على ذلك، وهذا يمكن النموذج التقليدي اللي كان سائد ذلك الوقت في بداية إطلاق برامج الهيئة، التسلسل الفيرتيكال أو العمودي الذي تتقاطع فيه الأدوار واللايرز، وكذلك تقوم فيه الأدوار التشريعية والتنظيمية بالتتابع مع الأدوار الإشرافية. عقب ذلك إطلاق ما نحن نعيشه الآن من فرز الأدوار الإشرافية عن الأدوار التنظيمية، وهو ما مكن الآن للجان اللي يمكن مجموعة من الحضور يقودونها، لجان البرامج التدريبية ولجان التدريب المؤسسي، لجان التدريب المشترك لبرامج التدريب المشترك. وهذا ما مكن الحقيقة أن المسؤولية وصلاحيات اتخاذ القرار أصبحت ممكنة للمراكز التدريبية بعد حصولها على الاعتماد. رحلة الجودة بدأت ولن تنتهي، رحلة طويلة ورحلة معقدة وتحتاج تكاتف الجميع، لكن وضع لها خطة نظن أنها خطة إن شاء الله يعني ستقودنا إلى ما نطمح إليه بإذن الله من مخرجات للعملية التدريبية. وضع مؤشرات وخارطة خاصة بمؤشرات الجودة للبرامج التدريبية في المملكة، وتم إقرارها من مجلس الأمناء. تم تسجيل سجل للمخاطر ولمؤشرات الجودة، ويتم مراجعتها بشكل دوري. وأبعد من ذلك النظر في الأثر والإمباكت، سيتم ربط هذه المؤشرات بطريقة مباشرة في قضية data driven أو اتخاذ قرارات مبنية أو يتم تغذيتها مباشرة من القرارات. الهدف الحقيقة كما ذكرت في السابق هو أن تنتقل الهيئة السعودية والجهات التدريبية من الأدوار المتداخلة إلى أن يتم توزيع المهام بما يضمن الفاعلية الأكبر والمسؤولية تجاه جزء من المخرجات كل فيما يخص الدور الذي يقوم فيه. التحدي الأكبر الذي نعيشه في المملكة الحقيقة، وهذا يمكن نقطة الالتقاء بين الجامعات والحضور يمكن اليوم جزء أكبر يمثل القطاع الأكاديمي، هاجس التعامل مع الكم وهاجس التعامل مع الكيف. الهيئة السعودية تحاول أن توازن التعامل. هنالك بلا شك مسؤولية وطنية في استيعاب أبنائنا وبناتنا خريجين الجامعات، وبالذات في التخصصات الصحية ذات التكلفة العالية وذات الاستهداف الاستراتيجي الوطني الذي يرتبط بالأمن الصحي. وحديث الجائحة خير، موقف الجائحة خير دليل على أهمية هذا الموضوع وارتباطه بالأمن والأمن الصحي، وهو لا يقل أهمية عن مفهوم الأمن الشامل. المرحلة التي تلت إطلاق برنامج التميز الوطني أو التميز الوطني في التدريب الصحي، وهي مرحلة امتدت من 2018 إلى 2021، تم فيها إرساء إعادة حوكمة البرامج التدريبية، إطلاق برامج التميز المؤسسي والبرامجي. كانت رحلة كبيرة جدا شارك فيها مئات الاكريديتورز والسيرفيرز من مختلف القطاعات والمراكز، وكان لهم الدور الأكبر الحقيقة في تمكين هذا المشروع أن يصبح واقعا مشهودا بعد أن شاهد مرحلة عميقة وطويلة من التخطيط والتداول الفكري إلى أن أصبح واقع نشهده جميعا. المرحلة التي نشهدها الآن الحقيقة هي الخطة الاستراتيجية التي تم اعتمادها نهاية السنة الماضية وتمتد من 2021 إلى 2025، وتم فيها إرساء بيت الاستراتيجية الذي ترعاه الهيئة السعودية مع شركائها في مختلف القطاعات الصحية، وهي خطة الحقيقة طموحة تقوم على رسالة تعزيز نفس رسالة الهيئة الأصيلة والعميقة في حماية وتعزيز الصحة بقيادة ممارسين صحيين يخدمون المجتمع بإنسانية وكفاءة، تقوم على قيم رائعة من الإبداع والجودة، العدالة المهنية، حماية المرضى. وسيكون هنالك 3 أركان يقوم عليها هذا البيت: النمو المستدام، تمكين الشركاء، الإبداع بلا حدود. هنالك مجموعة من البرامج الاستراتيجية التي تم ضخها خلال هذا البرنامج. هذه الحقيقة يمكن خارطة المشروع الاستراتيجي الذي تتبناه الرئاسة التنفيذية للشؤون الأكاديمية وإداراتها ال3 التنفيذية في التدريب والاعتماد والتقييم، وهي الحقيقة خطة وطنية طموحة تسعى إلى تحقيق أثر أكثر من أنه يكون تخطيط استراتيجي رنان، تقوم على تحقيق مستهدفات تمس المستهدف الرئيسي وهو المتدرب الذي نطمح أن يكون بعد رحلة التدريب ممارس صحي مستقل قادر على القيام بالمسؤوليات السريرية والصحية لرعاية المرضى. أنا عارف يمكن الكراسي اللي على المنصة تحول دون المشاريع، لكن سأقرأ لكم المشاريع وإن كانت يعني يعذرني الزملاء باللغة الإنجليزية. تقوم على مبادئ أعتقد من المهم سردها وذكرها للجميع. أحدها improving الإكزام تيكر experience، تجربة الممتحنين من المتدربين في الاختبارات، ويمكن هذه شاهدت بعض النقلات النوعية التي سأطلعكم على جزء منها. تحسين تجربة وجدارة المتدربين في عمل الأبحاث، التميز في التقويم المستمر التكويني الانفورماتيف اسسمنت. ويمكن شاهد اليوم البرنامج العلمي نقاش رائع عن العملية التقويمية للمتدربين. الانتقال للمرحلة الثالثة من تطوير المناهج بعد أن انتقلت الهيئة من البيزك كوريكولا ديفلوبمنت خلال الانتقال إلى تصميم المناهج المبنية على الجدارات أو الكومبتنسي بيز. بدأنا السنة الماضية إطلاق المرحلة الثالثة من تطوير المناهج المبنية على الأنشطة المهنية المناطة أو ما يسمى بالانترستبل بروفيشنال اكتيفيتيز، وهي ما سيمهد الحقيقة إلى نقلة نوعية في قضية تطبيق المنهج بطريقة تواكب التصور الذي تم طرحه هذا اليوم من ناحية نقل المنهج بتوصيفاته وجداراته ومستهدفاته المتعددة إلى عملية قابلة للقياس، قابلة للتعليم، قابلة للتقويم والتقييم بشكلها النهائي. إقامة تحالفات دولية مع المنظمات المعنية بالأكريديتيشن أو الاعتماد، وهذا مستهدف نقل الحقيقة معايير الاعتماد الوطنية. إطلاق منظومة الاعتماد الافتراضية الفيرتشوال اكريديتيشن، وهذه كذلك مكنت مع الغطاء الجغرافي الضخم الذي تشهده المملكة والمراكز التي تجاوزت المقار التدريبية فيها 600 مقر تدريبي. كذلك إطلاق برنامج وطني لتطوير أخصائيي الدراسات العليا، وهم الجنود الحقيقة المجهولين الذين أعدهم عنصر نجاح رئيسي لبرامج التدريب. سيتم الالتفات لهم خلال هذه الخطة الاستراتيجية ببناء منظومة جدارات خاصة بالبروجرام بوست جرادويت بروجرام ادمنستريتورز لضمان نجاح مدير البرنامج وممثل المتدربين والمتدربين في تحقيق مستهدفات التي أصبحت أكثر تعقيد من الناحية الإدارية الخاصة بالتدريب. إطلاق منظومة خاصة بالأكاديميك أفيرز ديجيتال سيرفيسز، وهذه يمكن أحد المراحل المهمة في أتمتة ورقمنة الخدمات داخل الهيئة السعودية. يمكن المجموعة منكم تذكر النقلة النوعية التي شهدتها الهيئة في موضوع ممارس بلس، وهو ممهد إلى تجربة مختلفة للممارسين في قضية التصنيف والتسجيل. الآن المرحلة الثانية وانتهت فيما يخص البرنامج الرقمي الخاص ببرامج التطوير المهني المستمر، وأطلقت الهيئة بنجاح بفضل الله برنامج مستمر، والآن حنا في طور إعداد وإطلاق النموذج الإلكتروني الرقمي الخاص ببرامج الدراسات العليا، وهما بإذن الله سيمهد لمرحلة مختلفة في تجربة المدربين والمتدربين. آخر مشروع كان هو خاص بإطلاق منظومة الجودة كفريمورك وطني يتم تبنيها مركزيا من الهيئة وكذلك بنائها داخل المراكز التدريبية. هذا البرنامج الحقيقة دون الخوض بالتفاصيل تم بناءه على النموذج المشهور بالكيرباتريك موديل، والذي ينظر بمرحلة متعددة من الانتقال من الرضا للتعلم للتطبيق والأثر والعائد على الاستثمار بالنظر إلى الدور المركزي الذي تقوم فيه الهيئة. هذه الشريحة وإن كانت يعني محشوة بالعناصر، لكن الحقيقة بتجربة ووقوف شخصي تشهد ما شهدته برامج التدريب خلال ال5 سنوات الماضية من تطور بدعم الشركاء في المراكز التدريبية والمستشفيات والجامعات. على سبيل المثال تم إطلاق إطار وطني لتأسيس برامج الدراسات العليا. تجاوزت الهيئة الآن، والحقيقة هذا خبر مهم للجميع، تجاوزت الهيئة الآن أكثر من 166 برنامج دراسات عليا في مختلف فروع الطب وطب الأسنان والعلوم الطبية التطبيقية والصيدلة والتمريض، ولا زال هنالك تحرك وطني للتوسع في برامج الدراسات العليا التي تخدم النظام الصحي لتقديم رعاية أمثل للمواطنين والمقيمين. هنالك جهاز استشاري ضخم تقوم عليه الهيئة من المستشارين في المجالس العلمية، يتجاوز 4000 عضو من مختلف الجدارات وأهل الجدارة والخبرة في التخصصات المختلفة، هم الذين يوجهون التحرك التشريعي والتنظيمي داخل الهيئة السعودية. تطورات تصميم المناهج تحاول مواكبة النقلات النوعية في التعليم الطبي التي يقودها مثل هذا المؤتمر. تطوير مقدرات الوطنية في التدريب على الأبحاث والممارسة المبنية على الإيفيدنس بيزد. كذلك تطوير منظومات تواكب نموذج التحول الوطني مثل تخطيط الأسرة، مثل إدخال نماذج المحاكاة، تطوير الأخصائيين الإداريين في الدراسات العليا، الكواليتي فريمورك، السوبرفيجن. النقلة النوعية اللي شهدها التدريب خلال السنتين الماضية كذلك في التخطيط المالي لدعم أنشطة التدريب. الهيئة أطلقت منظومة مالية تدعم الأنشطة التعليمية داخل المراكز التدريبية. يمكن على اليسار مجموعة من الأعمال اللي أطلقت خلال السنتين الماضية، أحد أهمها يمكن برنامج داعم خلف الكرسي، وهو برنامج وطني يعنى بتقديم الدعم للمتدربين، وتم توسع في هذا البرنامج خلال الجائحة ليشمل المبتعثين خارج المملكة وكذلك الممارسين الصحيين أثناء فترة الجائحة. يقدم مختلف أنواع الدعم النفسي والدعم الأكاديمي للمتدربين. تم إطلاق مبادرة تمكين المتدربين وتمثيل المتدربين. الآن أصبح كل لجنة إشرافية هنالك صوت ممثل للمتدربين يضمن مشاركتهم الفاعلة في العملية التدريبية كأدلت ليرنر وفق نظريات التعليم الطبي. هنالك أدوار إقليمية تقوم فيها الهيئة مع المجلس العربي للاختصاصات الصحية، كذلك المشروع الخاص بالتريننج اوف ترينر او تاهيل وتطوير مهارات المدربين، وهو برنامج نوعي تم اطلاقه بشكل اختياري في المرحله الاولى، والان تم ربط هذا البرنامج لتهيئه وتطوير المدربين ضمن معايير الاعتماد البرامجي، بما يضمن مواكبه قدرات المراكز التدريبيه الخاصه بالمدربين لبرامج الدراسات العليا. هذه فقط أحد الأرقام اللي تعكس الأرقام والبيانات الضخمة التي تشهدها العملية التدريبية. هنالك الآن أكثر من 286 فقط في هذه السنة الماضية في 2021 تقرير صدرت من النظام الإلكتروني للتقارير لتقويم المتدربين في مختلف الوسائل، سواء الانتريننج ايفالويشن ريبورتس او الدايركت اوبزرفيشن بروسيجرال سكيلز او الميني كلينيكال اكسبيرينس او الكلينيكال او الكيس بيس ديسكشن او غيرها من التقايم او التقارير التي تصدر بشكل رقمي، وهو ما يشكل تحدي آخر للتعاطي مع الجودة عن طريق تحليل هذه البيانات وإيصالها للمستفيدين بشكل فعال. تم إطلاق أثناء الجائحة منظومة خاصة بتقديم الدعم المجاني للمدربين ومدراء البرامج، أسميت بعد، منصة لتقديم عن طريق زوم لتقديم المحاضرات بين المتدربين أثناء الجائحة، وكان لها الأثر الحقيقة الكبير في تخطي الجائحة. أحد المستهدفات الرائدة التي أطلقتها الهيئة خلال هذا العام إطلاق برنامج تدريب على القيادة بالتكاتف مع الأكاديمية القيادة الصحية موجه للمتدربين، ونرى الحقيقة أن المستقبل هو على أكتاف. وأسعدنا اليوم الحقيقة التكريم الذي حصل لطلاب الطب في أثناء تأليفهم لكتاب المهارات السريرية. نؤمن إيمان كامل أن المستقبل القادم هو عن طريق إعداد جيل من الممارسين الصحيين الذين تشتمل مناهجهم وتدريبهم على جدارات التعليم الطبي وجدارات المسؤولية والمهنية. ويأتي برنامج ملهم بالحقيقة ضمن هذه البرامج، وهو يشمل مجموعة من المسارات التي تخدم هذا التوجه. برنامج داعم الحقيقة خلال السنة الماضية تم تلقي مجموعة كبيرة من الطلبات ويتم التعامل معها بكل سرية ومهنية، وبفضل الله كان لها الأثر الإيجابي لاحتواء الأثر الكبير للجائحة. الهيئة السعودية كان لها موقف تفاعلي نحسبه رائع مع الشركاء في التعامل مع ظروف الجائحة. كان هنالك خطة اتصال واضحة مع المتدربين والمدربين أسهمت فيها المجالس واللجان العلمية. كان هنالك مرونة غير مخلة بما يضمن التعامل الأمثل مع المتدربين، وكانت الخطط بشكل مستمر تطلق عن طريق قنوات التواصل مع المدربين ومدراء البرامج. هذه أحد الأوراق البحثية التي تم إطلاقها مؤخرا، وكانت تلقي بالنظر على تعامل البرامج الدراسات العليا في الهيئة مع الجائحة، وبعض التوصيات التي كانت الحقيقة الآن هي خطوات يتم اتباعها في بناء برنامج تمكين المتدربين. وكذلك تم صياغة إطار وطني ناشونال فريمورك خاص بداعم، سيكون كذلك جزء من مكونات الاعتماد المؤسسي، وسيتم خلق نماذج مشابهة لداعم داخل كل مركز تدريبي بدعم مباشر من الممثلين النظاميين للشؤون الأكاديمية ومدراء البرامج. هنالك دائما تحدي الحقيقة بين زيادة الضغط الخدمي للقطاع الصحي على المتدربين والطبيعة التدريبية للمتدربين، والهيئة الحقيقة تسعى جاهدة إلى أنها توجد النموذج المتوازن. لا يمكن للعملية التدريبية أن تقف بدون جانب خدمي يسهم فيه المتدربين بمسؤولية ذات محدودية وبإشراف مباشر من ممارسين صحيين ذوي استقلالية. لذلك الحقيقة الهيئة السعودية تحاول أن توجد هذه البيئة عن طريق تهيئة المدربين وإيجاد السياسات واللوائح المنظمة لذلك. سأختم الحقيقة ببعض الأرقام التي تتحدث عن المرحلة التي عشناها خلال الفترة الماضية. يمكن هذه الشريحة الأهم، بيسار الشريحة هنالك قفزة تستطيعون ملاحظتها من 2016 إلى 2021 تم مضاعفة عدد المجالس العلمية من 129 مجلس ولجنة إلى 418. عدد المتدربين كذلك شهد قفزة نوعية من 9200 إلى 19000 متدرب. عدد البرامج شهد قفزة، يمكن آخر إحصائية مع هذه الشريحة كانت 154 مقارنة ب 79 برنامج قبل 5 سنوات. عدد المقار التدريبية الحقيقة قفزت من 267 إلى 594. الانخفاض الذي حصل بعد 791 هو يعزى إلى إعادة هيكلة وحوكمة القطاعات الصحية، التجمعات الصحية التابعة لوزارة الصحة، والدمج الإداري الذي شهدت بعض المراكز. هذه الطاقة الاستيعابية لبرامج الدراسات العليا طبعا دي يغلب عليها التخصصات الطبية، كذلك شهدت الحقيقة قفزة، والحمد لله حققت الهيئة المستهدف المحدد من المقام السامي بتجاوز 4000 مقعد في القطاع الصحي. التدريب في طب الأسنان الحقيقة تحدي وطني ناتج يمكن بالدرجة الأولى لكثافة مخرجات الجامعات. كذلك الهيئة استطاعت على مدى ال4 سنوات مضاعفة الطاقة الاستيعابية. نفس الأمر الحقيقة هي هيئة للجميع ومختلفة مسارات الصحية، وهذا ما يشهد الحقيقة التطور والتوسع في برامج العلوم الطبية التطبيقية والتمريض والصيدلة. أحد مستهدفات برنامج التحول الوطني وبين الحضور مجموعة من استشارية طب الأسرة. أحد مستهدفات الهيئة وهو مستهدف استراتيجي مع برنامج التحول الوطني هو التوسع في برامج دراسات العليا لطب الأسرة، وبفضل الله تم إطلاق مبادرة أكاديميات طب الأسرة. أطلق 8 أكاديميات، وهذه السنة تشهد إطلاق 3 أكاديميات إضافية. عدد المتدربين في طب الأسرة على يسار الشاشة انتقل من 1200 متدرب إلى أكثر من 2400 متدرب على مدى 4 سنوات. الهيئة تراقب هذا الرقم وتسعى إلى مراقبة الجودة، لأن سيكون التحدي الأكبر الحقيقة ضمان جودة المخرجات. الأكاديميات القادمة في المدينة المنورة ومكة والمنطقة الأحساء. هنالك قفزات ضخمة الحقيقة في جانب التقييم، يمكن غلب على العرض اليوم الجوانب المرتبطة بالتدريب بحكم ارتباطي بإدارة التدريب نيابة عن الزملاء في إدارة التقييم وإدارة الاعتماد. هذه أحد البيانات التي تشهد قفزات ضخمة جدا. عدد عمليات التدريب انتقل في 2017 من 67 ألف عملية تقييم إلى أكثر من 130 ألف عملية تقييم في العام الواحد. عدد الاختبارات التي كانت تتواكب مع الاشتراطات والمعايير 25% على مدى السنة الماضية بفضل الله تم استيفاء كافة المعايير مع كافة البرامج. عدد بنوك الأسئلة التي تم ضخها خلال السنة الماضية تجاوزت 152 ألف سؤال عن طريق آلية معيارية في بناء الأسئلة والآيتم رايتنجز. الأمر كذلك في ما يخص عمليات التقييم. عمليات التقييم الحقيقة مع الانتقال النوعي الذي شهد برنامج التميز الوطني شهدت الحقيقة كذلك قفزات نوعية. سأختم خلال دقيقتين إن شاء الله. أحد الجوانب يمكن المهمة داخل الهيئة السعودية هو ما يرسل لعلها رسائل تأكيد على التزام الهيئة بمسؤوليتها تجاه المنظومة الصحية والتعليم في الدراسات العليا. الهيئة تسعى إلى إيجاد منظومة مستدامة، ويمكن أحد جوانب الاستدامة هو مؤشرات رضا العملاء مع الهيئة السعودية. يمكن في 2018 كان مؤشر الرضا 45% لخدمات الهيئة التي تجاوزت أكثر من 163 اتصال لمركز الاتصال. في 2021 على الرغم من تضاعف عدد الاتصال إلى أكثر من 334 ألف متصل، نسبة الرضا بفضل الله قفزت إلى أكثر من 97%. عدد الخدمات اللي حظيت برضا الحقيقة تجاوزت 86 من المتلقين. هذا أحد الآثار الحقيقة الرائعة للتعامل المنهجي مع العمل المؤسسي. الهيئة السعودية كان لديها أكثر من 16 مقر وفرع منتشرة في مناطق المملكة، تم تقليصها إلى 5 فروع. وهذا التقليص هو نتاج الأتمتة التي شهدتها العمليات الخاصة بالتدريب. عدد المراجعين خلال 2016 كان تجاوز 435 حالة مراجعة في مقر واحد، المقر الرئيسي. في السنة الأخيرة لم يتجاوز معدل المراجعين 15 مراجع، وهي قفزة نوعية قاربت يعني 100% بالانخفاض. الحلول النوعية اللي حاولت الهيئة تقديمها شملت البيئة، تحسين البيئة والأجواء. وأنا يعني أدعو من لم يعني يزور فروع الهيئة، واحد الفروع اللي نفخر فيها الحقيقة فرع الهيئة في مدينة أبها، شهدت نقلات وتواكب المعايير الخاصة بالذات التقييم والأنشطة التعليمية. الهيئة تسعى كذلك إلى تطوير الموظفين داخل الهيئة. خلال السنة الماضية فقط تجاوزت عدد الشهادات للموظفين 190 شهادة. نسبة الموظفين المستفيدين من برامج التدريب الداخلي تجاوزت 85%. عدد ساعات التدريب السنوي للموظف الواحد تجاوزت 63 ساعة تدريب في العقد السنوي. برامج مستهدفة نوعية تمس عمليات الهيئة، برنامج انسباير، برنامج واعد، بناء القيادات الخاصة بالمانجرز في العمليات الخاصة في التدريب. العمل المؤسسي داخل الهيئة شهد نقلة بإدخال مفاهيم نوعية لمراقبة الأداء، أحدها استخدام بطاقة الأداء المتوازن أو ما يسمى بالبالانسد سكور كارد. وفيما يخص إدخال التقنية الحقيقة يمكن ممارس بلس وإن كان خارج نظام التدريب. ممارس بلس هو النظام الآن الإلكتروني الذي يتعامل مع خدمات التصنيف والتسجيل. 24% انخفاض في نسبة عدم الرضا أو الشكاوى، 50% انخفاض في عدد استخدام الكول سنتر. كما ذكرت 9 فروع تم إغلاقها كانت خاصة ومعنية بالتصنيف بعد أتمتة العمليات. 86% نسبة الرضا. 95% من الخدمات أصبحت تقدم خلال مستوى اتفاقية مستوى الخدمة وما يسمى بالسيرفيس ليفل أجريمنت. هنالك منصة إلكترونية للتعلم الهيئة تسعى إلى بنائها فيما يخدم العملية. يمكن هذه نقطة مهمة الحقيقة. يمكنكم الآن الحقيقة الدخول من أجهزتكم الذكية على هذا الرابط public.saudicommission.org.sa. هنالك الآن 3 منصات خاصة بالبيانات المتاحة للجميع. الأولى خاصة بنتائج الاختبار النهائية مبنية على التخصصات، والثانية خاصة بنتائج الاختبار مبنية على المراكز التدريبية، والمنصة الثالثة وهي جزء من الانفتاح المجتمعي للبيانات خاصة باللايسنس اكزام أو اختبار الرخصة وربطها بالجامعات. ونؤمن إيمان كامل أن هذه التنافسية والشراكة تجاه الجودة ستكون هي المفتاح بإذن الله لتحقيق النجاح في منظومتنا الصحية. الهيئة شريك ذلك في تخطيط القوى العاملة. تم إطلاق مركز نوعي لتخطيط القوى العاملة بقيادة زميلنا الدكتور زياد نقشبندي، وهو ليس بغريب كان الرئيس السابق للرئاسة التنفيذية للشؤون الأكاديمية. هذه رحلة ممتدة، حاولت قدر المستطاع الحقيقة أني أغطي جوانب مهمة. أتمنى أني وفقت في نقلة ولو بسيطة. وأختم الحقيقة بأن هذا النجاح لم يكن لولا تكاتف وإيمان كافة الشركاء في القطاعات الصحية المختلفة، الجهات الأكاديمية، وزارة الصحة في مقدمة مقدمي الخدمة، القطاعات الصحية المهتمة بالتعليم العالي والدراسات العليا، قادة التعليم الطبي والصحي في الدراسات العليا والشؤون الأكاديمية. يعني لولا هذا التكاتف وهذا الإيمان لما تحقق هذا النجاح. الطموح أكبر من ذلك، نسعى أن تستمر إن شاء الله الرحلة بتكاتف الجميع، وسأكون سعيد الحقيقة بتلقي أسئلتكم واستفساراتكم. يعطيكم العافية.
شكرا دكتور، وما قصرت، ونعتذر ضغطناك شوي والبروف، لكن على أساس الوقت ضيق، فشكرا لك دكتور خالد. اسمح.
طيب، يعطيك العافية دكتور سامي على العرض الرائع، وبصراحة يعني الهيئة يعني مفخر وطني، فالله يعطيكم ألف عافية إن شاء الله. طيب, we will present now our next speaker, Prof. Rehan Ahmed Khan. Prof. Rehan Ahmed Khan, he have PhD in medical education. Professor Rehan is one of the most dynamic medical educators, renewed surgeon with passion for medical education. Prof. Rehan had been involved in the development of medical education in Pakistan with his effort through his portfolio as a president of Society of Medical Education and chief editor of Health Professional Education Journal, and his scholarly contribution, national and international. His interests include curriculum development, assessment, and technology in medical education. Prof. Rihan, he will present today the digital teacher. Prof. Rihan, all the floor is yours.
Thank you very much. I am thankful to Dr. Ahmed Al Amri and Dr. Mona Al Sheikh, the President and Vice President of Saudi Medical Education, and the Saudi International Medical Education Congress, to provide me this opportunity to give a talk on the digital teacher. What I'll be discussing today is the digital teacher and why is it important, the requirements to become a digital teacher. I'll provide some tips for engaging students in online teaching, and I'll also share with you what are the best digital tools to support your teaching practices. So a digital teacher is a teacher who uses technology to enhance the learning experience and empower learners. You must have heard about the academic digitalization, which is now in current fashion, and it is the conversion of text, pictures, or sounds into a digital form that can be processed by a computer. We have passed through many generations. There are many among us who are baby boomers, Generation X, were born in 1961 to 1980, Generation Y, 1981 to 1995, and then the latest generation, which is Generation Z, which is born after 1995. What we have to understand here is that majority of the teachers are either baby boomers, Generation X, or Generation Y, or some of them are even maturists. But the generation which we are going to teach, or we are teaching at the moment, is Generation Z. And these Generation Zs are technocholics. They are the ones who are using Google Glass, 3D printing, they are driving, the driverless cars, they have handheld or communication devices. So what we need to do is that we have to prepare ourselves as a digital teacher. And all of you are aware that main roles of a medical teacher are facilitator, a role model, information provider, resource developer, planner, and assessor. So what we need to do is we need to redefine this role. So we have to define a new role for the medical teacher, taking into context all the similar roles, but giving it a digital touch, which is academic digitization. So when we talk of information provider, the digital teacher, you need to know what has changed. We started with the blackboard, then we moved on to these transparencies, then we had presentations over PowerPoint, and now we are having face-to-face synchronous online sessions. And what has changed, education has gone online. We have virtual reality at practice. We are talking about machine learning, artificial intelligence, data mining. We're using algorithms. There are problem solving done through the artificial intelligence. Then there is talk of Internet of Medical Things and its impact on health care. So the new campus is your cloud, the learning management system which exists on the cloud servers. It can either be a Moodle, a Google Classroom, it can be Edmodo, it can be the Canvas, the Blackboard, or people are using a hybrid system. So part of it is on campus and part of it is on the cloud. So we need to know the new tools. If you want to be a good digital teacher, you need to know the new gadgets. You need to familiarize yourself with the new gadgets. So what are these student interactive platforms? We have learning management systems, as I've shared with you earlier, and to add that, there is Schoology. Assessment is done through Kahoot, Socrative, quizzes, Quizlet. We have online classes, which you're all aware that they're more in vogue after the COVID-19 pandemic. We're using Google Classroom, Zoom, Microsoft Teams. We have discussion forums. The students are learning on Twitter, Reddit, Kialo. There are interactive boards such as Padlet and Now Comment. So all these are not something which a traditional teacher is aware of. So to become a digital teacher, we have to digitalize ourselves as well. So for example, let me share with you that now when we use a Padlet, which is a notice board, and what we do is that here you can see an example that I was teaching my master's students through the Padlet, and when I was comparing a Delphi technique versus nominal group technique, and this was all done through a Padlet in which the students, they wrote on this notice board, and many of the students shared their experiences, and then I actually organized it, and then it could be shared with them through a PDF. Then there are interactive boards. You must be familiar with a whiteboard, which is used in Zoom, and there are whiteboards which are available otherwise as well. You might be using the polls to make your sessions more digital, more interactive. This can be through polleverywhere.com, or there is a polling software built in the Zoom. So as an information provider, which was usually through a blackboard or handing the students the notes or the handouts, the situation has significantly changed now. Now, when we talk about resource developer, we were used to develop the resource material or the study guides, but all of this is now done in the form of a digital content. So to do that content creation, we need to know the PowerPoint in and out. We need to know how to share our content through YouTube. There are other softwares available. You can go through Google Slides, Prezi. The lessons and tutorials could be shared through YouTube, TED-Ed, ThingLink. So the scenario is changing. Now, when we talk about developing courses, we need to do it online. And developing an online course, which you might have taken the part which is done asynchronously, which provides students a chance to do their learning in their flexible time, is done through this set of softwares. So you might need to learn the authoring tools such as Rise, the Articulate Studio. You may have to create, the animation videos through Doodly, Powtoon, Animaker. The podcasts are in vogue and fashion. Majority of the students would like to listen to the learning content on the go. There are vlogs. If you're making a course, you need to know how to do the voiceovers. So you can just imagine that there's so much to learn for people who are either digital immigrants or who are, baby boomers, because we are now addressing the students who are digital natives. And you need to know where to store these information. So you can use Google Drive, you can, use Dropbox, Box, Mega Drive. So in my past few slides, I've, mentioned so much technology with you. So this means that, we have to learn a lot. Just again, showing you that, the podcasts now are available. This is just one of the examples, that 26 best medical podcasts by Justin Knott. And this is a snapshot of Articulate Studio. Excuse me. So another role the teacher had was of planner. So as I initially shared with you, that when we used to plan as a traditional teacher, we would do this as a course organizer or a curriculum planner. But now again, if you want to do a curriculum planning or a curriculum mapping, you're supposed to do it on a digital platform. And when we talk about digital platform, we have platforms like SAP or Moodle, or if a university has its own learning management system, such as Canvas, Blackboard, Schoology. So what we need to know is there are different rights which are given to the teachers there, like manager rights, teacher rights, non-editing teacher rights, what are the student rights. This is all new information which has to be assimilated. And the Moodle is ever changing, and Moodle is a platform where you can run your courses, assess students, make their portfolios. Then one of the important roles, other than course designer, planner, is assessment. So assessment, usually we were doing it through pen and pencil or computers, but now even in post-COVID-19 pandemic or during the pandemic, we have witnessed that these assessments were done online, and the use of online open book assessment was widely in use. And so there are many universities, they are now conducting assessments anywhere, anytime, while maintaining the exam integrity. And how they are doing, either they're using their own assessment systems developed in Moodle, or they're using independent assessment softwares like Socrative, Kahoot, even the skills, soft skills have been assessed through Zoom meetings, through the breakout rooms. And I wrote an article which was Technology Enhanced Enhancement in COVID-19 Pandemic, in which I emphasized that how this total environment of learning and assessment has changed. And we have to understand that even after COVID, we're done with COVID, this scenario is not going to change. We cannot completely revert back to the traditional ways of assessment. So Kahoot is in fashion. Lots of people use gamification through Kahoot and makes the assessment very interactive and enjoyable. So now the question comes up, so what's new for the teacher to learn? I was attending a conference, this AMI conference, I think way back, 8-9 years back. It was in Lyon, France. So one of the speakers at that time, he said that many of you sitting here are physicians, surgeons, and you have a license to treat your patients. But do you have a license to teach your students? I mean, do you have a formal degree in teaching? So majority of us at that time, did not have a master's in health professions, or at least I did not have one. So, at that time I realized that we need to have a license to teach as well. So to enhance teaching, to improve teaching in clinicians, we have courses like Masters in Health Professionals Education, Certificate in Health Professionals Education. But to learn the digitalization in medical education, to learn how to become a teacher, we need a certificate in online and distance education as well, because this is something which is different than a simple teaching principles and guidelines which are employed in teaching traditionally. So what we have done is we have developed this certificate in online and distance education, and you can see from here that when we teach our students, what we do is that we teach them online learning theories and ethics. So they need to know etiquettes. We teach them instructional designing. We tell them what multimedia and educational tools they need to learn. We tell them about learning management systems. We teach them online assessment, gamification, and then we also teach them how to implement this institutionally. So what we're doing is now, on top of the certificate in health professional education and masters in health professional education, we are also creating an awareness that the teachers of this day and age, they need to know these material as well. And engage students in teaching and learning. It is also important to know the principles and guidelines so that you can become an effective digital teacher. All of you must be familiar with Ghani's 9 events, which we use to make our teaching and learning engaging and effective. But many of those principles, though they may fit in online teaching and learning, but we need to have certain other tips as well. So what we did was we did a literature search and published this article in which I'll share with you 12 practical tips to improve student engagement in online learning so that you can be an effective digital teacher. And at the moment, what we're doing is we are using a combination of learning activities. We have synchronous learning activities, which is what I'm doing at the moment, which is real-time, face-to-face. We have asynchronous learning activities in which we store the materials and then they can go through that. So what I'll do is just sharing with you that the first step is, if you want to make sure that you have a good synchronous activity, you need to choose an appropriate online learning interface. So that, as I already shared with you, you have to have a learning management system that can keep a record and streamline the process of synchronous learning. A best LMS is the one which is easy to integrate, is cost effective, and if you cannot, afford LMS, then you can go for Edmodo or Microfleet. Then you should be very well aware about principles of online instructional designing as well. And why is it important? It's because, say for example, you have to prepare something, a lecture, which is online. You need to keep in mind that there is a teaching experience which is based on your planning. There's a social presence which you create through interaction. And then there is a cognitive presence which you enhance through the technological tools that you use. And to engage students, you should be well aware at how to use chat boxes. So for example, even if at the moment as I am delivering my talk, and if the chat box was active, I could easily see what questions are coming up. And this is what we need to do as well. When we're teaching our students, we should keep the chat box active so that there is a real-time chat interaction going with the students. Then use a virtual whiteboards. Zoom has a built-in whiteboard. You can use other softwares as well in which you can draw on this whiteboard. You can even ask students to write on this whiteboard and you can generate an interactive session. It can be effectively used in problem-based sessions or tasks. Then engage the students with interactive paths. And I've already shared with you that this Padlet is different from a whiteboard as it acts as a notice board. So what you do is you give students a task, specifically in flipped classrooms, where you can ask the students to go onto a website, whatever they've learned, they can post there, and you can organize the very next day, you can do discussion on these Padlets, and once a Padlet or a notice board is finalized, that can be saved as a PDF to be shared with the students and for the future reference as well. Then, whenever we are doing an online learning, we, as a good digital teacher, we should know when to break a large class into small collaborative groups. And that is done through breakout rooms. You have this option in Zooms, you have the Zoom, you have this option in MS Teams. And the advantages to the students are, there's a lot of social learning, and there's a lot of cognitive presence, which I shared with you earlier, is one of the hallmarks of good instructional designing. Then grab attention with online polls. And I must say that this is one of the very interactive way of engaging students. So you can use online polls. I've lots of excuse me, online polls which I've already made on polleverywhere.com. So they're handy with me, but whenever I take sessions, I use those polls with my students. And that generates a lot of discussion, a lot of activity. Then using the gadgets. The concept of virtual reality, the augmented reality, and the mixed reality, it is now very much used in teaching and healthcare. So there are bundle of softwares in which there are virtual patients. Even the students can wear these headgears, teachers can wear these headgears, and in online environment, they can come to a virtual world where they can interact with each other and they can learn. And obviously this can be done in an on-campus situation as well. Then it is improvise to energize, use medical improv techniques to develop professional skills. And by this, what I mean is that while you're teaching online, if you're doing workshops, you can use role plays, you can create situations through which, the role plays, they show the learners a way in which they can develop their professional skills. And then, as you know, assessment drives learning, and we obviously need to assess students. And what we can do is we can have interactive quizzes. I use Kahoot a lot, and through Kahoot, the gamification, it creates a lot of interest among students. There's a lot of healthy competition among them. You can even give them the quizzes to be solved later at home. And if you want to do it, if you don't want to do gamification, you can use a built-in software in Moodle, or you can use this separate software as ClassMarker or Socrative. This I've already shared with you, the use of Kahoot. And this is a very important principle, which is, keep the energy levels up by taking breaks. The digital teacher, specifically when we're doing it online sessions and they are long sessions, we need to have breaks. It's because, then they re-energize our levels of interest in learning. Otherwise, it becomes a monotonous task. So this is what you see in here is the learner of the future. And the learner of the future is a digital learner. So if we want to effectively teach our learners, we have to become good digital teachers ourselves as well. I often quote this to my students that it is not important what I teach to you. Rather, the most important thing is what you have learned at the end. So with that, thank you very much, and I'm thankful to all of you.
Thank you, Prof. Rehan. This is a very nice topic and very interesting, and I think really to have this competency for to be a digital teacher is very essential for everybody who's working now in the education field. Now we will introduce our the last not least speaker, Dr. Shrouk Agu. She's an orthodontist, associated professors at King Abdulaziz University at Dental College, health professional educationalist, clinical educator, and an advocate for education reform in health profession education. Dr. Agu held several posts at King Abdulaziz University Faculty of Dentists and the Saudi Commission for Health Specialty, and the Saudi Society for Medical Education, and Saudi Society for Dental Education. Dr. Shrouk, she will talk about e-learning, what is not all about. Dr. Shrouk, the floor is yours. She need to here? Online, okay. We will wait for 2 minutes. Dr. Shrouk, she will arrive now online. Okay. طيب, if you have any question for our speaker, tell Dr. Shuruk she come. Any question? اتفضل دكتور. المايك.
Assalamu alaikum. Again, it's very intriguing presentation. Thank you for the important topics. I would like to ask about the challenges faced the health specialized, our specialized council. With these reforms, what was the major challenge faced? Dr. Haider?
Dr. Haider is موجود? Dr. Sami.
Okay, if Dr. Sami is not here, then Dr. Reham, do you see the role of the metaphors in enhancing or augmenting your skills or tips for the online teacher?
Can you repeat the question again, Doctor?
Do you see the potential of metaphors and on enhancing or augmenting tips mentioned already by Professor Rehan? Thank you.
Okay, Prof. Rehan.
What I've understood is the respected professors asked me that, do you see the role of the tips which I've shared with you in enhancing the role of a digital teacher? Is that what is the question actually?
Now with the metaphors and augmented reality, do you see it enhancing the tips of teacher online? And if yes, how?
You see, specifically when we were talking about the pandemic itself, and also I will share it with the perspective of a surgeon as well. So, you know, if I take it as the role of training for surgeons, the surgical training is now becoming very difficult, and that is because in many countries the hours of the surgical training has been reduced, one. The other thing is that there are fewer patients and more trainees. So when we talk about training these students, be it them in any specialty where this situation prevails, you need to have certain ways in which you can teach them effectively. So here comes the mixed reality, virtual reality, and the augmented reality. We have to understand the differences between them. So virtual reality is what, when we wear the headgears and we go into a virtual world where we have a software in which the trainees, they can learn the cognitive as well as the skills as well. Whereas the augmented reality is very interesting, in which the use of, for example, iPad or iPhone, we can use certain goggles or eyeglasses in which we can see the real world and the virtual reality as well. So you might be familiar about a game as Pokemon Go, which was used as an example of virtual reality. So yes, I mean, virtual reality has a lot of role, and now we're talking about 3D anatomy tables and all sort of these gadgets. And even I'm aware of surgical training programs which are done online, in which the facilitator or the trainer is sitting in another continent, teaching other students which are wearing virtual headgears, going into a virtual operating room and teaching students through that. So I hope if that was the question, yeah, I mean, there's a lot of space, there's a lot of work to be done through which we can, train our students through online teaching and, digitalizing the academic training. Thank you very much.
Dr. Shuruk is ready.
Thank you, Prof. Rehan. Okay, Dr. Shrouk, the floor is yours now.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me well?
Yes, you can start.
Perfect. We'll start. So, Bismillah wa salatu wa salam ala Rasulillah. I'll use the invitation put forward by Dr. Zuhair al-Sibai to try to speak in as much as I can in Arabic in this evening. And after this very insightful and delightful day on speaking about online learning and the principles of assessment and all of the beautiful insights, actually the wise insights that the speakers have shared with us today, what can we add more? What can we put on the table that wasn't really discussed? So a little bit about me before we go. Thank you for the beautiful introduction, Dr. Khalid Shahat. I'm honored that I'm introduced by yourself. As you all know, as Dr. Shahat have mentioned, I'm an orthodontist, an educator at King Abdulaziz University. I teach under and postgraduate orthodontics. I'm also an educationalist focused on curriculum development and a member in several national health professional education committees. I value a holistic human-centered approach to education and patient care, and I have to declare my bias before we start. So my objective today is to discuss with you what makes e-learning a success, but from a different angle. I'll share our experiences with you using current six-step development approach, and we'll discuss together some future directions for researchers and educators in the regions as we conclude. So e-learning, we all know what has happened. On the rise in the last 2 decades, the COVID made an acceleration, helped us to hit the online learning grounds faster. And thanks to the online learning strategies, we were able to salvage a lot of the shortcomings of not having access to face-to-face teaching in our institutions. Was that a success? Absolutely yes. Did failures exist? Absolutely yes. So it's time where we sit back and look at what we have done, what has worked, what didn't work, and how can we move forward from this. So if I take the opportunity to ask the esteemed audience, what do you think makes e-learning a success? The institute, the instructor, or the learner? What do you think are the most critical factors? Typically, what we hear about when we talk about online learning is a focus in technology. But let's imagine together that we have the best platforms out there, the best resources, the best software, the best connection, without the human dimension, without a learner who's ready to utilize these resources. Would that be a success? In fact, research tells us that the learner is the most important dimension in this equation. And the focus of e-learning programs should be on the learner rather than the introduction of new technology. Why so? Because if we identify the learner's need, what can who could benefit from the online learning experience, we can train our instructors accordingly. And we can design our courses to meet these needs. And we can equip our systems with the tools that are specific to that learner's needs. And the institutions can best utilize their limited resources to meet the best interest of that learner. So if we all agree that for all online learning to succeed, the learner has to be ready for it. Let's take a deep dive on the literature and see what characteristics would make this online learner successful. When we look at the literature, we find factors like engagement, motivation, self-regulation, self-reward, the ability to self-goal set and to self-direct the learning, the ability to self-manage. sum it all, a common overarching framework for all of these characteristics is self-leadership. What is self-leadership? Self-leadership is the individual's capacity to improve their own performance through these self-regulatory processes that we have mentioned. And the literature is very strong on that. So if self-leadership is this important, we can totally understand this recent study by Dernali in 2020, just after the pandemic has hit, which highlights that leadership impacts e-learning both directly and indirectly through developing the self-directed learning of the learner. This finding was also replicated in our own study, where we found strong relation between the students' ability to complete tasks on their own, to set goals on their own, to spend dedicated time for learning online on their own. A strong correlation was found by So, if this is the bottom line, we need an empowered leader-learner for e-learning to succeed. What would be missing then is a leadership curriculum that is incorporated in our healthcare curriculum to produce that learner. In fact, Peter Drucker, who is a well-known leadership author, stated back in 2004 that healthcare curriculum must include leadership skills if they are to meet the needs of the 21st century. Why? Because leadership skills help learners develop their lifelong learning skills so that they can survive with the VUCA world, with the changing, ambiguous, uncertain world that we live in. And if we need this empowered leader-learner in our local Saudi context, we must develop a curriculum that local need, that addresses our local problems that Professor Lambert mentioned this morning. We need a curriculum that empowers the leader-learner in his workforce. And I couldn't find a more suitable opportunity to launch this Saudi Leads curriculum more than the SIMEC 2022 conference. So in the next few slides, I will share with you the development process for this curriculum using Kern's 6-step curriculum development approach. As many of you know, Kern's have developed a framework for developing curriculum that starts with problem identification, targeted needs assessment, having goals and objectives set, followed by determining the educational strategies, and a guided implementation followed by evaluation and feedback. So we have discussed that there is a general need for developing leadership skills from an online learning perspective. Let's take a deeper dive into that. The potential impact of COVID-19 on e-learning course enrollment is that by 2030, 75% of the courses will be delivered in a hybrid learning format. It will have an element of online learning. Or at least 25% of the courses will be delivered fully online. And that's a marked increase in the e-learning, particularly in the GCC countries. By 2024, it's expected that the market size will hit $500 million, increasing by an annual compounded growth rate of 10% annually, half of which belongs to the Saudi market. These numbers raise some questions. If an online learner who has leadership capabilities, then what kind of skills does the Saudi learner need? And how could we develop them and sustain them? And how could this leadership development take into account the Saudi unique culture? Recognizing these important questions and the need for developing human skills, our government have launched several programs as part of the Vision 2030 to help us as a nation step into the future on solid grounds. Perhaps one of the most important of these programs is the one launched by His Royal Highness, the Crown Prince Mohammed bin Salman, on the establishment of the Human Capacity Development Program, برنامج تنمية القدرات البشرية. This program focuses on the development of future 21st century such as critical thinking, creativity, collaboration, and communication, flexibility, or the overarching leadership skills that encompasses all of this. More importantly, يضيف البرنامج البعد القيمي والسلوكي لمناهجنا ولقدراتنا البشرية by focusing on values such as commitment, perseverance, flexibility, resilience, positivity. So apparently there is a need. There's a program that calls for initiatives to meet this program. More specifically, in our healthcare sector, Vision 2030 calls for a huge transformation in the whole sector. The new model of care is focused on patient outcomes and value-based healthcare, both requiring the development of future healthcare work. So to summarize, there's a rise in e-learning demands. There are expectations set forward by the Vision 2030, both in the Human Capacity Development Program and the healthcare transformation sectors. Now that we have looked as a general need, let's focus targetedly on our healthcare professions and healthcare education schools. When it comes to the professions, the first question that comes to mind, should we develop a leadership curriculum that is specific to the different professions in healthcare? So dentistry, different from nursing, different from medicine, or should there be core skills common to all? The answers comes from the literature that there are great similarities in healthcare competency frameworks, which suggests that there is a rise in collective co-leadership, which is in harmony with patient care and interprofessional care. So this is our stance. We have common core skills that are aligned with all the healthcare professions. Does that mean that every institute should have these common skills? Absolutely yes. But also, the institute needs to put its own fingerprint as defined by their graduate attributes to distinguish their alumni from other graduates in the market. Stepping down to the learner level, the literature tells us that our students are not blank slate. They don't come empty. They come with information and leadership skills in their hand and in their minds. So the literature strongly suggests that we get to know our incoming students and meet them where they are in terms of leadership development. Just as an example, the generational differences are known to affect leadership. It is expected that millennials will lead 75% of the will hold 75% of the leadership positions by 2025. Just to give you a highlight on how the leadership skills are different or how the generations are different in terms of e-learning, we've asked our faculty, our own faculty and students to rate their readiness to adopt e-learning from a scale of 1 to 8. On an average, the students answered 6, the faculty answered 5. Not a comprehensive research study, but it just gives you a hint on how generations are different in adopting e-learning and in leadership skills. So now that we have a clearer view on our needs, we're ready to set our goals and objectives. Before setting our goals, we must agree on a common definition, a common working definition. So what is leadership? Leadership is the capacity to work together to achieve a constructive purpose. This is Dixon's definition when we chose to depart from this definition in our model. And we also chose on focusing on capabilities as opposed to competencies. Why? Because capabilities imply the ability to grow and lead under any circumstances or any situation. It also indicates ongoing lifelong learning. Our theoretical grounding for the models for the Saudi Leads curriculum builds on distributed leadership, which assumes that everyone, regardless of title, regardless of position, is a leader from where he is. He can step into leadership position if needed, but he can always influence others from wherever he is. We've added elements from transcendence and transformative leadership theories and from value-based leadership as well. And framework, of course, we have aligned our model with the Saudi National Qualification Framework so that institutes are ready to fulfill accreditation requirements just by adopting this model. We have also grounded the model in the Leads in a Caring Environment Leadership Capability Framework, a well-known Canadian framework for leadership development in healthcare. With all of this in mind, our Saudi Leads curriculum will help institutes meet the demands of level 6, which is the bachelor degree, National Qualification Framework graduate descriptors. So our curriculum will help the students commit to professional values and standards, plan and achieve self-development, make decisions, manage tasks, collaborate in teams, participate in advancing society, and becoming a responsible citizen. We will know as we move into the educational strategies. When it comes to educational strategies, about two things: content and methods. So we reviewed the literature deeply for information on content and leadership curriculum. And we have landed, as I've mentioned, on the LEADS framework for leadership development. LEADS is an acronym that starts for L, leading self, E, engaging others, A, achieving results, D, developing coalitions and partnerships, and S, achieving systems transformation. The original model fits well with the thoughts in mind that we had for our curriculum. However, it was customized based on our general and targeted needs assessment and our goals and objectives. Determining our educational strategy was selecting a method. So debating constructivist versus behavioral teacher learning approaches, the leadership literature tells us that leadership is best nurtured in a constructivist, learner-centered learning environment as compared to classic behavioral e-learning models. So strategies like small group teaching, project-based teaching, mentoring, coaching, Socratic discussions are all conducive of a learning environment that is capable of developing leadership skills. So once we started implementing the models, the first step was naturally to review the existing curriculum that we want to embed this soft skill curriculum in. And then customize the curriculum based on the assessment that we conducted, map the content with the NQA, with the National Qualification Framework at the graduate attribute levels, PLOs and CLOs. So for example, our PLOs are grounded in the National Qualification Framework descriptors. Then our CLOs were aligned to the PLOs, of course, and then the topics were aligned to the CLOs. Teaching and assessment were aligned accordingly. I'll just share with you the first line as an example of this. So this screenshot represents year 3 of a 6-year curriculum that we have developed for the Faculty of Dentistry in one of the schools that we've piloted this program in. So the first CLO, developing basic critical thinking skills such as recognizing assumptions, evaluating arguments, and drawing conclusions. The topic is critical and philosophical thinking that is taught through discussion facilitation and Socratic thinking. We've asked students to evaluate a video recording using the red model. So this is how the curriculum is at the topic level for each of the years, for each of the semesters, for each of the modules that we've threaded in. Here's an example of a curriculum, just a metaphor. And you can see how the Saudi Leads curriculum integrates with it nicely and beautifully without disrupting the current curriculum. So far, we have piloted this in 2 dental programs and in the process of integrating it in a nursing program. We have contextualized the learning experience based on the institution to determine the needs of the faculty. This curriculum does not work with absolute training and development of the faculty and staff as leaders to middle the way for the students. The next natural step is to evaluate outcomes, and that takes us to the last step of the Cairns model. Our evaluation plan was put forward as evaluation model, which uses student satisfaction as a base, but then it assesses students' learning and behavior on the hope that the leadership curriculum will impact the organization at the results level. So the graduates of the curriculum will have impact on their organizations wherever they are. And as I mentioned, this is all under piloting. We're currently gathering data on the impacts of this curriculum, and we'll be happy to share it with you in the near future. So to summarize the steps, we have built on the needs of our Saudi citizens as put forward by the Human Capacity Development Program and the needs of the healthcare transformation sector to determine the needs of the institutes, the profession, and the learners. We've determined our goals and objectives mainly by the National Qualification Framework, and we have a strategy with the leads caring environment leadership capability development program. We've chose the constructivist teaching approach to our curriculum. We've ensured complete alignment and congruence between the topics, the CLOs, the teaching and assessment, and complete alignment with the ETC National Qualification Framework. So institutes should be ready to meet this important accreditation demand that they're struggling with currently. And we have put evaluation plans based on Kirkpatrick's model. So here is it. An empowered leader learner is the product of the Saudi Leads curriculum. At least that's what we hope for. We have designed a curriculum that is national, fully integratable with existing healthcare curriculum, or the majority of them at least. It uses a constructivist approach and is customized based on the needs of the institution and technically grounded, and it aligns with the Leeds International Framework, and it fulfills the National Qualification Framework accreditation requirement. So in conclusion, the learner is the most important dimension in e-learning success. The development of the learner's leadership skill is essential for a successful e-learning experience. Not only that, it doesn't only enhance academic attainment, but it also prepares the graduate for lifelong learning. There is a strong need for developing national leadership curricula for the healthcare professions, and our proposed national Saudi Leads curriculum should help guiding the revision of healthcare curricula to align with the National Qualification Framework in a simple and predictable manner. More research is needed to evaluate the outcomes of this model. Meanwhile, I'll leave you with recommendations based on what I heard from the conference speakers today and based on our own work, is that the learner is the center of the game. He's the most important part in the educational process equation. We hope that the Saudi Leads curriculum will help educators engage and motivate learners and develop their leadership capabilities. Instructors need to be trained on constructivism. We need to design our course delivery methods and our course contents intentionally for engagement. We need to choose our systems and platforms in a way that allows for collaboration and interactivity. And institutions need to focus their attention on the human dimension. It's the one thing that technology cannot replace. And with that last word, I would like to thank you and thank the SIMEC 22 committee for their Dr. Minna Sheikh. Special thanks goes to my partner in this project, Dr. Saad Al-Sabahi. I'm thankful to her insights, friendship, support, and guidance, and her many thoughts in putting this presentation forward. And I'm happy to answer your questions.
Thank you, Dr. Shourouk, for this very nice presentation and topic you have been present. And now we will open the floor for the question. If anybody have any question, please you can ask. Yes, Doctor.
The question is from Dr. Shabbir. Assistant Professor Internal Medicine, Shagra University. Okay, and it's a question for Dr. Rihan. How much is it feasible to conduct online essays-based exam, keeping in view digital equity?
All right, thank you for the very interesting question. You see, when we had this COVID-19 pandemic, it was the first time we thought to conduct the online assessment. And one of the major issues with online assessment was to ensure that there is no cheating going on. But we have to keep in mind that even with the best systems available, we can only minimize the cheating process. So by which we meant that we, went for open book assessments, so that we, give questions to the students, which are of higher cognitive order, which actually analyzes or assesses the students' evaluation, analysis, and creativity, rather than just the rote learning. So, but on top of it, what we did was that we initiated certain proctoring as well. So we made sure that the students had 2 cameras on, one which you can see them from the front, the other on their side, so their whole view is available. Then we also made sure that the assessments were timed, and then there is another option of safe browser. When the students attempt these essay questions on the safe browser, if we want them to write from their own creativity and not cut and paste, they cannot go to other websites. So this is how we did it, and I personally think that we found it very useful, because we compared the results of open book assessments with the results of the similar students when they were not taking these tests on online method, and we found that more students were on the lower side, as it was difficult for them to answer questions which were of higher cognitive order. Thank you very much.
Thank you. Any other question? هذا.
Assalamu alaikum. This is Dr. Hassan Zahrani. The question for Dr. Shuruk. First of all, thank you very much for your excellent presentation. We are very excited to learn from your result and get your data published and shared with us. I would like to ask you, in less than 1 minute, what was your tips you are doing now currently with your student, minimizing transactional distance between you and them? Thank you.
Thank you so much for the kind wishes, and thank you for the beautiful question. I had to take a second to think about the 1 minute answer. The beautiful question. What am I doing in real life? Not at the curriculum level. And something that reduces the transactional distance, and I love that term, is really truly having the mindset that I'm learning from my students as much as they're learning from me. Removing this hierarchy is key to developing leadership skills and to model it in the real way. And then, to be honest, I've learned from the best in this aspect. So I'm pretty much sure that Prof. Jamila Farsi is amongst the audience, and she's the one who modeled that for us years ago. So did I exceed the 1 minute, or should I elaborate more?
طيب Okay, the last question.
This is a question from me. Dr. Ayub from Clinical Biochemistry, King Khalid University. For any one of you, or both of you, are you aware of any electronic packages that does A to Z? Nothing online. The question banking, as well as the assessment, the marks collection, the item analysis, everything in one application that can be used offline. All in one. The reason why I'm asking is because if the question banking is online, then your questions have gone somewhere. There is an administrator who can actually access those questions. Right? And if the assessment is online, it is open to hacking. So we want some package, and also there is internet interruptions and things like that. Are you aware of any package that is on the market that can do A to Z offline, but it has to be electronic? Dr. Rehan or
no.
Dr. Ashraf?
I'll leave the question to Dr. Rehan, he's the expert.
That's fine. You see, when we talk about things like online, we need to define it. I mean, if you mean to say online means through the worldwide network, I mean, yeah, obviously there is a chance of hacking. But when we talk about intra-network, which means a network which exists between the university computers, if you want to take exams which are basically to be done online, you have to have some sort of connection. But if you're talking about something which is only available on a computer, which is not connected to any network, then yes, there are softwares which are customized. Say, for example, in Moodle, we have a built-in assessment system in which you can make questions, and these questions are then handled by the teachers, which are given rights to use those specific quiz banks. And Moodle has what I would say options of making lots of questions in MS Word and then importing them at the same time. So it does save you time as well. But the best is, I mean, if you want to, make something which fits your, needs, then you need to develop a software which I would say is on order, which means you need to tell what you want, and then there are lots of IT people which can develop a software for you, which will do the post-item analysis as well, and that can keep the question bank. That is probably not an issue. So yes, but having said that, even online softwares, when we say they're open to hacking, that hacking is, to be honest, not that easy a job. So, just to share with you, you put a password to your MS Word, and you can try the level best to, break it, ask anyone. It is not an easy job. So these systems are, quite safe. They're only hacked usually not through the online hacking system, but someone who is physically there, who gets the password, or who has an access to that computer. So this is my take on that. Thank you very much.
Thank you very much for all of our distinguished speakers. Really, we have a good and excellent time today from different topics. And thank you for all of your attendees and attend till the last minute. And I hope, inshallah, you get all the benefit. And see you tomorrow, inshallah. Thank you very much.
Thank you so much, Doctor.
Allah Hafiz.